You're connected to the Zoom meeting. Yeah, we can hear you, sir. You can
Okay.
see your
Yeah,
video.
I can see your video now. I
Yes,
can't
sir.
see your video, but
No,
you
we
can
are
hear.
not.
Oh, you can hear me, isn't it?
Yeah, we can hear you, sir. We
Okay,
can hear
that's great. Okay,
Yeah.
because you have any where I have to give the
What do you want, sir?
no
Agenda?
no agenda. Have the speaker you'll introduce, or who's going to introduce that?
No, we will be playing the speaker introduction slide.
Okay,
So
sure.
you can introduce them.
Sure. Okay. Yeah. Thank you.
Okay.
Thank you.
Thank you.
Good afternoon, everyone, and welcome to day 2 of ADORE 2020. Hello, Dr. Parmesh. Hello, Dr. Arvind. Hi, Dr. Hiremat and Dr. Sanjay Reddy. So, we're going to be starting the event right on time. So, I thank you all for logging in well in advance. We've spent a lot of time with each other yesterday, going through a lot of topics on different technologies and newer advances that are likely to come and change the way we practice medicine. And today we have a slightly different program lined up. We've got a whole lot of talks on different approaches to management of diabetes, looking at different OADs, targeting different pathophysiological pathways. Also have some talks on inflammation and heart failure, different insulins that we use for control of hyperglycemia. And the session in the evening is going to be followed with talks on translational medicine, stem cells, cluster diagnosis of diabetes, and management of diabetes using genetic approaches. So we're going to have a whole lot of sessions, exciting talks lined up ahead. The first talk for today is going to be by Dr. S. Parmesh. So I now request Dr. Hiremat, who's a nephrologist from Sagar Hospital, Bangalore. Welcome, Dr. Hiremat. So I request you to introduce Dr. Parmesh and start off the session. So I request the organizing team to display the slides. Yeah, thank you.
Okay. Yeah. Thank you, Bhavna. It's a pleasure to be there with ADORE. And uh, it's always nice to introduce Parmesh Shamana, who's Director of Diabetic Care Center in Bangalore. This session, we are going to deal with evidence in practice. What I want to tell is evidence, we always talk about evidence-based practice, but we always have evidence-biased practice. So I think we have two drugs which are more important, vitagliptin and in management, and we have ARNIs, where we have two excellent speakers. One is Dr. Parmesh Sharma, who is the director of Bangalore Diabetic Center, who is going to talk on the topic today, which will help us to know what are the evidences in verified trial. So can I request Parmesh to go ahead with your talk rather than wasting time on introducing?
Thank you, sir, for those kind words. And it's always a pleasure to be on the stage with my mentor, Dr. Arvind.
Yeah, true.
Yeah.
Hi, Arvind.
So let's get started with the presentation. Are you able to see my screen?
We are able to see you, Parmesh. We are not able to see your screen. I think we are able to see you now.
Okay. The screen is there?
Yeah.
Yes.
So
I think you're on a presenter's view. Can you go to full screen? You're on a presenter's view.
sure, sir.
Yeah, correct.
Yes,
We are able to see you now.
So we are all familiar with the verified trial, and just now let's look at the lessons that we can derive from the verified trial. And the main theme of the verified trial was a comparison between first-line metformin versus an early combination of metformin and vildagliptin. And with that, we have today the guidelines which have been shifting from the standard conventional management to an early intensification. We are also going to look at the importance of early treatment intensification. And we will have a brief overview of the verified trial and also look at the beta cell function studied in the verified trial and the effect of OADs, how they differ in the Asian population, and also look at the Indian data from the verified trial. I think this will be the outline of the talk today. And looking at the guidelines, they all started with the 2018 guidelines, which said nothing in favor of an initial combination therapy, saying that there's not much evidence. By 2019, the tone changed to having a shared decision making. After the verified trial results came in, now there is a strong inclination to start an early combination therapy. So we'll now look at the importance of an early treatment intensification in the phase of diabetes management. And we all understand that type 2 diabetes is associated with a progressive decline in the beta cell function, and an early intensification of glycemic control definitely gives us lower morbidity and mortality, and also helps us to preserve the beta cell function. And there is a greater clinical benefit which gives us the results only when we do this intervention early in the course of type 2 diabetes. So when we look at the impact of early and appropriate intervention, the normal way we manage diabetes is to start with a conventional stepwise treatment approach. We start off with diet and exercise and OAD of monotherapy of metformin. And then we uptitrate the dose, we add the second oral agent, and then we add the basal insulin, and then the basal and bolus insulin. What I would like to point out is, if you look at the A1C curves, they never reach or stay at the level of 7% or below. And if you change this approach to a combined intensive therapy right from the beginning, and we see what happens is, with the combination therapy start from the beginning, the A1C not only gets down to less than 7, but remains there for a long period of time. We all know this from the UKPDS trial. The legacy effect is well known to most of us. The UKPDS trial took almost 10 years comparing the conventional arm with the metformin therapy, where the legacy effect remained even after the trial ended. In fact, 10 years after the intervention ended, even though the A1Cs had become close to each other in both the arms, there was still a significant difference in the complications in those who received a conventional arm and the metformin intensive therapy in the beginning. So now, if you look at patients who are on a monotherapy of metformin, and when they fail to achieve an A1C of less than 7, we would classify addition of the second agent as early if you can reintroduce the second agent within the first year. If you take more than a year, it would be intermediate. And if you take more than 2 years, it would be late intensification. And here we see that early treatment intensification shortens the time to reach glycemic control. If you look at the time of intensification to control, with early intensification, it is 20 months. With intermediate, it is 24, and with late, it is 25. Not only do we get early control with early intensification, we also see that the likelihood of attaining such glycemic control was much lower, almost 22% and 28% lower in those who had intermediate or late intensification compared to those who had an early intensification. And this did not depend on whether you started a first-line treatment with metformin or sulfonylurea. And we are all familiar with the decline in beta cell function in type 2 diabetes and how it is correlated with the severity and duration. And what we also need to see is the traditional sequential approach of adding drugs after each failure allows the patient to remain in a hyperglycemic period for a long time. So with that, let us also look at how the therapies that we use in diabetes affect the beta cell function. If you look at the beta cell function with most of the drugs, they affect the beta cell function either by reducing the glucotoxicity or lipotoxicity. Some of the drugs also help in reducing the inflammation or the amyloid in the islet cells. And incretins, of course, directly improve the beta cell function. And if you look at the verified trial in the overview, comparing it to the other trials, what we need to understand is most of the trials have come late in the diabetes stages. They happened when most of the complications have already set in, or when the beta cell function has already been lost, only the UKPDS and the ADOPT trial happened early in diabetes therapy. And comparing that to the VERIFY trial, VERIFY is again one of the trials which started with diagnosis. But what is different from ADOPT and the UKPDS is that the A1C of these patients was between 6.5 to 7.5, much lower than either the UKPDS or ADOPT. And of course, VERIFY was a multinational, multi-ethnic study with 34 countries and almost 254 centers involving 2,000 patients. And from our center, we had about 20 patients participating in this trial. And the main objective of this trial was to look at the long-term clinical benefits of an early treatment intensification with a Vilda and metformin combination and comparing it to the standard of care of metformin monotherapy in drug-naive patients with type 2 diabetes. And it was a randomized, double-blind, two-arm study. And what we need to understand here clearly is what is the definition of failure, treatment failure. The HbA1cs, of course, was done every 3 months once in the study. And when 2 consecutive HbA1cs was more than 7, it was defined as failure. And this study was a long study which happened for a 5-year period. And if you go further into the design of the trial patients were randomized into an initial monotherapy with metformin and placebo, or to an early combination of metformin and vildagliptin in the period 1. They remained in this period 1 as long as their HbA1c remained less than 7. When the HbA1c crossed more than 7 for more than 2 times, that is when they were shifted to period 2, where all the patients received metformin and vildagliptin. That means even those patients who were on metformin to begin with, they were added on vildagliptin. So in the period 2, both these patients were receiving metformin and vildagliptin. And they remained in the period 2 as long as their A1Cs remained less than 7. And like I said earlier, when the second failure happened, where the A1C of 2 consecutive times was more than 7, then they were shifted to period 3. That was the second failure. So this was a very interesting and a complicated trial to do because most of our patients don't accept insulin so soon. And if you look at the baseline characteristics of these patients globally, and our patients, of course, had an early onset of diabetes. The age was about 48 compared to the other groups. Our BMI was much lower. And if you look at the results of the VERIFY trial overall, the patients who were on the initial monotherapy of metformin alone, they had their initial failure, the median failure, by 36 months or 3 years of time. Whereas those patients who were put on an early combination of metformin and vildagliptin had a time of almost 5 years before they failed. That means there was an improvement of 2 years before they failed when they were put on early combination. You might argue and say these patients had an undue advantage of having 2 drugs, whereas the other arm had only metformin. So it's quite obvious that they would have this advantage. But what is more interesting and intriguing is when these patients were all made equal in the second phase, where they were put on both metformin and vildagliptin, and we looked at the failure in the second phase, even here, there was a 26% reduction of failure in those patients who were initially treated with combination. So the clinical implication of this trial was that early combination treatment halved the risk time to initial treatment failure versus monotherapy strategy. And the median time to failure was 3 years in the monotherapy strategy compared to 5 years in the early combination. And when all the patients were receiving the combination therapy, the risk time to second treatment failure was reduced by 26%. And both approaches were, of course, safe and tolerated well. Now let us look at the beta cell function studied in the VERIFY trial. And we had, like we said, 2,000 patients on the trial and 1,000 on each of these arms. And when we looked at the HOMA beta in these patients using the HOMA beta calculator, using the fasting plasma glucose and the fasting insulin, The baseline HOMA beta was quite similar in both these groups. But the results which came in was surprising to show that those patients who are on metformin had a decline in HOMA beta of 2 by the time they had the treatment failure, whereas those who were put on combination therapy with metformin and vildagliptin had an improvement in the HOMA2 beta of the tune of 17, the overall combined improvement being 19. So this change in the HOMA beta shows that it is consistent with the greater reduction of A1C in the combination group, and the conclusion was that an early combination shows not only an improvement in the glycemic control but also an improvement in the beta cell function when you use a combination approach. And we were talking about the effect of OADs in the Asian population. What are the peculiarities? We need to first understand the Asian phenotype to understand that. And if you look at the Asian Indian phenotype, it has been talked very much in most of the conferences, where we look at higher insulin resistance in our population, increased abdominal adiposity with a lower BMI, more reduction in the adiponectin levels, a higher leptin levels, a higher HSCRP, but most importantly, we see an early loss of beta cell function in our patients. So that results in the failure of metformin therapy and the need for early insulin in our patients. And of course, if you look at the effect of incretin-based therapies in Asians versus non-Asians, we see a better glucose lowering effect of the DPP-4 inhibitors in Asian patients compared to the non-Asians. Not only the DPP-4, even the trial meta-analysis by GAN showed that the glucose lowering efficacy of SGLT2 and DPP-4 were greater in Asian populations compared to the whites. But this difference was not seen for GLP-1 receptor agonists. And coming to the Indian subset analysis, we were able to publish the abstract in the recent RSSDI along with Dr. Mala. And the verified trial had about 163 Indian patients across 13 sites. Like I said, we had 20 patients in this into this trial. And the baseline characteristics of both the early combination therapy versus the initial monotherapy, they were all quite similar. And when we look at the results in the Indian subset, the time to initial treatment failure, the hazard ratio was 0.47. That means the early combination treatment reduced the relative risk of time for initial treatment failure by almost 53% compared to the monotherapy. If you look at the median time to initial treatment failure, our patients on initial monotherapy failed by 1.5 years, whereas the combination therapy, it took more than 4.75 years for the time for first failure. But what is the different from our population to the Western population was, the Western population had control on metformin for almost 3 years, while we failed almost earlier by half. So when started on metformin monotherapy, Indian patients tend to fail quite early by 1.5 years compared to the global population period of 3 years. So the time to second treatment failure, again, the hazard ratio was 0.42. So we see that the early combination treatment strategy can reduce the relative risk of time to second treatment failure by 58%. And not only that, if you look at the proportion of patients who achieved A1C levels of less than 7, in all the phases of the trial, starting from the beginning to the end of the trial by 5 years, we see a consistently higher ratio of those patients who had an early combination having a A1C of less than 7. So the key findings from the Indian subgroup study was that an early combination almost halves the risk of time to initial treatment failure versus the monotherapy strategy. And the median time to initial failure in our patients was 1.5 years in the initial monotherapy strategy compared to the 5 years in the early combination. And when all the patients were receiving the combination therapy, the risk for time to second treatment failure was reduced by 58%, and both the treatment approaches were well tolerated. The clinical implications was that the strategy of early combination treatment approach with Vilda and metformin can improve not only the glycemic control, but also the glycemic durability, comparing it with monotherapy. And our patients showed similar results compared to the Western population, and it was tolerated well. So the take-home messages from this trial are that beta cell deficiency is a known feature of Asian diabetes. Of course, the incretin-based therapies are known to improve the HOMA beta, and the DPP4 inhibitors have a protective effect on the beta cell function. And the addition of Vilda to metformin not only improves the glycemic control, but also improves the beta cell function. And the verified trial showed the beta cell function getting much better with the combination. And the verified trial showed the early combination is much better in terms of glycemic durability. And when started on metformin monotherapy, our patients unfortunately fail almost by half the time the Western population failed. So with that, I think the message is to start on an early combination in our patients, even if their HbA1c is lower. I want to stress that we took patients of 6.5 to 7.5 in this trial and put them on an early combination, even though they could have done well with just metformin. Thank you.
Thank you, Dr. Parmesh. It was an excellent capsule. What you have given, a practical capsule, where you mean to say that combination therapy is going to reduce the HbA1c, whether you take them at early stage or the late stage. And the fasting control is very good. And it improves the beta cell function. And these are holding good for all the Indian patients also when you compare to the Western side. And I think we'll take the questions later, Dr. Arvind, and I'll call upon Dr. Kiran Varghese to talk upon another important evidence in the practice, that is role of ARNI in heart failure and diabetes. Dr. Varghese is the professor and head of the Department of Cardiology in St. John's Medical College, Bangalore. Dr. Varghese, please, it's your stage now.
Thank you so much, Dr. Sanjeev, and I'd like to thank Dr. Arvind and all the organizers of the conference for giving me this opportunity. I'll just go straight into my slide presentation. I believe I am allowed to do the slide sharing.
Yeah.
Okay, so then I'll just... is it visible?
Yeah, Kiran, it's visible very well, no problem.
Thank you. So I'll be talking on the role of ARNI in heart failure and diabetes, that is angiotensin receptor and neprilysin inhibitor. Okay, a minute. Yes. Yeah, so diabetes is an independent risk factor for heart failure, and we know that it increases the risk of heart failure considerably, especially in women, 5 times in women and twice in men. And also it's highly prevalent in patients with diabetes, 25% in chronic heart failure, 40% of acute heart failure patients have diabetes. And the prevalence is 4 times higher than the general population, suggesting that diabetes has a pathogenetic role in heart failure. So I'll be touching on how diabetes and heart failure are interlinked, and briefly on the management of heart failure in patients with diabetes, and then the role of ARNI or sacubitril/valsartan combination in patients with heart failure with reduced ejection fraction and diabetes mellitus. So diabetes is on the rise, as we all know, globally as well in India, and the prevalence is very high. The prevalence is almost as 60% of Indians have diabetes or pre-diabetes by the age of 60. That's a really alarming figure. 60% of the population above the age of 60 have either diabetes or pre-diabetes. Now, heart failure and diabetes is emerging. It's more common, and it's a call for action. It's only over the last 15 years it became evident that the heart failure incidence and prevalence is high, not only in patients with diabetes, but also pre-diabetes. And it's one of the most frequent reasons for a clinical presentation in cardiovascular disease. The presentation with heart failure is more frequent than with stable angina or non-fatal myocardial infarction. Now, coming to diabetes and heart failure, Diabetes is not just a bystander, um, but an unwanted path leading to heart failure through a variety of mechanisms. One, in various ways, it increases the risk for coronary artery disease and myocardial infarction and an ischemic cardiomyopathy leading to heart failure, or hyperglycemia, insulin resistance, hyperinsulinemia by a variety of mechanisms causing cardiomyocyte hypertrophy or apoptosis and a variety of other abnormalities. Essentially, it all leads to heart failure in diabetic patients. And there are many risk factors like age, sex. Hypertension is a very major risk factor, as well as obesity and obviously renal disease also. Coming to the prevalence of heart failure and diabetes, if you look at the various trials which have looked at heart failure with reduced ejection fraction, that is basically chronic heart failure patients, the prevalence of diabetes is around 30%. Whereas if you look at the other way, in diabetic patients, the prevalence of heart failure is approximately between 10 and 30%. This coexistence has a strong impact on clinical management and prognosis. In heart failure with reduced ejection fraction, it's an independent predictor of fatal and non-fatal clinical outcomes. And in diabetes, when there's heart failure, there's a worse clinical status and increased all-cause and cardiovascular mortality. Heart failure and concomitant diabetes are strong predictors for adverse outcomes, and this has been shown in multiple trials. The all-cause mortality is much higher when there is heart failure superimposed on top of diabetes. There's an increased all-cause and cardiovascular mortality. The incremental risk for being hospitalized for heart failure by concomitant diabetes, as shown in the dedicated heart failure trials, can be as high as twofold, or almost 100% higher. Now, heart failure and concomitant diabetes is also a strong predictor for adverse outcomes. So there's an excess rate for heart failure hospitalizations by concomitant heart failure in patients with diabetes, and this excess risk is 2 to 4-fold higher. What about the impact of diabetes on clinical outcomes of heart failure at 1 year? Type 2 diabetes mellitus patients have 7% increase in the risk of cardiovascular death and 27% increase in the risk of heart failure hospitalization. The long-term mortality is 50% among heart failure patients with diabetes. Despite this, heart failure is often forgotten or overlooked complication. People don't realize that it's such an important consequence or complication of diabetes. And unmasking this heart failure, unmasking or early diagnosis, the more appropriate word, in patients with diabetes is imperative. About 50% of individuals with left ventricular systolic dysfunction, which is the antecedent to heart failure, at least in those with reduced ejection fraction, most of them remain undiagnosed and untreated. And so clinicians should not overlook the fact that diabetes patients with stable coronary artery disease may present with atypical symptoms such as shortness of breath rather than coming with chest pain when they have an ischemic problem. Very often they just complain of fatigue also. So early diagnosis and immediate treatment can help to delay or prevent the progression of this debilitating disease. Now we come to the management of heart failure in patients with diabetes mellitus. It's a busy slide. I think I'll just skip this. So heart failure therapy in patients with diabetes and heart failure. No clinical trials have been conducted exclusively in patients with type 2 diabetes mellitus, but they have formed such a large subgroup in virtually all the trials that I think the data is quite robust. Several heart failure drugs may exert metabolic effects that should be taken into account in type 2 diabetes patients. The guideline recommendation for heart failure in patients with diabetes, if you look at the ESC 2016 guidelines or even the more recent ones, There are no specific constraints to heart failure treatment in type 2 diabetes patients for the management of heart failure. In clinical trials, all the pharmacological and device therapies for heart failure were similarly effective whether or not patients had type 2 diabetes. So no real undue concern about, this treatment or that treatment may be undesirable in diabetic patients. However, there are some concerns when you are treating when you're giving heart failure medications in patients with diabetes, or variety of cardiac medications. For example, ACE inhibitors. The guidelines clearly recommend them in patients with heart failure with reduced ejection fraction. ARBs are also strongly indicated whenever an ACE inhibitor is not tolerated. Otherwise, an ACE inhibitor always is the first choice when dealing with heart failure. When you come to beta blockers, they have also been time and again, repeated studies have shown that they are very beneficial in patients with heart failure and reduced ejection fraction, but they may marginally influence the lipid profile and mask the symptoms of hypoglycemia. The mineralocorticoid receptor antagonists are also extremely useful, but caution has to be exercised in patients with impaired renal function and in those with serum potassium levels of about 5 millimoles per liter. These drugs are not contraindicated at any level of renal function, but the worse the renal function, the greater is the caution that has to be exercised. Diuretics, they increase the insulin resistance and subsequent worsening of glycemic control, but they can be life-saving, especially in acute heart failure. So the need of the hour is several anti-diabetic drugs have been implicated in worsening of heart failure symptoms or prognosis, especially the thiazolidinediones, which like the pioglitazone can worsen heart failure due to fluid retention. And some of the DPP-4 inhibitors like saxagliptin have also been incriminated in this. Several heart failure therapies such as beta blockers and diuretics may aggravate dysglycemia, but by and large, these issues are not very major issues. Despite that, a heart failure therapy that is protective against incident diabetes or worsening glycemic control would be a very welcome addition in patients who have both diabetes and heart failure. Neprilysin inhibition is a novel therapeutic strategy, and neprilysin has become a pharmacological biotarget in heart failure as its inhibition leads to the gradual increase of natriuretic peptides and other substrates in plasma concentration. The effect of sacubitril, valsartan, and neuroendocrine balance. Basically, on the one hand, you give sacubitril, and the other hand, you give valsartan beta blockers, and both these together with their complementary effects have a very good physiological effect in heart failure. Sacubitril valsartan shows superior outcome over enalapril in clinical endpoints. And whether it's the primary composite endpoints, you can see there's a 20% reduction, or cardiovascular death, there's again a 20% reduction with sacubitril valsartan combination when compared to enalapril. The yellow bars represent sacubitril valsartan. Heart failure first hospitalization also reduced by 21%. All-cause mortality also reduced by an impressive 16%. And all these were highly statistically significant with a p-value of less than 0.001. So let's come to the role of this combination of sacubitril valsartan in heart failure with reduced ejection fraction and diabetes. The beneficial effects are multifold. There's sacubitril valsartan improves insulin sensitivity, lipid mobilization, and oxidation by augmenting natriuretic peptides. In the Paradigm Heart Failure study, which was an absolute landmark study, which came out about 5 years ago, there were two important sub-analyses which were done. Sub-analysis 1 compared the effect of sacubitril valsartan with enalapril in patients in the paradigm heart failure trial according to the glycemic status. So they looked at the glycemic status to compare the two groups. And in the second sub-analysis, they investigated the effect of this combination versus enalapril on the HbA1c and the time to first initiation of insulin or oral anti-hyperglycemic drugs in patients with diabetes and heart failure with reduced ejection fraction. And this slide with its forest plot shows that sacubitril/valsartan positively impacts cardiovascular outcomes in heart failure with reduced ejection fraction, irrespective of glycemic status. In the sense, you'll find that all the dots are to the left of the line of unity, even though all of them are not statistically significant. It is significant in normoglycemia and pre-diabetes. However, when you look at the p-value for interaction, you find that this is probably a class effect, and it's applicable to all the subgroups. So sacubitril/valsartan provides a 20% reduction in the risk of cardiovascular death. So when you look at this slide shows the reduction in hospitalization for heart failure. This again is seen irrespective of glycemic status. Again, all the dots are to the left, even though not all of them seem statistically significant, because in subgroups, some of the groups are smaller. For example, undiagnosed diabetes, the group is half as much, so you have wide confidence intervals. Nevertheless, it's heartening to know that they are all to the left side, and the p-value for interaction is not significant, suggesting that this, it's probably, you can say that this effect is applicable in all the subgroups. So sacubitril/valsartan provides a 20% reduction in the risk of hospitalization. What about the quality of life in heart failure with reduced ejection fraction? Again, this is irrespective of the glycemic status. So quality of life also are improved whether you have diabetes or undiagnosed diabetes, pre-diabetes or normoglycemia. Overall, you find that even that is reduced by 17% within 8 months, 17% improvement in quality of life. What about the glycemic control, which is what most of us are very concerned about? And you find that these two graphs, the sacubitril/valsartan is the lower graph in yellow and the enalapril graph is on top. And you find that there's a decrease in HbA1c was persistently and significantly greater in patients receiving sacubitril/valsartan versus enalapril over 3 years. So what we find is that there is a drug which is not only extremely effective in reducing all-cause mortality, heart failure hospitalization, but also improves the glycemic status. So that's very, very heartening. Let's look at the magnitude of treatment effect based on HbA1c levels at 1 year. In patients who had HbA1c at more than 8 at screening, 8%. 8% of more patients had moved to a lower HbA1c category. What about those in HbA1c above or below that level? 11% more patients moved to a lower HbA1c category, and 14% lesser patients less likely to have moved to a higher HbA1c category. So many of the patients actually improved in their HbA1c, and clearly it even if it remained the same, that would have been good, but here we find there's an improvement. What about the impact on initiation of insulin therapy? And this Kaplan-Meier curve shows the time to insulin initiation in this sacubitril/valsartan group. There was a 29% reduction in the new use of insulin in patients on sacubitril/valsartan. What about the safety results? You find that this combination provides better tolerability as compared to enalapril with regard to renal safety. That's the renal dysfunction serum creatinine of more than 2 or 2.5 or more. You find that it's comparable in the group with normal, that means no diabetes, pre-diabetes. And when you come to new onset diabetes or newly diagnosed diabetes and diabetes, you find that it's actually much lower than the enalapril group. What about the rate of decline in the eGFR among these patients with heart failure with reduced ejection fraction and diabetes. And you find that there is also a very heartening improvement here, which has important implications for the care of type 2 diabetes, independent of efforts to lower blood glucose in these patients. So the change in the EFR also is much less in these patients. So in summary, the hyperglycemia, insulin resistance, hyperinsulinemia, and diabetes mellitus, they trigger a cascade of deleterious effects that contribute to the development of heart failure. So we've seen this time and again that a lot of patients with diabetes present with heart failure due to a variety of mechanisms. Heart failure and concomitant diabetes increases the risk of morbidity and mortality quite a bit, and yet it is overlooked while treating patients with diabetes. There are no specific constraints to heart failure treatment in type 2 diabetes mellitus for the management of heart failure, but a heart failure therapy that is protective against incident diabetes or worsening glycemic control is a welcome addition, and that is exactly what we have with the sacubitril and valsartan combination, also called ARNI, because they improve clinical outcome, and at the same time, they improve the glycemic control in patients with heart failure with reduced ejection fraction and diabetes. Thank you very much.
Yeah, thank you, Dr. Varghese. It was a nice talk on ARNI. And you have given a practical approach that ARNI is reducing the heart failure by 20%, which is phenomenally good, and 20% reduction in cardiovascular death, readmission by 20%, and decreased mortality by 16%, which is phenomenal by an ARNI. And the quality of life of a patient also improves with ARNI, and it can be very well used in patients with CKD, which is one of the important points. Always we have a difficulty when you're using ACE and ARBs. And with use of ARNI, the HbA1c, which was more than 8, they come into a lower HbA1c, which is again a practically very important thing. I think both the speakers have given excellent review in evidence in practice. Now I'll open up this for a discussion, and we have one question where in the chat box where they want to know whether we can use ARNI in patients with dialysis, on dialysis. Can ARNI be used on dialysis patients?
So as I said, there is no absolute contraindication, but always before we introduce an ARNI is a combination of an ARB, that is valsartan, and sacubitril. So if the patient who is on dialysis has a low potassium level, then you can use an ACE or an ARB or a mineralocorticoid receptor antagonist. So in such cases only, and for practical purposes, that is not possible in the vast majority. But you have occasional patients with potassium losing type of nephropathies. It can be tried in such patients, though the data is limited.
Okay. I can just put an extra word in this. I'm a nephrologist, so I use still ARNI in patients on dialysis. We are happy with using it because it has good cardiovascular benefits more. And we do take care of the potassium by using a small diuretic at that stage, or in patients on dialysis, we use a potassium-free bath for dialysis. So we still use it. And
That's great.
Yeah. Dr. Parmesh, there is one question for you. Can we replicate verify results with low dose sulfonylureas and metformin? This is a question by Dr. S.R. Arvind to you, Dr. Parmesh.
Yeah, sir has asked a tricky question.
Always. Intelligent questions.
Yeah, so looking at the population we included in the verified trial, it was with the A1C of 6.5 to 7.5. Even though sir specified as low dose sulfonylurea, we might anticipate a little more incidence of hypoglycemia in this subset of patients. Second would be, we don't know whether the beta cell improvement we found with vildagliptin could also be replicated with sulfonylurea as a combination. With all that caution in mind, I still believe Dr. Arvind is right that when we use a combination, it would be much better than using a single dose of, metformin alone.
Okay, I think that answers Dr. Arvind's question. Dr. Varghese, you have one more question. They want to know whether can ARNI be used with SGLT2 inhibitors, because both of them are known to cause dehydration. So what's your take on that, and what's your personal experience on SGLT2 inhibitors and ARNI?
Yeah, so the short answer is yes, they can be used. And in fact, the more recent trials have included patients with who many of them have been on either an ACE inhibitor ARB or even on an ARNI. So, and the SGLT2 inhibitors have shown benefit over and above the benefits seen with ACE inhibitors or with the ARNI group of drugs. So yes, clearly they can be used.
Are there any questions? I don't have anything in my chat box. Anything, Bhavna, you have any chat in your chat box? If you have anyone for the questions.
Yes, I have a question to Dr. Parmesh. Dr. Parmesh, given that SGLT2 inhibitors are also available generic now, um, and also vildagliptin, would you still combine vildagliptin with metformin if you had to use a drug first line? Or looking at all the vast benefits of SGLT2 inhibitors, would you rather combine an SGLT2 inhibitor with a DPP4 inhibitor for your patients? Is metformin really, does it always have to be the first line therapy?
I think we have to look at Verify as the one which has shown the path to an early combination. And the suggestion that you have, I think, is definitely more valid, and a trial in this regard would definitely throw out good results, not only with regards to glycemic durability, with regards to cardiac outcomes. I think we would definitely see much better results with a combination of metformin with SGLT2 than with a combination of Vilda with metformin.
Yes, I think I agree. It would be definitely interesting to look at if someone can plan the trial. So that would be interesting. I think Dr. Arvind had something to say because he was signaling at me, so I will mute now.
No, I think it's just a question to Parmesh and then another question to Kiran. Kiran, apart from valsartan, if any other ACE/ARB were to have been used with sacubitril, do you think the effect on heart failure would have been the same? Of course, in this case, the Novartis who did the trial, they make valsartan, it is their drug, so they used it. But if it can be repeated with any other ACE/ARB, how do you see this results going?
Obviously, we don't have data to answer that. One can only hypothesize, but
Yeah.
I would say that we would get the same results irrespective of which ARB one would use. It's just that in the trial, that particular one was used. So I don't think it would make very much of a difference. Just like, after the HOPE trial, there was such a huge increase in the use of ramipril, and somebody asked Salim Yusuf, how did you choose ramipril? Why did he choose that? And his answer was because they were sponsoring the trial. It was very simple.
That's more practical answer.
Yes.
Parmesh, one interesting finding from the Verify trial, especially the Indian subgroup of patients, the time to fail with metformin is just about 1.5 years. And for quite a long time, people have been saying that it's not just insulin resistance, but Indian patients are also insulinopenic. Now, does this result clearly tell us that we probably need to do something to improve their insulin levels right at the beginning?
Yes, sir. I think it's a confirmation of the previous thoughts that our patients are more insulinopenic, and it's not the insulin resistance which is the main factor. Insulinopenia is a major role in our cases.
Yeah, I have one question to Dr. Parmesh. In the third arm, what they have used initially, they have the first and second arm they have used. In the third arm, they have used insulin. What was their reaction for patients in Indian subgroup of patients? Because here, because we always talk about insulin resistance in our guys. So, what was their response in phase 3?
Yeah, I think I said in the beginning this was a difficult trial to execute because After failing with either metformin, then you add the second vildagliptin.
Yeah.
Our patients are used to getting another 2 oral tablets before they go to insulin. And here with just 2 tablets, we had to start them on insulin. And all those patients who refused insulin had to go out of the trial. They had to drop out.
Oh.
And only those who were willing to continue on insulin, to be added on insulin, were continued. But we didn't lose many patients. Actually, we had 20 patients. I think we lost about 3 patients in the process.
I think I can add something here to Sanjeev. Sanjeev, the DREAM trial, we had to start glargine. In that case, it was Lantus, even in IGT patients. So
Yes, yes.
that was also a challenge those days.
Yeah, because Indians are very, very difficult to take a prick. They are not ready for that. So whenever you tell about insulin, they just switch over the doctor. That is the easiest for them to do it, I think. So that's the reason I asked that. Yeah. I think I thank the organizers for asking me to chair this session, and over back to Bhavna for the further sessions, please. Thank
We
you.
have another 5 minutes.
Thank you, Dr. Sanjeev. Thank you, Dr. Kiran, and thank you, Dr. Arvind, Dr. Parmesh, Dr. Sanjay Reddy. I think, did you want to say a few words? Because I saw you raising your
No, I'm nothing. Go ahead.
All right, fine. So I thank you all once again for joining this session, looking at clinical trials and evidence and how to apply that into our clinical practice.
Thank you very much.
Yes. Thank you once again. So I now request our organizing team to play a small video for all of you to thank all the sponsors of ADORE 2020. All right, so thank you all for your patience. So I thank all the sponsors of ADORE 2020 for your support and for helping us bring this event together which is being streamed live free of cost for thousands across India. So thank you all once again. So we'll now move on to the next part of our scientific session. So we're going to have 2 clinical capsules for you today. We're going to have a talk on common fungal infections in individuals with diabetes and how you look at it and how you treat it and manage it. Then we're going to have another talk, which is going to be looking at targeting inflammation as a pathophysiological pathway in type 2 diabetes. I would now like to introduce to you, of course, Dr. Sanjay Reddy has been with us, part of the organizing team, and he's been with us throughout from yesterday, and you all know him. So over to you, Dr. Sanjay, to chair the next session.
Good afternoon, everybody. Welcome back to ADORE 2020. If you're joining in late on a Sunday afternoon, we had one session. Last session was interesting, one on the verified trial, and next was the use of RNA in heart failure. Very interesting talks by Paramesh and Dr. Kiran Varghese. Now we move on to the next clinical capsule. This is one of the most common things we see in practice, especially if you're saying uncontrolled diabetes or even regular patients. On fungal infections, manifestations of common fungal infections in patients with diabetes. Now, to speak upon this topic, we have Dr. Divya Sharma. Divya Sharma is a dermatologist. Welcome to the diabetology fold, and hope you enjoy speaking to us. It's not the dermatology group, which always has a lot of pictures. Hope we can see some of them. I have a lot of dermatology friends, so they keep on pestering me with these pictures day in, day out. Not to complain of, I love learning from them. And Divya is a chief consultant and director at Divya's Skin and Hair Solutions. Over to Dr. Divya for a presentation on common fungal manifestations in diabetes patients.
Thank you, Dr. Sanjay, for such a nice introduction, and I'm thankful to the ADORE organizers for inviting me over. And today I'll be talking about something that's very common and has become a very difficult condition for us to treat. So, starting with my presentation. Can you see my screen?
Screen is visible, yes.
So today we'll be talking about cutaneous fungal infections. We all know about diabetes. We have been hearing and talking about it. Fungal infections, we all know diabetic patients are very prone to fungal infections because of hyperglycemia, which may aid in the growth of fungi. Most of them can be treated and cured if diagnosed early. Infectious involvement of the skin is seen more common in type 2 diabetes compared to type 1 diabetes. Along with the systemic fungal infections, which are increased, there is also an increased incidence, though the reports vary from very commonly found in diabetes to not so commonly found in diabetes. But for all practical purposes, we do see a lot of patients coming to our OPDs with cutaneous fungal infections and comorbidity like diabetes. Now, possibly there is a compromise in the leukocyte function, or there is a blunted immune response, that even patients with well-controlled diabetes may be seen susceptible to fungal infections. Now, what is the cutaneous fungal infection? Doesn't need me to describe it further, that it's an infection which appears on the skin as the fungi which infect the skin thrive on keratin. Depending upon the area involved, we give it different names. We classify them into superficial cutaneous, subcutaneous, and systemic. My topic would be more around the superficial cutaneous infections, which are more commonly found in our clinical practice. If you talk of epidemiology, yes, I think Candida tops the list, followed by dermatophytosis, and then some infections like tinea versicolor, which we do see a little more in diabetics compared to non-diabetics. These are few figures talking about the increased incidence of fungal infection. Women top the list when it comes to the jock itch area nowadays. There was a time when we would hardly see a female with fungal infection in the private areas. This has become much more common. We'll be talking about the various factors. Possibly it is due to use of more tight clothing as we go towards, as the fashion sense changes, so does the incidence of cutaneous fungal infection. These are briefly about the drugs. We chiefly divide antifungal drugs into azole group. Azole group is the most commonly used group in the topicals. Clotrimazole, ketoconazole tops the list. Fluconazole, itraconazole are the oral triazoles. Allylamine is, so azole group is fungistatic. It is not fungicidal. Terbinafine boasts of fungicidal activity. Griseofulvin, the old drug, it's like an old wine in a new bottle, is recently assumed importance. It binds to tubulin and inhibits the mitosis of fungi. Dermatophytosis, or the fungal infections of the skin, are common worldwide. The dermatophytes are generally divided into 3 groups. We see trichophyton, microsporum, and epidermophyton species. Traditionally, we always saw more trichophyton rubrum as the most commonly isolated fungus in Indian subcontinent. We call it Tinea pedis when it is infecting the foot. We call it Tinea manum when it infects the hands. Cruris or jock itch. Tinea capitis, which is infection of scalp hair. To note that Tinea capitis is not a very common presentation in adults, as we all attain puberty and there is an increase in rise of oil on the scalp. The incidence of fungal infection on the scalp decreases considerably. So you would never see an adult with Tinea capitis until there is any other immunosuppression present in the patient. Tinea unguum or onychomycosis, very commonly seen in diabetics, and of course Tinea corporis, which is seen on areas other than hand, feet, and face. So the recent studies are showing an increased prevalence of dermatophytosis from 40 to 70% incidence. Clinically, traditionally, we always thought a patient would present with a ringworm. There will be a ring, there will be central clearing, there will be an active border. But here comes the menace of steroid-modified fungal infections. Because of incessant use of easily accessible topical steroids and fixed drug combination, so most of them are available over the counter. These formulations account for 50% of sales of topical steroids, though there has been a ban initiated by the DCGI, but we do not see it in action. How steroids cause the double trouble? They suppress the local immune response, allowing the centrifugal march of the fungus. The fungus gets to spread centrifugally and gets deeper and more troublesome to treat. We are also seeing, earlier we would talk about fungal infection of the hair, Tinea capitis in children, but we do see a rise in numbers of fungal infections on the face because of indiscriminate use of topical steroids by clinicians, pediatricians to treat sometimes innocuous conditions like pityriasis alba. One has to avoid the indiscriminate use of topical steroid. Here comes the newer clinical pictures of fungal infection. So you will see large map-like areas, as you can see, sometimes covering even 50% of the body surface area. This is the steroid-modified tinea. You can see not only the classical ringworm infestation, we can see dumbbell shapes of fungal infection. They can also present as pustules, or it may seemingly look like a folliculitis. It may also present with annular lesions easily confused with other conditions like necrobiasis lipoidica, but it comes out. So you need to have a very high index of suspicion in clinical presentation of cutaneous conditions in diabetic patients. We have to rule out the history of usage of topical steroid in any form. You can see this is a new menace for all dermatologists, the double-edged tinea. This is a classical picture we see because of usage of a combination of antifungal and a steroid ointment. This is a newer type of Tinea capitis. So I have often seen clinicians looking like, prescribing medications for Tinea capitis. So as I said, it was never the case. But this is known as glabrous tinea, where you would see large map-like fungal infections in the area surrounding the scalp. Rule out history of usage of steroid. Avoid giving a combination of antifungal or steroid in a diabetic patient. This is the gift of possibly our country to the world. Now we see a rapid emergence of Trichophyton mentagrophytes as the chief predominant species causing fungal infection, also known as India ITS genotype. Possibly this has happened because of usage of topical steroids. You can see in this condition where 74% positive culture was found for metacrophytes compared to 7% of trichophyton rubrum. You can also make out the varied presentations of fungal infections. Trichophyton species does not respond to the increased doses of antifungals as well. It has also led to mutations in the drug, resulting in decreased susceptibility. So how does it affect tinea? Trichophyton triggers Th2 response, which counteracts the Th1 microbicidial action, leading to persistent infection. Topical steroids profoundly inhibit Th1 response, hence leading to a perfect storm. It is very difficult to treat once the patient has used potent topical steroids. Routinely, we would diagnose a fungal infection using a potassium hydroxide preparation, mostly available in medical college or institutional settings. Normally, we would treat commonly fungal infection of the foot, which is seen in diabetics, with the topical antifungal. If no response, we may add systemic antifungal. Now, when I say naive tinea cruris, we mean where there has not been a prior use of topical steroid. Traditionally, we would start with topical antifungal and graduate to systemic antifungal if the need arises. Normally, for a naive tinea infection, we would treat for 2 to 4 weeks. But for a steroid-modified fungal infection, the treatment can last much longer than 4 weeks. Is there an emergence of antifungal resistance, or is there an emergence of a newer species? The house is open for debate. Newer zoophilic species, mentagrophytes, exhibit a very rapid growth in the primary culture. And what we need to understand that while the earlier fungi would not survive more than 12 weeks on a towel, this particular species can survive for more than 25 weeks. So it is very important that if we suspect a fungal infection in a diabetic patient, we should definitely consult them to disinfect the clothes by washing it separately in hot water. I even tell my patients not to use a washing machine and make sure they dry in sunlight. In conditions like Bangalore weather, where you do not have enough of sunlight, it's very important for patient to iron the undergarments from inside before they wear it. The new rule book of treating fungal infections, we cannot, no longer go back to the old Western literature where we treated an infection for 3 weeks. Hundreds and thousands of brands of topical and oral antifungals are available. Cheaper brands made by obscure companies do not have a satisfactory efficacy when compared to the well-known brands. I do see an increased clinical response to a better brand than an obscure brand. No new systemic antifungal agent is seen in the vicinity. We have to use our old armamentarium in an appropriate dose and duration. It is very important to consult the patients prior to the starting of therapy. Do not give them suboptimal dose and less duration. Very important for us to chart a guideline together. Please avoid OTC steroid antifungal combination. Why we attempted to use it? Because steroid, it gives a rapid improvement in the symptoms, only to give us a double trouble. So systemic antifungals cannot be repositioned. We need to individualize treatment, but make sure we monitor the LFT and RFT if we put a patient on a treatment more than 4 weeks. Itraconazole is the only option we have for deeper mycosis. Please use this molecule judiciously. Combination therapy with 2 systemic agents should be our last resort. I just want to briefly talk about toenail onychomycosis. It's a very persistent problem for diabetic patient. It can present as distal, white subungual, or candidal onychomycosis. We also see an increased risk of ingrown toenail. Few tips, a few pearls for practice. Please use toe spacers early in diabetic patients to avoid this. Number 2, we have to advise patients to trim their nails in a square form rather than, a well-rounded form, because this increases the risk of toenail infection. We should always advise a use of powder in between the toes. It's also important for a diabetic patient to disinfect their socks before they use. And it's very important to keep feet dry. In a country like India, where people like to wash their feet every now and then, we have to specifically instruct them to dry these spaces in between the toenails, because they can also act as a portal for bacterial infection. We have to remember drug and drug interactions. There have been few studies which show the interaction of sulfonylureas with itraconazole. Any drug that is metabolized by cytochrome 3A4, we need to exercise caution when it comes to antifungal. Terbinafine is the drug of choice if you suspect an interaction. We have also seen interactions of sulfonylureas with fluconazole in few studies. Topical antifungals are like an old wine in a new bottle. Do not use them less. They rather show very less resistance in the literature. Amlodipine is a new class of antifungal agents. It is very potent antifungal agent, especially when used as a lacquer form. If you suspect beginning of a fungal infection, start a patient on an amlodipine lacquer as soon as possible. Clotrimazole has been used for very long. There is no study that confirms that resistance has been found to it. Newer topical antifungals like luliconazole, sertaconazole, ibuconazole have more anti-inflammatory activity. Always follow the rule of 2. Ask the patient to use the ointment 2 centimeters beyond the affected area for 2 weeks beyond the clinical resolution. So even if the rashes have resolved clinically, please ask the patient to use topical antifungals for a longer period of time. Candidal infections, we all know, can be first sign of undiagnosed diabetes infection. Oral candidiasis is like an opportunistic infection. We do see an increased incidence of non-albicans species. It has been seen that there is something in diabetic patients which induces this yeast to convert into a hyphal form, and diabetics possibly also have a blunted immune response to candida, which could be the cause of problem. So in a diabetic patient, it is very important for them, if you see any sign of oral candidiasis, ask the patient to paint the mouth with an antifungal after removing the dentures. Their denture hygiene is very important. It can, 0.1% hypochlorite solution or white vinegar can be used twice a week. These are the few presentations of candidal infection. Candida perlichae is very common. Patient in this case needs to use an antifungal and a good moisturizing agent. Such patients might also require concomitant nutritional supplements. This is also one common presentation in diabetic patients where you can see redness, blotchy rash, thick, lumpy discharge. Candida means curdy white discharge, whether it is the balanoposthitis or it is vulvovaginal candidiasis. You might see thick white discharge. Sometimes patients have already washed this area, so you may not see a discharge, but you may see a red irritated vulval skin, which could be sign of vulvovaginitis. The transition of albicans from yeast to hyphae is inhibited at low pH, and hence the secretion of lactic and other organic acids may impede candidiasis. It has been seen that lactobacillus strains originating from sites other than the vagina, they exhibit strong anti-candidal properties. We commonly use azoles to treat vaginal candidiasis. They exhibit static activity. So they require, as I said, most of them are fungistatic, not fungicidal. So they require an efficient host immune response to resolve symptoms. Few pearls for practice. Please do not prescribe intimate washes. A lot of them have come up, especially for diabetic patients. They may contain local anesthetics, antiseptics, and preservatives, which may aggravate allergic contact dermatitis. In India, we should ask patients to have a good hygiene, but they should avoid washing the private areas every time they go to urinate. Frequent douching in women or preservative-laden intimate washes should be avoided. Patients should use a gentle soap twice or thrice a day. Over-aggressive washing leads to increased candidal colonization. Probiotic therapy, in my personal experience, is very, very successful for treatment or prevention of candida. There have been studies where Lactobacillus rhamnosus and reuteri had, for 28 days, along with fluconazole, resulted in a superior clinical and mycological cure. How do they help? They, possibly modulate the small intestinal mucosa. They inhibit the growth of albicans in the vagina, and they also reduce the ascension of yeast from rectum to vagina. Please prescribe probiotics along with antifungal therapy. Tinea versicolor, very common infection, especially in areas where there's a lot of humidity and sweating. As the name suggests, it is scaling of various colors. Patient can present with white color, red color, brown color, asymptomatic scaly lesions, mostly involving the upper trunk. In potassium hydroxide can be used to diagnose, though clinical diagnosis is enough. It's very important that we counsel the patient that pigmentary changes may take months to resolve. It is also like an opportunistic infection because the malassezia, the causative fungus, is a commensal, may not require a very aggressive therapy. Topical antifungals should be sufficient. Intertrigo, again, a common cutaneous disorder because of moisture and friction within skin folds. It's important to prescribe antifungal dusting powder, but always prefer an antifungal dusting powder without starch, especially in a diabetic patient. It may occur at any age. Fungal or bacterial infections can exacerbate. Please avoid the temptation of using a topical steroid early. We should be asking the patient to avoid douching and overcleaning of the areas. We should always start with the topical antifungal in any intertrigo patient. It can be, diagnosis is very simple, mostly clinical, doesn't require a culture or a potassium hydroxide mount. Application of a topical antifungal drug, especially the newer azoles like luliconazole, amlorphine, ibuprofen is recommended. And because luliconazole, ceticonazole have additional anti-inflammatory and antibacterial effect, they could be first drug of choice. Low potency steroid is a big no-no. Only in a patient who's not responded to topical antifungal for 6 to 8 weeks, you may go for it. Thank you so much.
Thank you, Divya. That was a nice presentation on fungal infections in diabetic. I don't see any questions in the chat box, but I have a couple of them, and I think Dr. Arvind may have some questions. My first question to you is, now we have a lot of drugs which increase fungal infections in diabetic patients. Like we use drugs called SGLT2 inhibitors. What they do is the chance of developing genitourine fungal infections is up to 4%. They excrete glucose in the urine, so the chance of fungal infections are high. So it can be other ways. It could also be induced by treatment for diabetes, though they're very effective drugs. We sometimes stop them. My second question was, when do you start oral agents in patients with tinea infections?
If again we divide it, if the patient has been a steroid naive patient who's never used any antifungal steroid combination, it is recommended to start with the topical antifungal. I generally wait for 2 to 4 weeks before I start a systemic antifungal in a patient, because one is there's no risk of interaction, so topical antifungals can be continued well beyond 2 to 3 months time as we do. Second, if the infection is widespread involving more than one area, like if you see a coexistent jock itch with patches on the face or the trunk, then we start with oral antifungal as soon as possible along with the topicals.
Okay, thank you. In candidal infection, which is the oral antifungal of your choice when you want to start? Suppose say you have oral candidiasis and it's affecting very much and you need to start, and for how long, and which is the drug which you would prefer for patients with diabetes?
Dr. Sanjay, I would start with oral hygiene measures. I will start with oral antifungal only. I prefer once a week dose, which in my opinion works better than giving a smaller, lower dose, say something like 400 mg per week. With 4 weeks, I would add a probiotic. If I see no sign of resolution, then I would go to oral itraconazole. Oral itraconazole can also be used in a weekly dose, which I find more effective in oral and vulvovaginal candidiasis. Rather than giving them a 3-week course of 100 mg per day, we can give a weekly pulse kind of dosage, like 400 mg per week for 3 weeks. And as we all know, oral hygiene, and in my personal opinion, probiotics do help a lot. I don't know what would be the opinion of.
No, I don't know, but our experience is limited. But we see these patients coming out with repeated infections, especially when you ask them to use a oral, a local antifungal. Once there's a small clinical resolution, they stop it and then it comes back. That's the most important. What you emphasized on the point is trying to continue them after there is a clinical resolution, I think is the key, and preventing, and hygiene becomes an important factor in them.
Oral prophylaxis by dentists, because we see a lot of lichen planus patients with secondary candidiasis. What we call as scaling is another way to reduce the recurrence of oral candidiasis. in a patient. So dental hygiene would also play an important role. So instead of upscaling the medicine every time patient comes with a recurrent episode, we have not seen clinical or microbiological resistance to fluconazole as of now. So there is a debate whether it is something else that we are missing in the jigsaw.
Okay. Thank you, Dr. Divya. I think Dr. Arvind has a question. Is going to ask.
Divya, I'm asking this question as a diabetologist, and we do see a huge number of patients with toenails getting infected with fungus, and then they have ingrowing toenails. Sometimes the edges are raised and there is fungus inside. They have never cleaned it for months together. On top of it, they also have web space infection with tinea. But everybody wants to become normal, and this habit of washing their feet and not wiping it still continues. Uh, the priests in temple, particularly when they come, they have more of this problem. How do we go about treating them?
I think so. One flyer or a set of instructions, the way we have for diabetic foot care, we need to give for every diabetic patient. Number one, use of toenail spacers, they're available online, is a very important thing which I do in my practice. I advise all diabetic patients to use that. They can also use indigenous sterile cotton balls in between the toenail spaces. We have to emphasize them to, of course, keep it dry. Adding an antifungal powder early in the prevention of a fungal infection would go a longer way. Starting a toenail lacquer at the beginning or the first evidence of fungal infection is also helpful. We have to tell them not to, generally we like toenails to be very trimmed and, just hinging on the nail bed. So I generally ask them to use a toenail clipper, which also should be sterilized. If they are suffering from a toenail onychomycosis, they need to have a separate nail cutter. They have to cut the nail in a square shape. And there are also toenail separators available for early ingrown toenail. So, they can be applied easily every day on the toenail to prevent the further, once ingrown toenail increases, it can actually lead to sometimes fatal bacterial infections. Then, as I said, so that any patient who comes with the toenail, we should start them on a topical antifungal for the web spaces. Because mostly it is the web space infection that leads to toenail involvement. And then toenail involvement can also lead to recurrence of it. So it's a ping pong effect. So it's very important that we ask them to continue putting topical antifungals in the web spaces as well. Coming to the treatment part, we do see a decreased efficacy of medication. So there are two ways. One is the pulse therapy of antifungals. So we give itraconazole 400 mg per week for 3 weeks in toenail and for 2 weeks for a fingernail. We can also add sequentially. So first we give itraconazole for 400 mg per day for 1 week. We give it for 1, 2, and 3 months. 4th and 5th month, we can add oral terbinafine because it has an additional fungicidal activity. The dosage is double the normal dose, so 500 mg per day for 1 week for 2 weeks. So sequential therapy can be used in advanced cases, but lacquers is something that any diabetologist can use in a daily practice to prevent further spread of onychomycosis. And very bad conditions where you see a totally dead and yellow nail, it is important for them to meet a surgeon and get the nail removed. And the antifungal therapy should also be initiated along with that. So I think usage of toenail separators, toenail for ingrown toenails would also help in management of the toenail infections.
Thank you, Divya. It was nice listening to you, and welcome to the Diabetes Club. Okay, hope you don't see too many fungal infections which are very resistant to treatment. Thank you very much. Thank you.
Okay.
Before we leave you, Divya, you mentioned about the probiotic
Yes, sir.
usage, and what is the dosage you give and for how long?
I generally prefer some preparations, like in my opinion, enterogermina-like preparations are better. I generally advise daily for 28 days. So probiotic other than lactobacillus is what I mean to say. we can use them for 28 days in any patient who comes with oral or vulvovaginal candidiasis. The clinical resolution of symptoms is almost instant. It works like a steroid. I mean, that's a wrong statement to be made in a conference. It doesn't, we should not use steroids, but it rapidly reduces the symptoms. So I use it for 28 days in a daily form. There are also combination of prebiotics and probiotics, especially patients who have vulvovaginal candidiasis, iron deficiency, and gastritis-like symptoms. I would always advise them a prebiotic probiotic combination, again in a species other than lactobacillus. So for 28 days course is what I do. It's been reported in the literature as well.
Thank you.
Thank you, Dr. Divya. It was nice listening to you. Now, going on to the next program, I invite Dr. S.R. Arvind, the chairman of the conference and chief of Diacon Hospitals, to talk about targeting inflammation and diabetes. Over to you, Dr. Arvind.
Thank you, Dr. Sanjay. This is a topic which is not really new, and it's been quite old. But we've been repeating this because there are a lot of new messages to be taken. Inflammation and diabetes, as we know, is ages old. I mean, we have been talking about it for almost 2 decades. It's a very well-established link, and inflammation is not just associated with diabetes. We see inflammation in pre-diabetes, and we of course know that we also see it in rheumatoid arthritis and atherosclerosis. People have been talking about this cellular level of chronic inflammation that's associated with pre-diabetes and diabetes almost since the 1990s. But then we did not really have the evidence. We did not understand the cellular mechanism of how exactly the chronic inflammation actually starts. I will not go through the details of this particular slide, but it's enough to know that there is a disruption of, one second, I will just take my laser pointer. There is a disruption of the inflammatory gene, and this disruption of the inflammatory gene can be a result of environmental signals or inflammatory moieties, or it can be even a virus attack. So what happens then is a cascade of events starts from the moment the inflammatory gene is erupted. And we know the rapid acting primary transcription factor is the nuclear factor kappa B. So once the activation of nuclear factor kappa B starts, the cascade of events actually starts not just moving, but running. And then the low-grade chronic inflammation that we talk of at the cellular level actually starts off. Well, type 2 diabetes is an inflammatory disease, and we have international evidence which goes back to, as I said, almost 2 decades, and it's nothing new, and there are enough number of articles how the chronic inflammation is seen in a person with diabetes. Now, many people want to know what are the potential markers of this chronic low-grade inflammation. You'll be surprised to find that a very simple WBC count itself can be one of the early markers of chronic inflammation. And of course, you also have cytokine markers, you have acute phase reactants, and immune cell markers. Whenever we talk of inflammation and diabetes, first thing that comes from the colleagues and friends is, well, I can't really be doing IL-6, TNF-alpha, IL-10. Well, for my colleagues and practitioners like me, the simplest 2 things that we can really look for is the white blood cell count and the hsCRP. And I myself was surprised when I started reading more about this inflammation, how we can actually test the white blood cell count. In fact, there's been a lot of studies, if you Google and try to see from 2002 onwards, the association of white blood cell, how it actually worsens the insulin sensitivity, and it can predict the development of type 2 diabetes. Now, if you have a high blood cell count, you're most likely to develop type 2 diabetes. In fact, the baseline WBC count is about 6,900 and less. Now, if anything more than that is there, then it has an independent 52% chances of you going on to develop diabetes. So the problem that we have as clinicians is we don't really know the baseline WBC count of most of our patients because we don't do it routinely in our patients. And the habit of going for a regular yearly health checkup, of course, is there. It's slowly improving, but seems to be coming really down. And there are also other markers, especially the cytokine markers. There's adiponectin, there is TNF alpha, and other inflammatory cytokines that are really something that can actually predict the development of type 2 diabetes. And this is, of course, a meta-analysis of about 19 studies. And what you see here is, if you look at the CRP, it has a relative risk of 1.48 compared to TNF alpha, IL-6, IL-18, and 1B. CRP probably has a better RR of 1.48 to predict diabetes. And interestingly, the sensitivity analysis strengthened the associations. And we also know that the low levels of adiponectin increases the risk of type 2 diabetes. And this is an interesting slide which goes back to 2008, which tells us that if the baseline adiponectin levels are high, the progression to type 2 diabetes is actually slower. This is from the famous POP-ABC trial, where they looked at a huge number of people who are normal to start with, and they were seen over a period of 10 years. In fact, now a 15-year follow-up is being planned, and they looked at a number of things. I'll only show you the WBC and the CRP count here, but they have done a number of things. What they're trying to show was there were two groups, Caucasians and the African Americans. No diabetes to start with, but they had strong family history of diabetes. And year by year, when you start doing different analysis, especially the biochemical parameters in this group, as the WBC count starts to increase, the chances of type 2 diabetes or moving to IGT increases. And the same thing with the CRP also. So as the duration of follow-up increases, as the CRP levels increase, you know that there is inflammation and the chances of developing type 2 diabetes. And in the same study, they also went on to show that the adiponectin level starts to drop, and then you are more likely to develop type 2 diabetes. And there were two groups, of course, the non-progressives and progressives, but in both the groups, there was evidence that the adiponectin level starts to fall even when you are normal, and that actually predicts type 2 diabetes. Having said all this, the question is, why are we not interfering with inflammation when we know that type 2 diabetes is associated with chronic low-grade inflammation? To tell you, a number of drugs for the last 20 years has been tried, salicylate and many others listed in this particular slide. And of course, I will only be focusing on hydroxychloroquine today because that has a lot of evidence. Now, this is the rosuvastatin Jupiter study. Well, we all know the results of the Jupiter study, so I'll not go into the details of that. But rosuvastatin was a statin that was used, and statins not only reduces the cholesterol, but we also know that the statins are anti-inflammatory. So one of the things that people were looking for was to see the anti-inflammatory effect of rosuvastatin. But then what actually happened was the rosuvastatin group did have a higher incidence of physician-reported diabetes. So rosuvastatin is still being used, but not definitely as an anti-inflammatory in many of our patients. Salicylates were used, and the whole world was looking at this particular trial, which is called the Tinsel trial. In fact, it directly was trying to see if it can be alterations at the IK beta alpha level of this cascade of events that starts from the inflammatory gene. Everything seemed to work very well when salicylates were used. And decellular metabolism or blocked at the IK beta alpha levels. And what followed in the tinsel trial was they were able to demonstrate actually a decrease in the WBC count, which is what we were looking for. There was a decrease in the neutrophil levels. In fact, the adiponectin levels actually increased. So far it was great. Everything that was trying to tell us that the inflammation is coming down happened with salicylates, but unfortunately, it did not reduce the hsCRP. In fact, it also reduced HbA1c, but it had no significant effect on hsCRP. So after many years of good work by Dr. Alison Goldfein, who will probably be talking in about an hour's time from now, we found that salicylates cannot be used to actually reduce inflammation, chronic low-grade inflammation that we see in type 2 diabetes. So this is about the tinsel study. The interest in hydroxychloroquine started many years back, almost 13, 14 years back. And they were using hydroxychloroquine as a very standard drug in rheumatoid arthritis. And then this particular prevention of diabetes in JAMA 2007, it's a very interesting article. And then I want all the doctors to go through it when they have time. So what they really found was when hydroxychloroquine was used for more than 4 years, there was a reduction of almost 77% in the risk of type 2 diabetes. And compared to those who did not use hydroxychloroquine, the group which used hydroxychloroquine did not progress to type 2 diabetes. And there was a 77% risk reduction of developing type 2 diabetes. And this is the trial which actually made people sit up and say, why is it that diabetes is not getting developed in those who are taking hydroxychloroquine? So it must be doing something, not just on inflammation, but then probably it must be doing something else also. Because at that time, and even now, it's very clear that hydroxychloroquine and its anti-inflammatory action, I mean, it seems to reduce IL-6, IL-1, CRP, increases adiponectin, it has a role to play on the leptin and reduces TNF-alpha. So it does a lot of things. So is it the anti-inflammatory action of hydroxychloroquine that did not push the patients from normalcy to diabetes, or was there something else? In fact, in 2014, DCGI actually gave the permission for hydroxychloroquine to be used in diabetic patients as a diabetic agent. And there was enough proof that it not only has an anti-inflammatory action, it also has a good action on the insulin sensitivity and increases the levels of available insulin. And that was very, very interesting at the cellular level. I'll just quickly tell you how it happens. In fact, hydroxychloroquine inhibits the insulin degradation. And in this cartoon, you can see that insulin dissociation from its receptor is shown here. And there are insulin degrading enzymes, which are actually degrading the insulin. So there are enzymes in an acidic environment which are actually degrading the insulin, and the bioavailability of insulin comes down. But when you use hydroxychloroquine, interestingly, what is happening with hydroxychloroquine is it is making that area alkaline. And because it becomes alkaline, it actually inactivates the degrading enzymes itself. So the insulin degrading enzymes do not degrade the insulin. So the insulin that is available for use is much more. And this is what the cartoon is showing. And then people have also looked at the hydroxychloroquine's effect on insulin. So when you give hydroxychloroquine, the degradation enzyme levels are coming down, and then there is an increased levels of insulin available to be used by the body. So this is exactly how it acts on the insulin and also reduces the blood glucose level. So one, of course, is the anti-inflammatory effect. And the second thing is the direct action by degrading insulin degrading enzymes. This is another trial that came out in 2012 where hydroxychloroquine is shown to improve. So you give hydroxychloroquine here, and within 6 weeks, there is an improvement in insulin sensitivity. And you stop hydroxychloroquine, the sensitivity drops. Well, the important message is, of course, it takes about 6 weeks to start acting, but clearly is improving the insulin sensitivity. And as the insulin sensitivity improves, the resistance comes down at the end of 6 weeks. You stop it, the resistance is going back. So at all levels, the action of hydroxychloroquine on insulin has been very clearly shown. And these are Indian studies itself from Baidya and his group, clearly telling us not only it is reducing HbA1c, but it's also reducing hsCRP by 1.5 to 1.7. So this is interesting. So it's reducing inflammation, it's reducing HbA1c. There's been a number of international studies. Of course, there are Indian studies and real-world observational studies. So we'll quickly go through that. I mean, there have been studies from 1990 and 2002 onwards, everywhere clearly telling us that there's a reduction of HbA1c. In fact, this study shows a very, very good reduction of almost 3% HbA1c. But the average that we have seen in most of the studies, if you do a meta-analysis on your own, you find that anywhere between 0.6 to 0.8 is the reduction that you can expect with hydroxychloroquine, which is right. And this is an international study where the patients were already on metformin and glimepiride, and then the hydroxychloroquine 400 mg once a day was added along with a placebo. And what they found was in the hydroxychloroquine group, a reduction of 1.3 HbA1c compared to the placebo group. So these are international studies which are available. And this is when hydroxychloroquine was pitted directly against pioglitazone. The HbA1c reduction was good at 1.2, but the pioglitazone group, of course, had a weight gain, which we know of. And quickly, we'll go through the phase 3 Indian trial, which actually gave or made DCGI permit hydroxychloroquine to be used as an anti-diabetic agent. And they randomized about 267 patients. Without going into the details, I can clearly tell you the change in the baseline of HbA1c in the HCQ group was about 0.9 compared to it is about 0.87 compared to the pioglitazone group, which is about 0.9, because it was a DCGI mandate to actually try hydroxychloroquine in one arm and pioglitazone on the other arm. And this again is a 72-week multicentric observational study, and this again has been published from the Arjun Vaidya's group, where they have shown a reduction of 1.7 in HbA1c and about 2 milligrams reduction in hsCRP. There's been large clinical data of HCQ in type 2 diabetes, and I can go on and talk about it, but everyone has shown a reduction in A1C and hsCRP. And interestingly, hydroxychloroquine works the best when the hsCRP levels are more than 3, and this has been shown in the phase 3 trials also, that if the hsCRP at the beginning of the baseline is more than 3, that group seems to get a better reduction of HbA1c. These are the number of Indian studies, which some of them have been published and some of them have been shown in various conferences, either as oral or poster presentations. So we have the evidence that hydroxychloroquine definitely has a role to play in type 2 diabetes. The drug controller has actually permitted this drug to be used in type 2 diabetes after the failure of 2 drugs. Initially, it was told that metformin sulfonylurea failure cases can actually go for this, and that's the label instructions. But the question is, when you talk of hydroxychloroquine to be used in type 2 diabetes, well, the question that most doctors ask is, well, why not we just stick to the time-tested agents? Well, I just would like to say this. I think it's time to see beyond the glycemic control, and especially SGLT2 have clearly told us that it's not just glucose. I think it's also something beyond the glycemic control. Any trial you take, there is a set of patients who get the benefit, and there's a group who do not get the benefit. And we always ask the same question: why is it that some people get the benefit and not all? And then we end up saying, well, there is a residual risk in that group. Or sometimes, as an Indian, you say, well, it's the karma of that group. Whether it's the karma or the residual risk, how do we actually target the unconventional risk factors better is the question that we have to ask. And today we have so much of evidence about inflammation being present in type 2 diabetes. Let's ask ourselves a question: is it time to target inflammation? And if there is a drug which is targeting inflammation with sufficient evidence, and if there is a drug which is also helping a diabetic by reducing HbA1c, why not actually use this? And with that, I will leave you with two more slides with the take-home messages. Well, hydroxychloroquine is a definite therapeutic option in diabetes and controlled by dual oral hypoglycemics. And we have evidence that it has an action, it has a role to play on insulin degradation, and its effect on inflammation has enough and abundant data to support it. It's a good, effective glycemic control. It has a novel mechanism of action. Hydroxychloroquine is a multifaceted drug with pleiotropic benefits. It reduces, or it's probably neutral on lipids. It has antithrombotic effect, and definitely hydroxychloroquine clinically proven to reduce CV risk in rheumatoid arthritis and lupus patients. So it's also CV safe and can actually or probably give us CV benefits. So thank you so very much. And I leave you with this question: will hydroxychloroquine be the next aspirin? Well, we don't know. People still want more data. People still want more evidence. We'll wait for the day. We'll wait for it when it is going to actually happen. Thank you so very much.
Thank you, Dr. Arvind. Thanks for that wonderful talk. Now, there's a question from the audience. We'll take that first. What's criteria to select patient for hydroxychloroquine therapy in type 2 diabetes, and contraindications of HCQ in type 2 diabetes?
Thanks. If you have unmuted, I can speak. The DCGI says if two drugs fail, this can be the third one, and that's a labeling for hydroxychloroquine right now at this point of time. And what we have seen from the trials is very clear. If the HSCRP is more than 3, this drug seems to be working extremely well. And the HbA1c reduction that we see in that group of patients where HSCRP is more than 3 is anywhere from 0.6 to 0.8. Otherwise, in some of the trials, it has also been 0.3 to 0.5. But what I'm saying is the action of anti-inflammatory effect of this drug and the pleiotropic effect, and looking beyond the glycemic control is what we have to look at. As far as the side effects is concerned, people are worried about the macular edema that it is supposed to cause, but then you go for international recommendations, it's very clear. It's a drug-related effect. So if the dose does not exceed so many milligrams over 5 years, nothing is going to happen. In fact, the chances are less than 0.1%. And anyway, a patient with diabetes is always tested for retina on and off. So the macular edema caused by hydroxychloroquine is not a threat at all. Well, intolerant to drug, some skin rashes, like what happens in dermatology usage, of course, you have to stop the drug if you see the rash, but otherwise, side effects are probably very, very minimal with hydroxychloroquine and with once a day dosage. Rheumatoid arthritis, rheumatologists have been using this drug for years together, and they're so happy using this drug. They have never seen any problems. And because we have more powerful agents in the field of diabetes, people hesitate to use hydroxychloroquine. But you will always have a subset of patients who will benefit. In fact, initially we started using this drug in patients with periarthritis of the shoulder or rheumatoid arthritis, etc. But now we do use it in many cases. Of course, it may have come down with very powerful SGLT2s and other things coming into existence, but there is still a group of patients in whom you can use hydroxychloroquine.
Welcome, Manohar. I think you joined in late, but we're ending the session, but you can continue listening.
Sorry for joining in late.
Late. Yeah, I understand.
Its role in reduction of insulin dosage is much talked about, hydroxychloroquine. What is your opinion, sir?
Well, I haven't done any of those trials, but what I can tell you is
It has shown a reduction of about 4 to 6 units of insulin in those who are using more than 30 units. And that's what I have read in the literature, but I haven't seen this in my practice so far.
Okay. Thank you, sir. And I think we do not have any more time for questions. We end the session now, and I hand over the mic to Bhavna to take it over to the next next symposia. That's an insulin symposia coming up in the next couple of minutes. Over to you, Bhavna.
Thank you very much. We now have a small presentation to play for you to thank all the sponsors of ADORE 2020.
Exactly.
Okay, so thank you all once again. I see that for our next session, our chairs and speakers have all joined in already. So hi, Dr. Manoj Chawla, Dr. Prasna Kumar is here, and the others are set to join. So let's move on now to the insulin symposia. So I request Dr. Manoj Chawla from Mumbai, the director of Lina Diabetes Care, to take over the session. So over to you.
Thanks, Bhavna, and thanks to the Primer Group for having me here with all in this interesting insulin symposium at the ADORE conference. So we have some stalwarts who are going to be speaking in the next hour and a half, and a very interesting session with multiple different topics covering most areas on insulin. And the opening batsman for this session is none other than Dr. Prasanna Kumar. Hardly needs any introduction, and I'll leave it at that. One of the most senior-most endocrinologists, and it's a pleasure to listen to him every time. Dr. Prasanna Kumar will be speaking on biosimilar glargine, its safety, efficacy, and cost benefits. We, of course, have 4 talks in this session, and then we have sufficient time for a panel discussion. So we'll request all attending to type in their questions in the chat box and send it to us. We'll be happy to take all those questions at the end of 4 talks. Over to you, Dr. Prasanna Kumar.
Good afternoon, everybody. Thank you, Dr. Manoj Chawla. Can I share my screen?
Yes, sir. Please go ahead.
Thank you. Okay. I'll be talking about the biosimilar insulin glargine. Biosimilar insulin, what is the safety, efficacy, and what is the cost-saving factor in these cases? Now, before we understand these things, let us try to so cost of diabetes care is almost 1,75,000 crores. If you see the GST in November, it's almost 1 lakh and odd crores. So that way, 2 months of GST in India collection will be what we are spending care to all the diabetics in the India, which is almost 70 million. 2010 to 2020, there were 3 times increase in cost. We did this initial study way back in 2005 or 6 with Anil Kapoor. From there to today, the latest one, which was almost 332 US dollars or 25,000 rupees per year. This is probably the minimum or the mean if you take like that, not necessarily the maximum, and not hospitalization. The ratio of known to unknown in rural and urban, which is 3.3:1 in rural compared to 1.8:1 in urban. So if you detect all of them, the cost will be probably double or triple. So the diabetes prevalence in rural India has increased 3 times for the last 10 years as such. And what are the factors which affect the cost? Prevalence of diabetes more than 5 years, more than 3 comorbid condition, complication, hospitalization. Drug cost account to more than 50% of the cost household, which Anil Kapoor and we did this study in 2007. Now it may not be 50%, it may be 20% or even less today. But for those who are retired, it is substantial one. If you look at annual direct cost and all, which we published 2007 in Economic Analysis of Indian Care by Indian Journal of Medical Research, that the anti-diabetic drug formed 17% of the total cost. But today, the cost is much more than 25%. 13 years back, what we had done is different. So why should we bother about biosimilars? Are they cost effective, cost saving? And what is its relevance today? As you know, biosimilars are not generics. You know, generic drugs, whether it is paracetamol, antibiotic, and oral drugs. So generics are identical copies of small molecule medicinal product derived from chemical manufacturing process. Whereas biosimilars are similar versions of biological medicinal products derived from bacteriological, biotechnological manufacturing. A biosimilar is a therapeutic protein molecule with an identical amino acid sequence to that of a previously marketed product with no clinically meaningful difference in efficacy safety. I'm going to show some data how the development of biosimilars compared to the originators occurs and what are the regulation authorities and what studies show how the biosimilar glargine, because that is the topic of today, is as good as the originator. Now, difference in regulatory pathways for biosimilar genetics are in biosimilars, quality testing is on multiple batches, usually 3 or more, whereas genetics only 1 batch. Preclinical testing, in vitro characterization, comparative pharmacokinetic, pharmacodynamic studies, what we call PK/PD required in animal models. Clinical testing, phase 3 trial essential to compare. But these things are not necessary. That is why generics are much faster, much more cheaper. You must have seen many of the central government stores where they sell the generics. Now, the definition of a biosimilar, US FDA or European medical US FDA calls it as follow-on biologic, whereas EMA calls it a subsequent antibiologic. So similar to an orderly in terms of quality, safety, and efficacy. So these are the 3 important things by WHO, both in quality, safety, and efficacy. US FDA says biosimilars are highly similar to an already FDA-approved biological product known as the biological reference product, the original one, and have been shown to have no clinically meaningful difference from the reference product. Minor differences in clinically inactive components are allowed. It can't say 100%, even if you have 1 or 2% difference, does not matter at all. All of you have been to Paris and you have seen this photograph of Mona Lisa. You can't buy the painting as such because you know it's not for sale, and also even if it is beyond the reach of anybody. Whereas somebody can buy a copy of it, or you take a photograph, enlarge it and keep it in your house. So significant knowledge, expertise, and state-of-the-art capabilities are essential for consistently producing high quality, safe, and efficacious biosimilars. So why we should need biosimilar? Because the rise in incidence of disease from 2-3 million to 30 million, today it is 70 million. High level of income disparity and poverty, especially in country like ours, where there are billionaires, equally there are a number of people, maybe 25 crore population below poverty line, who don't get a second meal. Spiraling medical cost of treatment, challenges with accessibility and affordability to drugs, especially when you retire, income comes down like COVID time. Lot of people change from the originator to the biosimilar because 20 to 30% cost is less. Increase in off-patent drugs is all these days. Many of those things we have seen in oral hypoglycemic agent, which are 1/3 or 1/4 of the cost what we used to see 6 months back. Positive biosimilar clinical trial results, shaping up of stringent approval process. So the size and complexity of generics and biosimilar. Aspirin is a generic, 180, you will see relative molecular mass. Insulin, 5,800. Erythropoietin bigger. Monoclonal antibodies are huge molecule assets. So when you see originator and biosimilar, it's an inverted pyramid as you see in biologics, clinical studies, PKPD, non-clinical, analytical. Whereas non-clinical is slightly smaller. PKBD are same as what you see here, but clinical studies are small, meaning that the process from bottom to top model, when you see, it's an inverted pyramid when you compare biosimilars, where analytical takes bigger one, clinical studies are smaller for obvious reasons. The importance of PKPD for biological biosimilars are PK gives insulin absorption over time. PD shows action of insulin and clinical outcomes. So this is what you see biologics. Whereas when we are now talking about biosimilar, establish quality similarity with innovator and regulatory requirement for registration. So a biosimilar product can only be approved by FDA. It has the same mechanism of action, route of administration, dosage, strength, and approved indications and conditions for use. The facilities where biosimilars are manufactured must also be met by FDA standard. This is how you see the step 1, step 2, development of characterization, non-clinical, clinical pharmacology, clinical studies in originator, compared to biosimilar where the characterization is longer, non-clinical longer, but clinical pharmacology and comparative clinical studies are smaller. The step 2 studies are smaller, and that is why the huge investment in clinical trials, now you know CVOT trials, that just cannot happen with the biosimilar, not necessary also. That makes the cost of originator plus also developing drug huge. As you can see here, the cost of insulin in India and USA just cannot compare here. 60 to 70 times higher, and sometimes even 100 times higher, as you can see here. Many of those times what you see. As you have seen in 2002, all of you and 6, the biosimilar. First one was in India. It is not because anybody in the country. The multinational dropped their cost because they could not compete with the Indian biosimilars where the cost was less. That's why ultimately advantage goes to the patient. Not only that, once it has come down, you see, it continues to be so for the last 4 to 6 years. And more biosimilars probably cost will come down also. And people thought, okay, this is for poor countries and poor people. It is not so. There are 20 approved biosimilars currently in Europe, and what started maybe $5 or $10 billion, it is almost $200 to $300 billion of business in the world biosimilars as such. The evolution of the guidelines, because before 2000, how European Union was the first one, Australia, Japan, Canada had 2005, India and China had what are the regulatory guidelines to approve a biosimilar in 2016. Recently, 2019, even USA has. Many of the Indian insulins have been now approved by USA. Hopefully 2021 it will be approved. So what are the summary? Biosimilars are therapeutic protein molecules with an identical amino acid sequence to that of a previously marketed product with no clinically meaningful difference in efficacy or safety. Biosimilars are not generic. They are similar but not the same as reference point. Biosimilars provide valuable options that create choice of prescribers patient. Quality of biosimilars is the manufacturing. As you can see here, how the basiclar here, the molecule, and again land test. This is the biosimilar, bottom one is originator, both of them merge when you have this drug as such. So this is one of the, that is Lilly's IGLAR, that is insulin glargine biosimilar, have been evaluated in a comprehensive development program where 1,779 patients in phase 2 preclinical studies and PKPD in phase 1. And there are 3 clinical studies. There is element 1 in type 1 diabetics, element 2 in type 2 diabetics, element 5 in type 2 diabetics. As you can see here, there are various studies where all this has been passed as such. Then you see efficacy and long-term safety profile of insulin glargine demonstrated across continuum. So these studies were type 1 diabetics preschool, then origin trials P2. I'm sure some of you have been involved in this origin trial of the pre-diabetes and type 2 diabetes, and also the inside study of type 2 diabetics as such. So what is this element study? Efficacy and safety of really LY29630116 insulin glargine compared with insulin glargine Lantus of the Aventis in patient with type 1 diabetes in a randomized control trial. This is called element 1 study. There are like that element 2, 3, 4, 5. And the element trial glargine was mostly in type 1 diabetes. As you can see here, at 24 weeks and 52 weeks, similar A1C reduction, whether it's a original molecule or whether it's a biosimilar. Same thing if you see similar proportion of patients achieving A1C target, 24 weeks and 52 weeks, the biosimilar was equivalent to the originator as such. And this is another one, daily insulin dose. Again, whether the efficacy is same. As you can see at baseline and 24 weeks, the daily insulin dose did not vary between the originator as well as the biosimilars. And body weight, even if you see this difference, there is no significant weight difference when the glargine was used, originator versus the biosimilar as such. Then you see in type 1 diabetics, the similar rates of hypoglycemia. So that means safety is safe. As we can see, both the total hypo, nocturnal hypo, and severe hypo same in both the originator and the biosimilar. Same thing, the event rates, as you see, the events of hypoglycemia were also not significant between the two. Most important is immunogenicity, because when it is protein, you don't need these studies in the oral or generics, but you need it in proteins, especially injectable ones. Proportion of patient with detectable antibodies similar with the LY-IGLAR compared to the Lantus in patient with type 1 diabetes. Same thing, quantitative insulin antibody titer at the study end was similar, both the originator as well as the biosimilar. As you see the side effects, whether it is serious adverse effect or the other adverse effect as such, as you can see here, there's not much significant difference between the two glargines and all. So the summary of this element 1 trial is significant reduction in A1C from baseline with LY-IGLAR biosimilar that is comparable to original IGLAR. Similar safety profile, incidence of hypoglycemia, adverse event profile between originator and biosimilar. Similar immunogenicity profile between the IGLAR and the glargine biosimilar. This is element 2 study. The previous one what I showed you was element 1, it type 1 diabetics, whereas this is type 2 diabetics, similar efficacy safety of the biosimilar glargine and insulin glargine in patient with type 2 who are insulin naive or previously treated with glargine. Randomized double-blind control study. As you can see, our criteria was equal to and more than 18 years, type 2 diabetics. They were on minimum 2 oral antidiabetics plus or minus Lantus, A1C 7 to 11, insulin naive, or less than 7 if previously treated with Lantus, or BMI less than 45. So one group to the originator, another to biosimilar, it was followed up to 48 weeks. As you can see, this study, similar A1C reduction in type 2 diabetics with both the drugs, and similar proportion of patients in originator biosimilar achieved A1C. So this is total daily dose. Again, baseline 24 weeks. You don't see any difference between the originator and biosimilar. Same way, like I showed in type 1 diabetics, element 1 trial, element 2 trial did not show any significant difference in body weight change, which is very important between the originator as well as the biosimilar insulin, large. Safety. Again, if you look at the side effect, the incidence of safety and event rates were similar in both the glargine group. And The proportion of patients with detectable antibodies was also similar in element 2 trial, type 2 diabetics, and so also quantitative insulin antibody titers. This is to show that both type 1 and type 2 diabetics, the efficacy, safety is similar. And these are the adverse events, serious adverse events, when you look at the original glargine and the biosimilars as such. Element 5, the last study which I am going to show, is study design. It's an open label study in type 2 diabetics, more than 18 years age of type 2 diabetics, then A1C more than 7, less than 11, and must be taking A1C more than 2 oral agents. And this is what you will see in those patients. One group randomized to the originator and the second one is biosimilar. As you can see here also, similar A1C reduction, similar proportion of patients achieving the HbA1c goal, and insulin dose, body weight was same, and safety, similar rate of hypoglycemia, both the originator and all. Immunogenicity was also same in the element 5 trial as such. Antibodies were not significantly different whether you take the original glargine or the biosimilar, and adverse events were also less. So you have seen all the 3 studies, element 1 in type 1, element 2 and element 5 in type 2 diabetic. So what is the ultimate message for us? Significant reduction in A1C from baseline with a biosimilar glargine that is comparable to originator. Similar safety profile as shown by element 1, 2 and 5, incidence of hypoglycemia, adverse event profile between the two, similar immunogenicity profile between the originator and all. Overall clinical profile of biosimilar insulin is suitable therapeutic option in patients whom insulin glargine is considered an appropriate treatment. As you can see, efficacy, safety, dosing is similar, so that the biosimilar insulin glargine can be taken with mealtime insulin type 1, can also be taken in conjunction with other oral anti-diabetic in patient with type 2 diabetes. So ultimately, what is the message that we take home? When you study insulin glargine, how it was there version after 20-25 years back, and now last 5 to 10 years when the biosimilars are introduced. At least in the case of glargine, you know, from the originator, there are 3 of the manufacturers of biosimilar glargine in India. It's almost 20 to 30% less. That is quite significant when you look at patients taking 10, 20, 40. Some of my patients take even 100 units of the basal insulin also. The similar pharmacological characteristics, as I told you, pharmacokinetic, pharmacodynamics of insulin glargine compared to the originator, and this biosimilar demonstrate significant reduction in A1C from baseline that is comparable to originator, and biosimilar glargine demonstrates similar safety profile that is in terms of hypoglycemia, adverse profile compared to originator, comparable immunogenicity profile between the 2 groups. All major global diabetes organizations recommend basal insulin as the preferred choice of insulin initiation. All of you must have attended many insulin symposia, summit recently, which happened, which shows that if the fasting is high, the first insulin recommend is always basal insulin because of less of hypoglycemia, less of weight gain, and much smoother control 24 hours. Insulin glargine is considered as a gold standard in terms of basal insulin therapy. Biosimilars are therapeutic protein molecules with an identical amino acid sequence to that of a previously marketed product with no clinically meaningful difference in efficacy and safety. Biosimilars are not generics. You must remember, most of those generics are tablets. They are similar, but not the same as reference products. It's not just a chemical entity which is manufactured. Biosimilar glargine is similar in efficacy, tolerability, safety to innovators, Lantus at a very economical price. As I told you today, after COVID, 9 to 10 months of it, a lot of people have lost their job, a lot of people have been displaced, a lot of people have been, business has come down. In such a situation, we see a lot of them, because of availability, accessibility, affordability, have changed from the originator to the biosimilars. And this is one of the reasons why that people, when they come and say, doctor, I can't afford this insulin, which is costly. This is true not only in India, across the world. Even in USA, you see, the cost of medicine has become high, and US FDA is likely to approve many of these, the biosimilars. Thank you for your attention. If there are any questions at the end of the session, I'll be happy to answer that.
Thank you, Dr. Prasanna Kumar, for that absolutely clear presentation on biosimilar glargine. I'm sure there will be some questions in discussion, and as you suggested, we will take it up in the panel discussion. We move on to the second talk by Dr. Mohan Badgangi. Dr. Mohan Badgangi will be speaking on the best in range TIR, which is the new metric that we all keep referring to. So the best TIR and clinical outcomes with the insulin evidence. Dr. Mohan Badgangi is the senior consultant endocrinologist at the Department of Diabetes and Endocrinology at Manipal Hospital, Bangalore. Good afternoon, Dr. Badgangi, and good to see you, sir.
Good afternoon. Yeah.
Right.
Good afternoon.
Over to you to share and start the presentation.
Yeah. My topic today, I think Deepa is sharing the PPTs.
Okay. Deepa or somebody from the technical team, are you all sharing the slides for Dr. Badgangi?
Yes, Deepa will share the slides. She's just getting them open now.
Okay.
Let me start. In the last a decade or so, we have always been wondering whether the gold standard HbA1c is adequate enough in the management of type 1 and type 2 diabetes. And so we've always been wondering whether HbA1c is enough or not. Is it adequate? Or are there any new parameters that we would like to have in our tools for follow-up and management of type 1 and type 2 diabetes patients? So in this context, I will try to talk to you about time in range and continuous glucose monitoring, and what are the clinical outcomes that we have seen in the last 1 decade. Next slide, please. So is it time for us to change when we look at all these metric system or all these composite parameters that we are likely to use in our management on day-to-day basis? Next slide, please. So why do we need a monitoring tool beyond HbA1c? Is HbA1c enough? Is it not enough? Are we able to measure glycemic variability, or are we really able to correlate the chronic complications or the long-term complications with HbA1c alone? Is the mean blood glucose or the day-to-day blood sugar fluctuations are more important, and how do they correlate? So there is a intra or intraday glycemic excursions, various hemoglobinopathies, anemia, pregnancy, and treatment adjustments, and hypoglycemia we want to detect, and there are ethnic variations, racial differences. There is a personalized diabetes management. That's why we feel HbA1c may not be enough. Next slide, please. So we are moving from the composite parameters of day-to-day blood sugar management, HbA1c, to we want to detect something called as the hyperglycemia, hypoglycemia, as well as the glycemic hexad, which gives you glycemic variability, fasting blood sugar, and postprandial blood sugar. Ultimately, what does it tell you? It tells you the glycemic burden on the vascular tree or the organ function. Ultimately, in our practice, or complications, when we want to prevent, we want to preserve organ function. Next slide, please. So we are moving away from this definition of just measuring HbA1c. So what is the glycemic variability? It is the intraday fluctuations or interday fluctuations, and which in turn tell us about peaks and troughs, and also they give us an idea about underlying oxidative stress, as well as the increased risk of severe hypoglycemic episodes. Next slide, please. So when we talk about time in range, what is time in range? It is the time spent by the diabetic patient in 70 to 180 milligrams per deciliter of plasma glucose in the total of 24 hours. So it includes the glycemic variability. There are some of the readings are on the higher range, some are in the lower range, and majority of them are to be in range in order to get a good glycemic control and prevent complications. So patients experience different energy levels, moods, quality of life, and time in range can capture these differences in a way A1C cannot. Next slide, please. So this is, again, there are various levels have been identified in time in range, that is TBR, time below the range, where level 1 gives you a hypoglycemic episode of 54 to 70 milligrams, and less than 54 is level 2. And somebody needing assistance is level 3. Similarly, the 3 levels identified in hyperglycemia, which are more than 180, 180 to 250, and more than 250 when the patient presents with ketosis, ketoacidosis, or hyperglycemic crisis. Next slide, please. So there has been a lot of thinking, a lot of expert opinion, a lot of guidelines, a lot of experimentation, and opinion makers have poured in their knowledge, and a lot of the people who are working in the field of glycemic biochemistry, the basic scientists, have come into play. And over the last decade, people have come up with guidelines, and they have accepted the various values and given us an idea how to measure time in range, how to identify and how to extrapolate this, and how to incorporate this system into our day-to-day measurement of SMBG, and thus provide a better quality of life and better management to type 2 diabetes patient. So it has happened over the last decade or so, and ATDD, ADA, AST, ASD, as well as AACE, all are part and parcel of these recommendations. Next slide, please. So as I told you earlier, that ATDT recommendations are shown here, that they identify 3 levels of hyperglycemia, 3 levels of hypoglycemia, and the majority of time, that is 70% of the time spent, should be between 70 to 180 milligrams by most of our patients. Then only you can achieve a good glycemic control and prevent long-term complication. In this, you can identify some special population like elderly population, and you can also identify people who are at risk of severe hypoglycemia, and also people, women who are pregnant, where you need to have a very tight control in the 2nd and 3rd trimester. And people who are getting operated, or people who are undergoing major surgeries, they need to recover faster in the post-operative phase. So you need to identify these people as a special population and adjust the time in range so that the outcome is better. Next slide, please. So there is a good correlation between HbA1c of 7% and 70% of your time in range, that is 70 to 180 milligrams of deciliter. 70% of your 24 hours should be spent in that, and each 10% rise in your HbA or fall in your HbA1c gives rise to reduction in the HbA1c. That means if you don't come up to 70%, somewhere if you're 50%, your HbA1c is likely to be much higher and your complications are likely to be more. So that's why you need to identify this in type 1 as well as type 2 diabetes patients, and then correct them accordingly so that you can prevent long-term complications. Next slide, please. So what is the impact on microvascular disease? Next slide, please. This has been again studied in some landmark trials like DCCT. Next slide, please. So if you look at the TIR, time in range, in intensive group was 52% versus conventional group was 31%. So the conventional group had much higher rate of retinopathy, and with a tighter correction as well as increasing time in range, the retinopathy decreased in most of these groups in DCCT. And DCCT is a very old trial, but the same thing can be replicated in our real world practice or clinical practice. Next slide, please. So every 10% decrease in TIR, there was a risk of retinopathy increased by almost 64%. And there is a risk of microalbuminuria as well. That is 30%, 40% increase in microalbuminuria. So that means the time in range directly correlates with your chronic complications. Next slide, please. So does it apply to type 2 diabetes as well? Yes, there is a good association of continuous glucose monitoring with time in range and diabetic retinopathy in type 2 diabetes patient. TIRs were defined as percentage of time spent within the glucose range of 70 to 180 milligrams per deciliter during the 24-hour period. And also these people underwent measurement of fasting blood sugar, HbA1c, and also many of them did 7-point SMBG, but a 7-point SMBG does not cover nocturnal events. And at the same time, the CGMS is an interstitial tissue glucose, but there's a good correlation with the fasting blood sugar. There is a slightly less good correlation with the postprandial blood sugars when it comes to, but overall, it gives you an idea about time in range, much better than what you would be measuring by SMBG. Next slide, please. So even in type 2 diabetes patient, there was a good correlation between the time in range. When the time in range decreased, the diabetic retinopathy was much higher in type 2 diabetes patients as well. Next slide, please. So what about diabetic peripheral neuropathy? Type 2 diabetes patients with chronic kidney disease are always at a higher risk of lower extremity peripheral neuropathy. So these patients were studied, and what they realized, next slide please, what they came into conclusion is that inverse correlation was there with time in range. The people who had good time in range had a much less evidence of progressive peripheral neuropathy as compared to people whose time in range was decreasing as the duration of diabetes and CKD increased. So that's why I think you need to have a good time in range for all these patients with type 2 diabetes and chronic kidney disease. Next slide, please. So what is the impact of time in range on macrovascular complications? Most of the time we are today worried about large vessel disease, that is the angina and coronary artery disease, whether it is single vessel or double vessel, stroke and peripheral vascular disease. So next slide, please. So if you look at carotid intimal thickness, people who had higher time in range, they always had much less intimal thickening and they had much less evidence of stroke. But people who had lower and lower time in range, say 50%, 60%, 40%, they were the ones who suffered from frequent TIAs, frequent stroke, peripheral vascular disease, and amputation and gangrene increased in these patients. Next slide, please. So TIR less than, in a nutshell, what are the outcomes of if TIR is not maintained? What happens in your patient? If TIR is reduced by, suppose the duration of diabetes increases and your therapy is not adequate and your TIR starts reducing by 10%, retinopathy increases by 64%, nephropathy increases by 40%, and neuropathy, risk of amputation, infection, and chronic ulcer increases by almost 25%. So these evidences also show increase in the surrogate markers of macrovascular complications like abnormal carotid intimal thickness, that is the sometimes asymptomatic atherosclerosis likely to progress in all the vascular tree type 2 diabetes patients. Next slide, please. So does improving TIR lead to better outcomes? Next slide, please. I think yes, association of TIR with outcomes following cardiac surgery. That is a major surgery where you want to know if we have a good TIR, more than 70%, whether the outcome will be good. Next slide, please. This was studied in ICU as well as post-cardiac surgery. The range that led to better outcomes was blood glucose of 100 to 150 was found to be safe in diabetic patients undergoing cardiac surgery, and better diabetic or non-diabetic patients with more than 80% TIR, and people with less than 80% TIR. Maintaining the target of TIR in diabetic patients was much difficult compared to non-diabetics. Next slide, please. What happens in range? What happens to the range in patients with pregnancy? Now, pregnancy, type 1 diabetes spend only 50%, 55, 60% in the target range of 60 to 140 milligrams during the first, second, and third trimester, respectively. TIR of more than 70%, TAR of less than 25% are achieved only in the final weeks of pregnancy, which is very dismal figure. So that is why we need to increase the TIR even in pregnancy in the second and third trimester, and reduce the TAR as well as TBR in pregnancy in the second and third trimester. Next slide, please. So what are the key messages from this, the new concept of TIR and the new concept of TBR and new concept of TAR and blood glucose measurement using CGMS and combining that with your HbA1c, either your daytime monitoring, SMBG, or home blood glucose monitoring. If all the data can be pooled, there is a need to go beyond the current established monitoring parameters, targets. TIR stands out as one of the solutions to meet this requirement. Landmark trials like BCCT, when visited, established the importance of maintaining blood glucose in range. Studies done to determine complications with TIR variability indicate increase of risk, macrovascular, microvascular, and deterioration of higher functions. That is basically to say that quality of life needs to be maintained. So evolving evidence indicates keeping patients in time range leads to much better outcomes with present therapy. As Dr. Prasanna Kumar was mentioning about the cost of diabetes treatment, today I think 90% of the money is spent on diabetes complications and 10% is spent on prevention of diabetes complications and proper treatment or diagnostic evaluation or diagnostic tools in type 2 diabetes or type 1 diabetes management. I think that's why it is very important. Next slide, please. So I think that is my talk for the day today. Thank you very much. And if there are any questions, I'll take at the end.
Thank you, Dr. Bargangi, for again emphasizing on this emerging metric, time in range, and the importance and the connect with all the complications. Completely with you, sir, in terms of we need to look more often for time in range and move beyond the conventional metrics. I'm sure, again, we'll have some good discussion and questions on the panel answers as we move ahead. Now we move, can we stop sharing the slides for Dr. Bargangi and we move to the next talk in today's session? Can we stop sharing the slides, please? Thank you. And the next session is going to be taken by Dr. Matthew John. Afternoon, Dr. John. Good to see you. Hi, even though it's virtual. And Dr. John Matthew is going to be speaking on insulin initiation and intensification made easy with the co-formulations. Over to you, Dr. John. Dr. John, of course, is a senior endocrinologist and a good friend from Trivandrum and runs the Providence Endocrine and Diabetes Specialty Center in Trivandrum. Over to you, Dr. John.
Yeah. Thank you, Manoj. My slides are visible? Manoj,
they are visible. Yeah, John, they're visible in the full view mode. Please go ahead.
Okay, thank you. So I'll be speaking, thanks first of all, the ADORE team for inviting me. And I'll be looking at insulin initiation and intensification made easy with co-formulations. So these are my financial disclosures. I speak for Novo in this meeting. And I'll be dealing with this in three parts. One is looking at the core realities of type 2 diabetes management in India. Then we'll be looking at bridging barriers to insulin inertia. What are the reasons and what are the practical solutions? And then we look at how we can use co-formulation in the Indian scenario. So as you're aware, there are various challenges in managing diabetes in India, and some of which is related to our high carbohydrate diets, the high postprandial glucose it produces, some of which is believed to be ethnicity related. We have a large number of patients whom we need to see in the OPD in a very rapid or a very, very short period of time. Most of them are on oral anti-diabetic agents, and we need insulins which can help us to initiate therapy faster. So this is a part of the START study, which was done by Dr. Shashank, and it's very clear that whether you are in a rural area or whether you are in an urban area, and across various places, the east, west, north, or south, close to 60 to 70% of your entire intake, energy intake, is from carbohydrates. And this actually translates to high postprandial glucose. We have data. I'm not going into too much of detail, just to show you, inform you about data. There is an association of high carbohydrate consumption by mortality. So this is basically more related from the PURE study which was done in around 18 countries, follow-up of around 7 years. And there was an increased risk of 17% between the lowest and the highest quartiles in terms of mortality, in terms of carbohydrate intake versus mortality. And we have a host of epidemiological studies like the Honolulu Heart Study, nurses studies, etc., which shows that post-challenge glucose is associated with increased risk of cardiovascular and all-cause mortality. Then there are studies also from South India, from Dr. Mohan's group, showing a higher association of neuropathy, nephropathy, and retinopathy in Indian patients of long duration follow-up. Primarily in this group of patients, the postprandial hyperglycemia acted as an increased risk factor for patients. Now, we also have data from the Asian group showing that in patients who present to us, both fasting and postprandial glucose control is extremely important. Fasting control, as you are aware, in general, it's believed that it is important in patients with high HbA1cs and postprandial in people with lesser HbA1cs. But in Asian population, this doesn't seem to be so. We seem to be equally vulnerable to the A1C seems to be related to both, even at lower A1C and higher A1C levels, which basically brings us to the fact that we need to start managing both fasting and postprandial hyperglycemia from day one. Now, again, I'm not going into too much into the details of why insulin should be initiated and why it's difficult to initiate insulin, but some data to support the belief that we have a different form of type 2 diabetes in terms of the beta cell function and in terms of the insulin resistance from various other categories of patients world over. And this, again, very interesting data showing that when you compare PIMA Indians with the Asian Indians, you realize that be it the basal insulin levels or be it the stimulated insulin levels, that's a post-challenge insulin levels, you can see even at the basal state or in the post 30 minutes of insulin stimulated state, you can see that be it normal, impaired fasting glucose, impaired glucose tolerance, or combined group or diabetes, whatever it is, there is an insulin deficiency which happens early in the course of diabetes in people of Asian ethnicity. And to start insulin is sometimes a difficult task. I think as we have improved insulins over a period of years, we are now finding it more easy to initiate insulin. But remember that there are various factors which cause psychological insulin resistance, both for the patients as well as for the doctors. To this esteemed crowd of physicians, I don't need to explain many things, but I think all of us have evolved our own techniques and methods to how to help patients initiate insulin. In a study which looked at what really helped patients initiate insulin, because this is one of the few studies by Polonsky's group which looked at what helps patients initiate insulin. What has been shown is that when you demonstrate insulin process to the patient and show that it's an easy thing to do, especially when you do it with devices like pens, when you explain the benefits of insulin in terms of both the glycemic control and also in terms of the reduction in complications, or when you do a collaborative style of explaining the need for insulin, these are the factors which patients really appreciated in terms of starting insulin therapy. And what was not effective is an authoritative, forcible style of starting insulin therapy. So if you look at this, you would realize that using insulin as a threat to initiate for poor glycemic control is probably not the best way to do it, but rather collaborative style, a sort of reaching a sort of consensus with the patient in terms of insulin initiation. Maybe not this visit, maybe next visit, let's try sort of deals with the patient. All these things will work in terms of starting insulin for this patient. Now coming to the co-formulation part of my talk, how to individualize insulin therapy to Indian realities. So this is the case, a case which is very common in our outpatient department. This is a lady who is 54 years with the chief complaints of burning sensation and numbness of the feet. She's been having diabetes for 8 years. She's got hypertension, and BMI is not too high. It is around 22 normal body weight. You can see the fasting and the postprandial glucose 164 and 198. And you can see the post-dinner glucose, which is quite high, that is 296, and an A1C of 9.3%. You can see the blood pressure is fairly good. The creatinine is 1.0, which turns to an eGFR of 62. The patient is on metformin, vildagliptin, and gliclazide. Now, when you look at injectable options for this patient in this scenario, we should realize that we are dealing not only with insulin, we need to deal with other injectable agents like GLP-1 RA. We also need to realize that all patients are not the same. Things in terms of the costing of the molecule, in terms of what the molecule can control in terms of fasting or postprandial or both, things like this play an important role in choosing the insulin. So which patients would you like to move to insulin and which patients would you like to move to GLP-1 RA? The general guidelines of type 2 diabetes, even the 2021 ADA practice guidelines, says that GLP receptor agonist is probably the first injectable if patient can use it. When we need to divide patients on what fits to which patient, you can realize that when you have obesity or overweight, presence of atherosclerotic vascular disease or diabetic kidney disease, then GLP-1 RA score over insulin in terms of the benefits. When it comes to patients with extreme hyperglycemia, especially those with catabolic state, those with ongoing diabetes complications, especially retinopathy, patients with low body mass index, people who find it more difficult to access GLP-1 RAs, or people with gastrointestinal issues should probably use insulin as the first injectable. And when it comes to insulin, again, we have different choices. We need to choose whether we want to go for a basal insulin or some sort of an insulin which has got both basal and a prandial component to it. So that is either basal insulin or looking at premixed insulin, premixed analog, or a co-formulation. Now, most of us use all these molecules in our clinical practice based on patient characteristics. And just to make that differentiation between the IDEG-ASP, that is Rysodeg, versus BiASP, that is the Novomix, the difference is in terms of the long-acting insulin which we have. The Digludec is the one with the co-formulation. Protaminated aspart is what we have in the Novomix. And if you look at the PK/PD characteristics of these molecules, you realize that Digludec has got a very consistent action with less of variability across 24 hours. This is not the case with protaminated aspart, which has got a higher variability in comparison to Digludec. And if you look at the pictures, you would also realize that the shoulder effect, which is seen in Novomix or BiASP, is actually not there in IDEG-ASP. So the presence of two analogs bringing the best of a short-acting analog and a long-acting analog, which does not mix together in the pre-filled syringe, the pre-filled cartridge, makes all the difference in between the two molecules, IDEC, ASP, and BiASP. Now, if you look at studies which looked at Novomix versus the co-formulation, studies have been done in both insulin-naive patients and non-insulin naive patients converted from basal insulin. You can see that in the insulin-naive patients, there are studies which started with a basal A1C of 9.5% over 26 weeks, final A1C 6.5% in both the groups. There's no difference. But with a better fasting plasma glucose reduction in the Rhizodeg arm, with lesser risk of confirmed and nocturnal hypoglycemias in the Rhizodeg arm. When it comes to patients who were on basal insulin getting converted to Rhizodeg, realized that again, 661 patients, longer duration of diabetes, 13 years, from a baseline of 8.4% coming down to an A1C of 7.1%, and better fasting plasma glucose reduction in the Rhizodeg arm, IDEG ASP arm, lesser insulin dose in the IDEG ASP arm, and reduced number of confirmed and nocturnal hypoglycemia. So putting both together, to sum up both the studies together, you can say that in comparison to BiASP, biphasic aspart, you are able to bring down glucose to the similar extent with lesser risk of hypoglycemia when you use IDEG ASP. Now, I don't need to explain too much about the difference between basal insulin and co-formulations. When you have co-formulation, you deal with both the pathophysiology, both fasting and postprandial glucose. You could use it in patients who are having a higher A1C, baseline A1C, and still bring them to target. That means if your insulin initiation is delayed, in like you have in a typical patient, it's a simple initiation, simple titration strategy. It is good for both intensification and initiation with the same device. So that is the advantage of using an Rhizodeg over a basal insulin. Now with the new guidelines from the RSSDI ESI, you are also allowed to start with once daily Rhizodeg in patients if the patient is already on 3 oral glucose lowering drugs. So Rhizodeg can be considered as one of the initiator insulins in patients with type 2 diabetes. Just to put evidence to whatever we are just talking, this is the Onishi study. These are insulin-naive patients in Japanese studies, where patients who are insulin-naive and on oral glucose lowering agents were randomized to receive Rhizodeg versus glargine, 147 patients versus 149 patients. Over 26 weeks, the Rhizodeg arm had, and the glargine arm had almost similar fasting plasma glucose control, but a marginal improved HbA1c in patients who are using Rhizodeg over patients who are using glargine. And if you look at the overall 7-point SMPG profile, you would realize that in the meal, prior to the meal, which you give the Rhizodeg, the combination drug, the co-formulation, you have a reduced postprandial glucose. So just like the patient which we just showed who has got a high the post-dinner glucose, using a co-formulation prior to the dinner can help bring down the postprandial glucose. Now coming to the safety aspects, there is overall lesser risk of overall confirmed hypoglycemia, which did not achieve statistical significance, and overall lower risk of nocturnal confirmed hypoglycemia, again, which did not achieve statistical significance. So to sum up this part of the talk, you can say that co-formulation of aspart and digludec is able to bring down A1C similar to that of glargine, better A1C control with lesser risk of hypoglycemia. Now, when it comes to intensification of co-formulation, you started a patient already on a co-formulation. How do you go further? The patient is not getting controlled. You have 3 months of therapy. Your A1Cs have come down from say 8% or 9% to 8%, but still you need to intensify further. What do? You got different options. You could increase from a once daily co-formulation to a twice daily co-formulation. That is probably the best method of intensification of patients who are already on co-formulation. The advantage is to use the same pen, the same insulin which the patient is familiar with, and then just make it twice daily. And again, you are not controlled. You can continue to make it either a basal bolus insulin or still keep the twice daily Rhizodec going and add a prandial analog. There are, of course, other methods of intensifying patients who are on co-formulations. That means to convert them to a basal bolus regime. Or you could also keep the co-formulation and consider using additional prandial insulins for the lunch and dinner or the other 2 meals which are not covered with the co-formulation. Do you have studies to prove it? Yes, we do have data to support that in patients who are already initiated on IDEG, ASP or OD versus glargine and 1 dose of aspart. When at the end of 26 weeks, if you did not reach an A1C of 7%, you could intensify the patients. So 2 forms of intensification was considered, whether you can move to twice daily co-formulation versus a multiple dose of short-acting insulin and glargine to be continued. So we are all aware that basal bolus insulin still stands the test of time as the best, or rather the gold standard in terms of insulin intensification. But if you look at the data for twice daily co-formulation with a basal bolus insulin, you can see the A1C control is almost the same. The fasting plasma control is almost the same. The confirmed hypoglycemias are less with the use of co-formulation, and the nocturnal confirmed hypoglycemias are significantly lower with the co-formulation. So you are basically able to use a twice daily Rhizodec and reach the near normal A1C targets at par with the basal bolus insulin therapy with less risk of hypoglycemia and less number of injections. So IDEG balances efficacy and safety with the convenience as compared to a basal bolus therapy. Now, just to put 2 or 3 slides in perspective regarding the main meal concept, Rhizodec is given prior to the main meal, that is the current recommendation. The main meal could either be the most carbohydrate-rich meal, or it could be the meal which shows the highest postprandial excursion based on your glucose monitoring. So always remember that, but most of the time for compliance reasons, we tend to use Rhizodec with breakfast. It is acceptable to use with lunch or dinner, whichever is your major meal. Now, how do you initiate? You initiate at 10 units daily. You gradually increase the dose based on the fasting plasma glucose. You decide a plasma glucose target for your patient based on the risk factors of hypoglycemia and the age and other comorbidities, and you titrate insulin to reach that target. If your patient is already on basal insulin and you want to move him to a co-formulation, when do you start doing it? When your patient reaches a basal insulin dose of more than 0.5 unit per kg or approximately 40 to 50 units of basal insulin, you can always consider using the patient, putting on the patient onto a co-formulation. So you could start at 1:1 for a patient who is very badly controlled, or you could reduce. So if your primary aim is to convert a basal insulin to a co-formulation because of postprandial hyperglycemia, you could start at a lesser dose than going into a 1:1 conversion. And when you're doing it from a premixed insulin to co-formulation because of an increased risk of nocturnal hypoglycemia with the premixed insulin, you could start at 80% of the doses. This is the general recommendation. Titration, again, you can follow a titration schedule of +2, -2 based on your targets which you set for the patient. So these are the one I'm just showing you right now is the target which is generally mentioned in literature. And for twice daily IDEG, you could use the fasting sugar when you use once daily, and you could use the pre-breakfast and the pre-dinner sugar when you're using the twice daily IDEG-ASP. IDEG-ASP is available as a pen fill or as a flex touch device, which is one of the advanced pen devices in the market with very low dose force and very consistent dosing and easy touch button. To summarize, postprandial hyperglycemia remains a concern in a significant number of patients with type 2 diabetes, especially from India. And high carbohydrate diet is a major risk factor. Studies have shown, mainly epidemiological studies have shown a link between cardiovascular mortality, total mortality, and high postprandial or post-challenge glucose. And use of co-formulations can help both at initiation and intensification of patients with type 2 diabetes. Thank you very much.
Thank you, Dr. John, for enlightening us again on co-formulations. And again, I'm sure and I'm expecting some questions on people getting more clarity on this aspect, especially options for intensification. We move on to the last talk in this session before we open up the entire session for question and answers in the panel discussion. It gives me great pleasure to welcome Dr. G. Vijay Kumar, who is a consultant diabetologist at the Apollo Specialty Hospital, Chennai. Dr. G. Vijay Kumar will be speaking now on the shift to SWIFT, which is towards physiological mealtime glucose control. So this is going to be taking a whole circle about completing all aspects of insulin therapy. We've had co-formulations, we've had basal insulin conversations, and now Dr. G. Vijay Kumar will complete the circle with prandial insulin options. Over to you, GVK. Dr. GVK, you can go ahead and share the screen.
Yeah, I'm sharing.
Perfect.
Good evening. Good evening. Thank you, Manoj. I'm giving the opportunity. Thanks, Arvind, Dr. Prasanna, Sanjay, everybody for giving this opportunity. Today, I'm given the task of discussing about the shift to SWIFT towards physiological mealtime glucose control. That is the one which has been given. I would like to say that this is actually a sponsored talk by Novo Nordisk. The meeting objective of the day is going to be a practical reality in Indian hospitals, what is happening, and understanding the clinical importance of postprandial hyperglycemia, which is a more important factor as far as India is concerned because of the dietary habits that we have. The postprandial blood glucose is a greater problem in country like India, generally in Asia, where the rice eating or the carbohydrate intake is very high. And obviously, we can simplify the treatment with a further fast-acting insulin, short-acting insulin log better than aspart that we have, one of the best short-acting insulin analogs that we have. Now, as part of my first part of the talk, if you can see that, if you look into the causes of death in inpatients with diabetes, you can see vascular deaths are major, and next is infection. This is a reality in India. Vascular disease and infection, and renal failure and malignancy also will contribute to the mortality in the hospital. If you look into that, about 8.2% of diabetics do get inpatient admissions, and there is 5.6% of inpatient mortality. The most important thing is mortality compared to non-diabetics is about 48.3 per thousand in diabetic, whereas it is in non-diabetic, it is 23.4 per thousand. It is almost more than double mortality the moment you have diabetes. So it looks like in Indian setting, hyperglycemia is in critical and non-critical care is also the adverse outcomes and increased mortality. Now, there are some other problems very specific to India. If you can see, the WHO recommends that we should have a doctor in every 1,000 population, but we have only 0.09 of government doctors in India. Even if you add up the private sector, I don't think it will reach 1:1,000. And so what happens is that the burden on a doctor is also going to be very, very high. It's going to be very, very high. And then the time that is spent with the patient is also quite low when it comes to a practice in India. Similarly, even the nurses. In fact, if you can see that we are short of nearly 2 million nurses in our country. And then it is also said that in one study, Emma Johnson, we can see that in BMJ Open, it has been published. You can see that a higher nurse to patient ratio is linked to a reduced risk of inpatient death. That's what this study has found out. So I think beyond glycemic control, these are also things that we need to look into that. As far as a postprandial hyperglycemia is concerned, you know that in the right side of the screen, you could see that compared to the Western population, say like Canada, Poland, European countries, if you can see, the the PPG levels are going to be far higher than what we see in the Western population. This is basically because in our country, we can see that in the left side of the screen, if you can see, the 76% of the calorie the intake comes from carbohydrates in rural area, and it is no inferior to rural area, even in urban area, it is 71%. The recommended usage of carbohydrate in a diabetic is going to be 50 to 55% and not more than that. So in general, Indian population takes more and more of carbohydrate, and no doubt why India has got a higher PPG levels compared to what we see in the other countries, the Western countries. Because if we can see in the Western countries, only 40%, less than 40% is contributed, the calorie intake is from carbohydrates. So naturally, the postprandial blood glucose is going to be far less compared to what we have in India. Now, it is very interesting to say that, about 10-15 years ago, we used to talk very nicely about the Monnier et al. You can see the left side of the screen, the Monnier et al. If you can see that when HbA1c is very, very high, the contribution to the HbA1c by the fasting blood sugar is about 70%, and it is 30% by postprandial blood glucose. And if you can see that as the HbA1c comes down, you can see that to less than 8, if you can see that the contribution from fasting comes down and postprandial increases, and it comes to 7, close to 7. We can see that 70% comes from postprandial and 30% only contribute from fasting blood glucose. What is it we need to understand from this is that when the HbA1c is lower, what we need to understand is that we cannot keep on counting on the fasting blood glucose, whereas, in fact, if you do that, you will end up in nocturnal hypoglycemia. Instead, if you, as the HbA1c comes down to less than 8, and you want to bring it down, we need to concentrate more on postprandial blood glucose so that we can achieve the target of less than 7 without considerable hypoglycemia compared to what if we can address only the fasting blood glucose. So this is a very, very important lesson that we need to learn. But the surprising thing is that in the Asians, it is a different one. You look at the HbA1c, higher HbA1c, say like more than 10. If you see that, on the right side of the screen, the last bars, if you can see that in the right side, if you can see that the contribution from postprandial, even at the higher HbA1c, is almost 40%, 45% to 50%, almost equal to the fasting blood glucose. And as it comes down, if you can see that HbA1c, and more because of postprandial compared to HbA1c. So the scenario changes when it comes to Asian countries, especially in India, where the carbohydrate intake is very, very high. The contribution to the HbA1c, both at higher HbA1c and lower HbA1c, is going to be very significant. So it is not that, in India, we have a role to play to say that we need to address the postprandial even at higher HbA1c. Whereas on the left side, Monnier et al., we just say that fix the fasting first, right? We fix the fasting first. So if you have higher HbA1c, fix the fasting first. It may work out in India. It's not that it doesn't work out, but there is a role for addressing postprandial even at higher HbA1c. That's what I would like to say that. Now, what is optimum PPG control? Is that is one of the studies, the Gonzaga diabetes study, where he has followed it up for about 5 years, about 500 people with type 2 diabetes, men and women. At the end of 5 years, 77 CV events for 5 years, and long-term follow-up of 14 years confirming the evidence. And it has been found that postprandial blood glucose is a stronger predictor of cardiovascular events than fasting blood glucose in type 2 diabetes, particularly in women. So this is what they found. No, it has been known, even in the San Antonio study way back in 1990s, it has clearly said that postprandial hyperglycemia is an independent risk factor for cardiovascular disease in diabetes. That is known for us. We know that. Now, that is 2 hour postprandial blood glucose. Now, how about 1 hour postprandial blood glucose? Is there any importance to that? If you can see that, The 1 hour postprandial is a stronger predictor of developing type 2 diabetes to 2 or BPG. This is what they have been found from several studies like Paris policeman study, and so many other studies when they followed up with a 1 hour GTT, 50 gram GTT is 1 hour value. What they found is that those who had a higher, they are not diabetics, those who had a higher post glucose or postprandial glucose definitely had a higher incidence of cardiovascular disease in the later part. They followed it for 25 years or so, and so many other studies, including decode study, it has been found to be the same. So the endothelial function seems to be worse at 1 hour than at 2 hours. So this is what the conclusion from the one study that Antonio Cirillo study. We can see that targeting 1 hour post-meal glucose. Is it time for paradigm shift in diabetes management? This is a question is raised. Now, as far as India is concerned, Dr. Mohan et al. Have done a study, and they have found that from the starting of the food, because of the carbohydrate intake in Indians is very, very high, it is not at 2 hours, which is maximum. It is at 1.5 hours from the starting of the meal. And at 1 hour itself, we can see the peaking of blood glucose happening, even in India. So it is more relevant for where Asian countries where the carbohydrate intake is higher, as we discussed. Now, 1 hour postprandial hyperglycemia, like 2 hour postprandial hyperglycemia as well, can cause these problems, like higher triglyceride levels and impaired triglyceride HDL ratio, upper B levels, increased arterial stiffness, like any other thing. Endothelial dysfunction happens because of postprandial even at 1 hour. Now, if you see that the recommendation by ADA says that 1 to 2 hours, IDF says 1 to 2 hours from the starting of the meal, but AAC and CDA, there is Canadian Diabetic Association, says 2 hours. So both ADA and IF suggest that targeting PPG after 1 hour from the start of the meal is a good idea. Now, how is it we can simplify with a fast-acting insulin? See, insulin aspart itself is a fast-acting insulin analog, and we are trying to improvise it, is still making it faster. That's called FIAST. Now, there are certain practical challenges in patient during insulin management. There will be inappropriate timing of short-acting insulin with regarding to meals, and decreases in appetite or calorie intake. And a sick person may sometimes take food, may not take food. And then what I see in the hospital is that when they're especially sick, we can see that suddenly they may go into nil peroral status, especially when they're planning for surgeries. And acute illness will cause further hyperglycemia because of the stress hormones. So these are some challenges, and basically, and the timing of testing, and the ability of the nurse who is there, whether she's trained or not to do appropriately. All those things are challenges that we see in the hospital. So what happens is that in spite of challenges, we should be able to manage this blood glucose with minimizing hypoglycemia with an appropriate insulin. That's what we have to think about. That is any insulin which can be given more conveniently, depending on the food intake that they have taken or not, and which is very short acting, so that even if they go to NPO, they may not go into hypo as like what we get with intrameal hypoglycemia with regular insulin. Not achieving glycemic control during the acute illness, all of us know that can cause decrease in immune functioning and increase oxidative stress and inflammation. Now, conventional rapid-acting insulins and their current challenges is timing of injection at to meal time, and as I said that fear of hypoglycemia. Many patients will say that I'm worried about the hypoglycemia. Even the doctors on duty on roll there also have this issue, and the speed at which the insulin acts also may have a good challenge for the now. If this is if suppose somebody takes food, and then this is the way normal pancreas reacts and insulin at a meal time, they secrete at the meal time. Suppose you take a regular human insulin, you can see that peak happens long after because the pharmacokinetics are such that it goes to the peak around 3 to 4 hours regular insulin, whereas the postprandial peak is around 1.5 hours or so, what we have discussed. So we have to give this insulin at least 1 hour or 1.5 hours prior to the meal, and which may be very, very difficult to do, both even outpatient as well as inpatient. It's not possible. So we had all these years, almost for 20 years, we had a rapid acting insulin, like one of the insulins which have been widely used is aspart. We can see that it is closer to, compared to human regular insulin, usually the peaking is very high, it is closer to normal pancreatic secretion of insulin. But whereas now you got a improvised version of this particular aspart insulin, which you can see that which is still further closer to the normal pancreas secretion, so that it works more physiologically. In fact, all these years we have been talking about rapid acting aspart is physiologically working. It is further physiologically working. This is the beauty of insulin. You know, there are so many improvements and inventions are happening. No doubt why insulin has got already 3 Nobel Prizes. We don't know how many more we are going to get in insulin. So this is importance of insulin. You know, the tremendous improvements in insulin pharmacokinetics and analogs have really changed the revolutionized the treatment, and then also improve the quality of the patient, because no intermeal hypoglycemia and mealtime hyperglycemia are to a great extent reduced with least hypoglycemia and weight gain as well. So these are the things that the developments in insulin therapy have really helped us. So the ultra fast acting insulin should better approach physiological insulin secretion, closer to that, replace early insulin secretion defect in type 2 diabetic, and help control postprandial glucose better, and have a better profile for pump therapy. So it should be there. Now let us see how it works. We can see that if this fast acting aspart compared to the conventional aspart insulin, we can see that it starts at 5 minutes earlier than onset of action is 5 minutes earlier than the regular aspart. That is number one. And the most important thing is that it has got a better action at 1 hour, right? 1 hour to 1.5 hours. We can see that it starts working at 30 minutes itself. And so that at the time of 1 hour, you got a better control of postprandial blood glucose compared to regular aspart. 1 and 1.5 hours, you can see that. So the clearing of the postprandial blood glucose, even at 30 minutes, is also better assured with faster acting aspart. So there is more than 74% greater glucose lowering effect within the first 30 minutes. So the twice as fast onset of appearance in the bloodstream of the fast acting insulin aspart. So it is definitely area under the curve improves, and then it is going to be faster acting, and the onset of action is faster than the regular aspart. Now, always we need to depend on the various evidences that we have, and there are several studies that are being that faster onset aspart in the name of onset 1 to 9, 1 to 9. Of course, 6 is not there. We can see that this has been a good insulin. If you can see that both in type 1 diabetics and as well as type 2 diabetics. And the total number of patients from India in onset programs is about 132 subjects in phase 3A, and phase 3B is about 162 subjects. Now let me go through the first study, that is onset 1 trial design. If you can see that this is basically in type 1 diabetics. Here they have taken into 300 and close to 400 patients in each arm. Faster aspart at mealtime plus insulin detimer, or even glargine. There has been glargine also has been there. And then insulin aspart at mealtime, that is regular aspart, conventional aspart with basal insulin. And then there's one more arm which said that whether if we can, the faster aspart can be given post meal along with basal insulin post meal. So this is a interesting thing. So the inclusion criteria includes about type 1 diabetics, male and female more than 18 years. They should have been already on basal bolus therapy, and then either they should be on detimer or insulin glargine. HbA1c is between 7 and 9.5, BMI is less than 35. And key endpoints in this study are going to be the number of hypoglycemic episodes, if at all. Is it going to be better with faster acting aspart? Is there any difference? And the number of treatment emergent adverse events. Change in HbA1c from baseline at 52 weeks, is it there? And how about the postprandial blood glucose? Is it able to control better than the regular aspart? And also the weight change also has to be looked into that. An additional 26 weeks treatment period was included to further document long-term safety and efficacy. Here what you should understand is that first 2 arms are double-blind, and then the faster aspart that has been given after meal is an open label. That is on the type 1, and we'll come back to the results after looking into one more that is onset 2 in type 2 diabetic patients. Here you can see that those people who have been on basal bolus therapy, you can see that they should have been on insulin glargine or detimer and NPH, and then also on metformin. And then you can see that HbA1c should be 7 to 9 and BMI should be less than 40. And key endpoints in this, if you can see that HbA1c, so that is better effect of HbA1c with fast-acting aspart, 2 were postprandial increments in body weight, number of treatment emergent hypoglycemic episodes, number of treatment emergent adverse events. Now, if you look into that, both onset 1 and type 2, first let me finish the onset 2, where type 2 diabetic, there is a similar reduction in HbA1c between faster aspart and insulin aspart. So that is non-inferior to each other. Now, in the type 1, if you can see that, there is a slightly better HbA1c, that is 0.1% reduction with mealtime faster aspart compared to conventional aspart. The same thing has not been found when it is given after meal, but the difference is not great. But definitely there seems to be a slight edge with in a type 1 diabetic with faster acting aspart.
GVK, sorry, we'll have to wind up in a minute or so.
Yeah, sure. And then if we look at that evidence from phase 3 clinical trials, definitely it is faster acting aspart has been beneficial at the 1 hour, definitely better. So in the pooled analysis as well, though there is not much of a difference in the diurnal this thing, but as far as the nocturnal hypoglycemia is concerned, there is a 16% significantly reduced lower risk with fast acting aspart. Similarly, onset 9, if you can see that, with the faster aspart, there is a superiority to 1 hour confirmed, like what we have seen in our study as well as been found. So also there seems to be significantly lower risk of overall and nocturnal hypoglycemia with fast acting insulin aspart compared to conventional aspart. Even the hypoglycemia, it looks like that significantly lower risk of late, that is in between meal or late postprandial hypoglycemia, or far less with fast acting insulin aspart with regular aspart. So in summary, if you can see that it is faster and effective, it is safer, and it's also flexible to use because you can use it even after food. That is the fast acting insulin aspart. And to end my say, we can see that fast acting insulin aspart is rationally designed to closer approach the physiological mealtime insulin action. Fast acting insulin aspart is an ultra fast acting insulin with a better pharmacokinetics compared to conventional insulin aspart, and definitely it has demonstrated improvements in PPG and also reduced nocturnal hypoglycemia. Thank you for your patience.
Thank you, Dr. GVK, for enlightening us again on the prandial insulins. I believe all the speakers are now here with us for the panel discussion, and would again remind everybody who's joined in to send us your question through the chat box, and we'll be happy to take all those questions. So we start with the questions coming in. The first one, I'll give the question to Dr. Prasanna Kumar, sir. Any biosimilars of glargine in Indian market presently, and probably the cost difference? So probably they missed hearing your talk, and that's why this question has come in, or haven't understood. And again, asking the question for you to clarify about the biosimilars available in the Indian market and their costs, sir.
There are 3 biosimilars to glargine. First one is Basaglar, and the second one is Glaritas and also Basalar. From 3 pharma, they are there. The cost difference is about 20 to 30%. Let us say the virginate is about 720. One of the biosimilars are about 600 or not, another is about 550 or so. So 20 to 30% cheaper compared to originals as such.
Right. So till we await the other questions, I'll take the opportunity and the pleasure of posing more questions, and would also invite from the other panelists from the primer group and the organizers who have joined in. So, Dr. Prasanna Kumar, sir, very often the question asked is, and as you showed the data, the companies making the biosimilar insulins, of course, their investments in doing the studies required for biosimilar regulation and the cost that goes in coming out with the biosimilar insulin is much lesser. I'm not sure what is the percentage between a company innovating an insulin right from the early phase studies as compared to somebody who's doing a biosimilar registration. Having said that, one would have expected the cost of biosimilar insulins and the advantage to be given to our patients to be a much higher difference than the 20% that you spoke about. Your thoughts on that, sir?
See, if you look at a new molecule, one of the major companies in the world, insulin manufacturer, I had been to their original place. It costs $250 to $350 million to see that a product comes to the market. That too, at that time, that was somewhere in 95 to 96 when we saw, they said they will screen 10,000 molecules to see whether there is any efficacy, safety, potency. Out of 10,000 molecules, 90% die in the first phase. Then you have phase 2, phase 3. By the time the molecule come out of 10,000 molecules that they screen, hardly 2 or 3 molecules were coming to the light as such, are marketed. So that way it's a huge cost. If you look at the molecule which is a biosimilar, you already know its safety, efficacy. You don't have to do much research at all. You just have to do minimal studies, maybe PK/PD studies, I said, then a small number of clinical trials as such. The cost is almost 1/100th of what you spend. Maybe if you see $200, $300 million, you don't need even $5 to $10 million or even less than that to come out with a molecule. And that is why even the multinationals like Lilly and all are going into biosimilars because it's a gamble. Many companies have closed down because there was no drug in the pipeline at all. They invested huge amount of money in research. Take India, 75 years. We have hardly not maybe one handful of molecules, which we say probably that we have we have got the original assets selling. Even that too is not a global market as you see. So a country like ours cannot afford to have original molecule. In fact, many original research companies who were there 10, 20 years back, some of them even winded up here in India and they have gone back also. So it is a gamble and it's not an easy task. People think it's very easy to find new molecule. It is not so. But I'm sure in next 20 years, India and China will have many of the new chemical entities, unlike in the past because of technology, people involved in research, affordability of research money they can put. That's why it's a game changer. But if you have, it's a proud thing and you get 10 years investment in 1 or 2 years because some of the molecular gliptins had made $4 billion within 1 year itself. So you can imagine that the amount of money you invest and the returns you get, there's a huge gap. And now there is patency right for 7 years. So you 2014 or 15, the glargine patent range has gone. Suddenly you see all the companies are coming. This is how the whole economics of a new chemical entity and a biosimilar.
Thank you. Thank you. We'll take the next question to Dr. Badgangi. Dr. Mohan, sir. So that was again a wonderful talk on time and range, again enlightening and spreading the message about doing time and range more often. There are some questions which come to mind when we talk about spreading the message on TIR. One, clearly the newer recommendations talk about what are the time and range and the different categories, be it for type 1, type 2, the elderly and the pregnant. However, what is lacking, and this question is very often asked, what should be the frequency, especially in the Indian context, if at all, for us to start looking at time and range? And are there differences? As we look at the other metric for HbA1c today, we know that there are ethnic differences in HbA1c. The target of 7 has been amalgamated, but if you see, there would be actually differences in the HbA1c, which is the normal HbA1c for an Asian individual as compared to a Caucasian. So are the time and range studies really applicable to our Indian population in the fact that there's dearth of actual research on TIR in India and the frequency of testing for the same?
I think the concept of TIR is quite applicable in India, and it is a very useful tool, and it shouldn't be so much difference in terms of validating for our population, because it is the numerical value of 24-hour glucose values spent by a patient in terms of so many hours. So I think that should not really, but how well it will correlate with HbA1c or 7-point or 6-point SMBG, that only the clinical studies will tell us. But the more burning problems in India is how often can one afford to do it? And we will have to be more selective in doing CGMS itself in our patients. We may have to select those who are on multiple dose insulin, those who are at a very high risk of hypoglycemia, who have frequent hypoglycemia, say for example, people on steroids who have hyperglycemic crisis, people who have a seizure disorder who are likely to endanger their life. These are the patients, and plus, of course, the pregnancy, when there is a difficult pregnancy or after difficult conception, somebody has conceived, and you want to be very careful. So these are the patients, especially in type 1, who have already developed complications because of their strong family history. So these are the other associated illness. These are the patients that you will have to be very selective in our country. And the cost factor is, who is going to bear the cost of CGMS? Is somebody going to fund, or is it going to be completely free, not so free? These are the big question marks that will come up very soon. But if you look at if it can prevent, if you can use time in range, and if you can curtail the cost of treating diabetes complications, I think it will be worth it.
Thank you, sir. Yeah, I think that continues to be a dilemma. And in fact, not only in India, even when you look at the ADA, the current position statement which came in, nobody's yet speaking about the frequency. I can see Bansi has joined in and he's been working with the ATTD group. Bansi, any thoughts on the frequency before I move to Dr. John and Dr. GVK? On the frequency of TIR, do we have any thoughts on how often it should be done?
So in a type 2 diabetic patients, Manoj, there is no frequency of, even we don't know what is frequency of even self-monitoring of blood glucose also. For type 1 diabetic patients who are on multiple daily insulin injection or on a pump therapy, the preferably they should be on continuous glucose monitoring continuously if we can get their time in range. And if we can get their time in range more than 70% of the time, if they are in time in range, probably whether they need A1C or not, that is also not very clear, because if somebody is achieving a good time in range, there is no need for even A1C to be measured for them. But for type 2 diabetes, we don't have any guideline that how frequently they should do the continuous glucose monitoring. But again, it has to be an individual decision or individualistic approach also for that.
Sure. So HbA1c will continue to be extremely relevant, and like what we see, the TIR through an CGM will probably be done in some patients once in 6 months or once a year in India, again depending on the rural-urban setup and the affordability. Let me take the next question to Dr. John Matthew. John, again, an excellent talk on the co-formulations, and which seems to be a good enough option for intensification for insulin therapy. The question often again asked by many physicians is, does this come as a benefit in terms of the reverse role for patients who are on multiple daily injections, be it thrice daily or 4 times daily? You think there are clinical evidences that you reverse them back to 2 shots of the co-formulation and they will do well?
Manu, it's a good question, but I don't think I have an answer for that. I'm not aware of any trials where they really did the reverse and found out that is equally good. But I think there are patients, say, example, who come to us on basal bolus insulin, especially the older group of patients who are reasonably well controlled but quite old, multiple comorbidities. So for them, a quality of life issue is the number of injections that you take every day. For such patients, I think it's always worth a try. And we also do it even with, not even with co-formulations, we even do with the Novomix sort of premixed analogs also. Someone who is on basal bolus therapy after a cardiac surgery comes back to you after 3 or 4 months, wants to get converted to a twice daily regime. Change it and see. I think it's only a trial and error and finding out whether it suits that particular patient.
Sure. What is also interesting, John, that when we talk about insulin therapy in patients with stage 4, stage 5 CKD, including patients who are on renal replacement therapy, in India, we traditionally have been trained to think more about prandial insulin as an option because shorter the insulin, it's going to be better. You see the data from the West, and they'll advocate the use of basal insulin as the first choice for renal patients. Do you think co-formulation as a mixture of the two could be an option in renal patients?
Yeah, I think one advantage is that both aspart and degludec, they are not much affected. The PKPD characteristics are not much affected by renal dysfunction, even at lower levels of EGFR. It would be a good option, but always, I think my perspective is that I would usually, based on the self-monitoring, will go either to a basal or a prandial and then add on the other. I usually don't use it in that scenario. But I think definitely the theory says it can be.
It's some thought-provoking stuff, right?
Yeah.
Thank you. And finally, we move to Dr. GVK for his presentation on prandial insulins. GVK, every time we have a short-acting insulin come in, the data tries and shows that this is getting more physiological as compared to the prior one. And then sometime in the future, we'll probably have another one which is as still closer and faster acting. However, there continues to be some dilemma about the time of injection. So when aspart and lispro came in, they said, the 15 minutes is good enough for this before, or you could give it just before the meal. And then, of course, data by Satish Garg and others showed that no, even those insulins actually need to be given 20 to 30 minutes before. So you think in terms of time, the data that we see, is it really applicable clinically, or this keeps changing? And what is the right time to use the prandial insulins?
You mean to say the insulin analog, right? Okay. I mean, I
Yes,
think
yeah.
the data here shows that we need to give it at least 10 to 15 minutes earlier. We are dependent on what the data that has been given to us to speak, and that's a problem we are facing. And even if you see the fast-acting insulin analog, it is just 4.9 minutes faster acting than the regular aspart. That is one thing. Second thing is that there seems to be some slight benefit over aspart because of the 30 minutes period. It is able to clear the blood glucose much better than the conventional aspart. These are the two things. Apart from that, you can see that both fast-acting aspart and regular aspart, both are cost is the same. This is one good thing. So definitely, if given a chance and the cost is not an issue, probably we can take the fast-acting aspart because it is slightly 5 minutes earlier, closer to physiological insulin.
Sure.
Otherwise,
I'll just quickly dive into another question before a minute that we have to conclude. You think in some patients, the faster-acting aspart is a disadvantage as compared to aspart because the action does not last till the next meal? And then these people have better postprandial but a higher pre-meal sugar.
No, I think the duration of action is going to be the same for both faster acting as well as the regular aspart. There's not much of a difference. Only thing is that the intraprandial hypoglycemia seems to be lesser with fast acting aspart compared to, because most of the insulin is acting in the first half an hour to 1 hour, but it is persisting. But intrameal hypoglycemia is much better than what we have seen in the regular aspart. That's the only thing. Probably the drug would have been cleared by then, but the duration of action is supposed to be the same for both.
Sure. Thank you. Thank you, GVK. And let me take this opportunity to thank all the speakers for those wonderful presentations in the Insulin Symposium. Dr. Prasanna Kumar, Dr. Mohan Badgangi, Dr. John Matthew, and Dr. G. Vijay Kumar. Thank you so much for your lectures and the panel discussion. I hand it back now to Bhavna and Dr. Arvind to take this ahead. And thank you once again for inviting me to share this session.
Thank you.
Thank you all once again for joining us for the Insulin Symposia. So we will now play a small presentation from our end to thank all the sponsors of ADORE 2020.
Thank you, IT team, for this wonderful presentation of the sponsors, whom we thank from the bottom of the heart. And then the next session, Dr. Sanjay Agarwal is supposed to come and chair the session, but Dr. Sanjay Agarwal must be busy with whatever he's been doing in probably Pune, so I will not disturb him much. We have three great talks coming in the next session. It's all about targeting the omnious octate. I mean, that's the big word that people have been talking about. Everybody wants to beat the omnious octate with various medications that they have, and we have three different topics covering remogliflozin, a serious contender on the SGLT2 space, and this will be first spoken by Dr. Banshi Sabu, followed by Dr. Sriran Godbole, who will be talking about GLP-1 RA, the cardioprotective effects, an umbrella review. I think that should be very interesting, followed by Dr. Bhavna Sosle talking about the benefits of combination therapy with DPP4 and SGLT2. And these are three hot topics. And the first speaker, of course, is Dr. Banshi Sabu. Well, not many people know Banshi Sabu in India, and I really don't know whether I should introduce him and make him more popular than what he already is. One is a good friend of mine and a great speaker. Two, he is the current president of RSSDI, and he is the Secretary General of Diabetes India. So we work together on various projects, various meetings. With that, I welcome you, Dr. Banshi. The virtual space is all yours, and you can actually start the talk. Thank you so very much.
First of all, thanks, Dr. S.R. Arvind, for very kind words. And I'm just sharing my screen. Is
There were
it?
no kind words. There were nice words.
Okay. They all were very nice. Sir, slides are visible?
Yes, perfectly
Yes.
visible. There's
Thank
no
you.
problem at all.
Thank you. So, thanks once again, Dr. S.R. Arvind and Bhavna, for giving me an opportunity in this ADORE meeting. What I'm going to talk about the RAMO, which is after once the DAPA had come as a almost off patent in a very cheaper molecule, which is now available, but still he had given me a talk, which is very interesting. Otherwise, a serious contender in the SGLT2 space. We know by 2045, as per IDF Atlas 2019, we are going to have more and more diabetic patients. So diabetes in India is predicted to have alarming increase in diabetes pandemic. We know about the Omnius octet. This is the session name, also the Omnius octet in pathogenesis of type 2. We know there are multiple pathophysiological defects in type 2 diabetes, and kidney as a victim in type 2 diabetes has been known since long, but it has been made a target for management only recently. So that is what SGLT2 inhibitor, which had come in last 5 years or 10 years, till that we were not knowing, but it was a victim in type 2 diabetes patients. The SGLT2 inhibition, it decreases glucose, decreases microvascular morbidity, decrease in glucotoxicity, and low risk of hypoglycemia. It has got insulin independent mechanism. It has got osmotic diuresis. So initially there is a weight loss and decrease in blood pressure and loss of excess calorie in the urine. That is how it have a sustained weight loss, and that's the benefit in the patients of type 2 diabetes. The altered renal glucose control in type 2 diabetes is because of renal gluconeogenesis. There is a 300% increase in gluconeogenesis. There is increased SGLT2 activity. That is, SGLT2 transporters are increased, and its activity in patients with type 2 diabetes as compared to normoglycemic individuals. And there is an increased renal threshold, and that is also responsible for increased glucose reabsorption in renal tubules. And we know that in diabetes, this increased threshold will not, increases the glucose reabsorption. While adding SGLT2 inhibitor, this can be decreased significantly, and even at the level of 100-120 milligram of blood glucose, it starts excreting in the urine. SGLT2 inhibitor not just work on the kidneys, but they have favorable effects on other components via direct as well as indirect means. The via direct mean, we know that it has got inhibition of renal glucose reabsorption, or direct increasing the glucose excretion from that. But there is a, because of decreasing glucose level, it improves beta cell function. There is a decrease in creatine effect. It has got increased glucagon secretion, which is in physiological range, and there is a other benefits like increased lipid oxidation too. So the overall clinical benefits of SGLT2 inhibitor is there is a decrease in visceral weight loss. There is a decrease in weight by 2 to 4 kg. There is a decrease in A1C by 0.7 to 0.9. The blood pressure is also getting decreased, systolic and diastolic both, in range of 3 to 5 or 2 to 3 millimeter respectively, and interstitial volume and plasma volume, which also get decreased. And this is the reason why they are beneficial in type 2 diabetic patients. And there are multiple evolving evidence, which has promising role of SGLT2 inhibitor in type 2 diabetes from 2015 onward, when we had come first empiric outcome trial, and then now recently a DAPA heart failure study, which was published. So it had shown that there are multiple benefits of SGLT2 inhibitor that I'll be talking. SGLT2 inhibitor have shown benefits in cardiovascular and renal outcome, whether you talk of MACE composite, CV mortality, hospitalization for heart failure, and even renal, even in DECLARE, CANVAS, and empiric outcome trial, you had seen that they have shown the benefit in cardiovascular as well as in renal outcome. CV benefits in terms of MACE, hospitalization for heart failure or for cardiovascular disease, DECLARE, TIMI, CANVAS, CREDENCE, and empiric outcome. All 4 trials had shown there is a significant decrease in hospitalization for heart failure, even for CV death, and overall MACE composite. There was a benefit of SGLT2 inhibitor in patients of type 2 diabetes who have established cardiovascular disease. The CV benefits start as soon as therapy was started. So within 1 week or 2 weeks, the benefit was started in all these cardiovascular outcome trial. And these CV benefits were corroborated in real world evidence too. So even with CVD in real world data also had shown a significant benefit of hospitalization for heart failure, all cause death, and all MACE. So I mean, the similar data was there in CV outcome trial, in randomized control trial, as well as this data was also available and seen in real world data also. The renal benefits was not only in terms of hard clinical endpoints, but there was a difference in attenuation of eGFR decline too. So I mean, the decrease in eGFR or further deterioration of renal function was also halted because of SGLT2 inhibitor, and that has been seen in real data as well as in randomized control trial like Credence 2. So there is a consistent SGLT2 inhibitor benefit was observed in different meta-analysis of cardiovascular outcome trial, which had shown decrease in cardiovascular events, CV death, progression of renal disease, as well as in heart failure. So the SGLT2 benefit is because of multiple hypotheses. It is just not a diuretic hypothesis. It is a thrifty substrate hypothesis, which is increase in ketonemia acting as a super fuel in the cardiac and renal tissue. There is a RAS hypothesis that angiotensin 2, which have RAS blockade, which increases vasodilation and positive inotropic effect. It has got anti-inflammatory effect, which is also responsible for the benefit. It has got metabolic effect hypothesis, which improves many metabolic variables. It decreases sodium level, which also restoring the mitochondrial calcium handling in cardiomyocytes. And there is a decrease in blood pressure lowering also, which may be responsible for decrease in blood pressure and after load too. So SGLT2 have multiple hypotheses because of these, the benefits of cardiovascular and renal benefits what we are seeing. So there are multiple hypotheses of SGLT2 inhibitor benefits. So the overall place of SGLT2 inhibitor in type 2 diabetic patients, whether all patients should be given, patient with established cardiovascular disease, we don't have any doubt that these are the choice of drug, even with the guideline also now talking about that patient who have established cardiovascular disease, the first choice of the therapy after metformin should be SGLT2 inhibitor. And with European Society of Cardiology, which is talking that even with the patient of established cardiovascular disease who is drug naive, the first choice should be SGLT2 inhibitor rather than we should think of metformin before. So I mean, that is what the evidence with the patient with established cardiovascular disease. But what about the patients who are diabetes with multiple risk factor for cardiovascular disease? Even for the primary prevention population also, the SGLT2 inhibitor, which can prevent the heart failure and renal disease, but may not reduce the major adverse cardiovascular events, because we don't have at that point of time the established cardiovascular disease, but it definitely shows the benefit to decrease the renal disease and heart failure with the patient with multiple risk factor also. But at the same time, when we are using these molecules, they have important adverse effects also, and which will be there with all SGLT2, including REMO also, that is genital mycotic infection, bacterial urinary tract infection, and increase in diabetic ketoacidosis risk, which is less than 0.1%, but theoretically it is there with all SGLT2 inhibitor. There are some important contraindication too, like severe renal impairments, patient on dialysis or with end-stage renal disease, patient with fluid or carbohydrate restricted diet, because they are more prone to develop euglycemic ketoacidosis, and patient with acute serious or medical or surgical illness, patient with pregnancy, lactation, or in children also who are even type 2 or type 1 diabetic, it is contraindicated. Now, where we can put the remogliflozin? This is, I had just talked about different SGLT2, whether you talk of all three who have cardiovascular outcome trial data, or you include this also, which is available with us. What the clinical evidence? So there is a robust clinical development program for remogliflozin was available from 2017, a early development study in Indian population, pharmacokinetic study, single dose PK study, which was completed in phase 1. There are 22 study which was there for dose finding, dose interaction, formulation study, and there were some special study which was done even in type 1 also. We have phase 1 trial of Remo which is available. Phase 2, there were 3 studies which is having more than 800 patients, 12 weeks, and primarily they had seen the effectiveness of this clinical efficacy study. And then we have phase 3 study where 900 patients were there, and it was compared with dapagliflozin, and it was 24 weeks study on that pivotal study. It has been available. It is available in our country, and DCGI had approved this molecule in Indian type 2 diabetic patients who can be added remogliflozin also to your type 2 diabetic patient. The early development as per US FDA requirements, while late development as per CDSCO guideline, it is being developed. The pivotal phase 3 Indian study are robust by design because it has got randomized controlled trial, non-inferiority study, a double-blind, double-dummy trial where treatment was concealed from the patients as well as from investigator. There were 3 arms in a real world. The first was 100 milligram twice daily. The second arm was 250 milligram twice daily, and a comparator where the dapagliflozin with 10 milligram once in a day. The only trial with head-to-head comparison with existing SGLT2. So at present, all over the world, different SGLT2 inhibitor, we don't have any head-to-head trial, but this is the only trial which had shown the head-to-head trial between DAPA and remogliflozin. The sample size of this 906 Indian type 2 diabetic patients, all Indian patients with highest number of in phase 3 clinical trials. So, I mean, there are multiple other SGLT2 molecules which are available, but out of all those, it is the only in this particular trial where highest number of Indian type 2 diabetic patients were randomized, because these all were multinational trial and multi-centric trial where the Indian patients were not so high. This was the trial which was primarily done dedicated only in India, where 906 type 2 diabetic patients were there. In this phase 3, there were 58 sites across the country, multi-centric trials in all zones of our country. Remo had comparable effect as far as all glycemic parameters are concerned when it was compared with DAPA. HbA1c at 24 weeks, there was 0.58 A1C reduction was there in DAPA, while 0.72 was there with Remo. Week 24 with fasting plasma glucose level was decreased slightly higher with dapagliflozin with 20.23, while 17.86, while postprandial glucose level was more decreased with remogliflozin was 39.2 average, while 32.4 which was there in DAPA arm. So it was found that 100 milligram twice daily was found to be non-inferior to DAPA 10 milligram with significant p-value. The Remo is comparable to DAPA in safety profile 2 as far as adverse events are concerned. With 100 milligram twice daily, with DAPA 10 milligram, it is comparable with 27.4%, with 29.5%. In Remo, the hypo risk is comparable. Male UTI and female UTI, everything is almost same. Slightly male UTI had shown 1.7, which was less in 0.5. Mycotic genital infection was more with DAPA in compared to Remo, but they all were almost same, not having any significant p-value 2. The equivalent efficacy observed in clinical trials versus other SGLT2. So if you just see the other SGLT2 who have the Indian type 2 diabetic patients, if we just compare, they were not, I mean, compared directly, but in the clinical trial, if we just say the sample size of these patients with 584, 485, 634 in EMPA arm, and Remo was having 612. These were the duration of 24 weeks, with Cana was having 26 in India. The strength which was there with 100 and 300 milligram of Cana, 5 milligram with 10 milligram of DAPA, EMPA with 12 and 10 and 25. Remo was there with 100 milligram BD and 250 milligram BD. If you see, the A1C reduction was almost same in all the patients in all sample size. The fasting plasma glucose also comparable with PPG reduction was also comparable in all the group on all different SGLT2 clinical trials. With weight reduction was also comparable between 2.5 to 3.22. The systolic blood pressure reduction is also comparable, and even the diastolic blood pressure. So that shows that Remo is comparable with all other SGLT2 in terms of weight reduction, glycemic control, as well as blood pressure too also. There are currently ongoing development is going on with 4 clinical study in India with more than 11,000 subjects, with 2 real-world assessments forming a large database of evidence with any SGLT2 inhibitor in India. So, I mean, we have a lot of SGLT2 inhibitor in our country, but there are multiple clinical trials which are going on along with the real-world data from India, and probably by next year we may have a few more data for this REMO, and with more than 11,000 subjects who are recruited. This is one of the trial which is data which I am going to talk about, the INSPIRE, a Indian type 2 diabetic patients of REMO as far as safety and effectiveness, a real world experience study. So we had shown a randomized control trial, a comparable with dapagliflozin, and then this INSPIRE, which is a real world data. In INSPIRE real world retrospective database analysis, where we have real world patients of safety profile of remogliflozin in management of Indian type 2 diabetic patients, and the selection criteria of all any Indian type 2 diabetic patients based on regime as per routine practice with 3 months follow-up, which was completed. Data of eligible patients was retrospectively captured and analyzed. The full analysis set of 5,452 patients. The average age of the patient was 54.9 plus minus 10.27. Male and female, 61% male and 38% female patient. Duration of diabetes is 6.2 plus minus 4.29. Weight of these patients was 74.6 with BMI of 28.3, averagely A1C of 8.6, with fasting plasma glucose of 181 to 257. This is the mean A1C with blood pressure of 126 to 28. So these were the patients who are included. They were already on other concomitant oral anti-diabetic agents. As we know, the most common used in our countries, 1/3 of the patients were on metformin and sulfonylurea. But you can see all different oral anti-diabetic agents were there in these patients who were started with REMO. This is the real world data. The efficacy, the glycemic parameter, the A1C average reduction was around 0.95 with fasting plasma glucose of 42.4 and 69.1 was reduction in postprandial. So in real world, you can see a better reduction of A1C with more fasting and postprandial glucose level was decreased in this INSPIRE real world data. The weight reduction was around 2.6 kg and BMI reduction of almost 1. The blood pressure of systolic blood pressure is 3.3 with diastolic blood pressure reduction of 2.3. In a subgroup analysis where the patients who are having A1C of more than 8.5, the patients, less than 8.5, the patient between 8.5 to 10, and patients who have A1C of more than 10, and the patients according to BMI also in the subgroup less than 25, 25 to 30, and the weight who are having more than 30 BMI. So in the subgroup analysis, the A1C was found to get reduced more in the patients where baseline A1C was more in compared to the patients when A1C was less than 8.5. That is what is expected. The similar way, by BMI group also, the weight reduction was found to be more with the patients who are having more the baseline BMI or more the weight at the starting of the therapy. The safety, the adverse events were the genitourinary tract infection, which we are seeing commonly with our patient with SGLT2 inhibitor, but other side effects or other adverse events were very, very low, and it is comparable with other SGLT2 inhibitors too. The equivalent effectiveness of and with other SGLT2 inhibitor in real world data again. So if you see any of SGLT2 inhibitor with the real world data, the INSPIRE had shown similar effectiveness or equivalent effectiveness as far as A1C reduction is concerned and as far as other adverse events are concerned. In real world clinical setting, REMO-based design demonstrated a significant reduction of glycemic parameters, significant reduction of non-glycemic parameter. Reduction in A1C, fasting and postprandial glucose was higher in case of higher baseline A1C with reduction of almost a tune of 1.76% in subgroup of patients whose A1C was more than 10%. Reduction in body weight was again higher in case of patients who have higher baseline BMI with a A1C weight reduction of 1.6 kg with the 3.3 kg with the patients who have BMI of more than 30. So in summary, in real world clinical setting, REMO was demonstrated a therapy was observed to be safe, tolerable. Genitourinary tract infection is one of the most common side effects. The impact on renal parameter was not clinically significant. Remotherapy has shown a favorable result in terms of reduced uric acid level and urinary albumin creatinine ratio in routine clinical practice. And the results observed was comparable to glycemic efficacy observed in real-world study of other SGLT2 inhibitor. For conclusion of this INSPIRE study had demonstrated that REMO is to provide effective improvement in both glycemic and non-glycemic parameter with no major safety concern. So that's what INSPIRE study had talked about. The guideline, we know that any guideline you talk from the ACE 2020 guideline to the ADA guideline with the established cardiovascular disease, the first choice of the therapy comes with SGLT2 inhibitor or GLP-1 analog. In India particularly, patients are not more comfortable by injectable therapy. So the choice of therapy becomes with us is an SGLT2 inhibitor. And even with the ESC, as I already told you, the patients who have established cardiovascular disease, the choice of therapy is SGLT2 even before starting the metformin in drug-naive patients also. And the patients with even in RSSDI guideline, which is an ABCD approach of RSSDI ESI guideline, which was published in 2019, with out of different, A for age, B for body weight, C for CKD, D is duration, E for established cardiovascular disease, F is the financial issue, G is the glycemic load of the patient, and H is the risk of hypoglycemia. Even if you see everywhere, the SGLT2 is a choice of therapy. So out of these 8, even at 5 places, we had put the SGLT2. At that point of time, if the finance is a problem, even you can use this cost-effective SGLT2 inhibitor in our patients. So the balanced approach towards SGLT2 inhibitor uses the favorable effect. We know that reduction in preload, reduction of afterload, that's blood pressure, improvement in mitochondrial efficiency, delay of decline in EGFR, delay of micro and macroalbuminuria, weight loss, reduction in epicardial adipose tissue, improvement in glycemia, and reduction in uric acid. The unfavorable effects are definitely euglycemic diabetic ketoacidosis, fracture, urinary genital infection that is more common, and some patients with CANA trial of canvas had shown even amputation too. So the important precaution to use SGLT2 is adequate fluid intake to prevent volume depletion, perineal hygiene maintenance to prevent genital infection, avoiding patient with history of recurrent genital or urinary tract infection. During severe UTI episode, discontinue it temporarily, but it does not become a contraindication not to use it again, but use it with caution in elderly patient and particularly when you are using with diuretic. With this, I thanks Dr. S.R. Arvind and ADORE team for giving me an opportunity to talk on SGLT2 inhibitor, particularly REMO in India. Thank you.
Thank you. Thank you so very much, Dr. Banchi. And we'll have time at the end of this session to take the questions. I hope Dr. Banchi is not busy and can stay back for the question and answer session. The next talk will be by Dr. Sridhar Godbole, and he will be talking about GLP-1 RA, cardioprotective effects, an umbrella review. He's a very senior endocrinologist from Pune and is the director of Institute for Treatment and Research in Diabetes and Endocrinology. He's the director of Endocrine Laboratory, and he's also a consultant associated with Jahangir Hospitals, which is a part of the Apollo now. Dr. Sridhar Godbole, please take over. The virtual space is yours.
Thank you, Dr. Arvind, for having me here at the ADORE Congress. And I hope my slide is visible.
Crystal clear.
Thank you. So I'll be giving an umbrella review of the cardioprotective effects of GLP-1 receptor agonists. And this is my disclosure. So just to have an overview of the action of GLP-1, which is germane to cardiovascular events. Of course, the primary action is at the level of the pancreas. So there's going to be stimulation of insulin secretion, a reduction in the glucagon, but also there is more also animal evidence of new beta cell formation insulin biosynthesis, and decrease in the beta cell apoptosis. At the level of the skeletal muscle, there's going to be increase in the glucose uptake. At the level of the liver, there will be increased glycogen storage. So all these features are going to cause glycemic control. In addition, there is decreased motility at the level of the GI tract, which is how majorly the short-acting GLP-1 receptor agonists work. At the level of the fat cells, there's going to be increase in the glucose uptake and lipolysis. At the level of the kidneys, natriuresis contributing to reduction in the blood pressure. At the level of the brain, of course, there is some evidence of neuroprotection, neurogenesis, and increased memory, not so much relevant to the heart, but there is, of course, increased satiety with some molecules, and that contributes to reduction in obesity and fat. At the level of the vasculature, there is increase in the endothelium-dependent vasodilatation. And very importantly, at the level of the heart, you have increased myocardial contractility, but accompanied by increase in the heart rate, increase in the myocardial glucose uptake, and a decrease in the ischemia-induced myocardial damage. I'm not going to go into the details of this very busy slide, but I'm only going to basically discuss Trulicity, which is available in India. You have, of course, generic exenatide twice a day available in our country, and you have liraglutide. Albiglutide has been withdrawn from the European markets, unlikely to ever come to India. Once a week exenatide not available, lixisenatide for all practical purposes not available now. So you can see the T max of Trulicity, that's dulaglutide, 48 hours versus 8 to 12 hours for liraglutide, and this is of course 2 hours for the short-acting exenatide, which we have in our country. The half-life can vary, of course, from a few hours in the case of exenatide, 2.5 hours to around 4.5, 4.7 days with dulaglutide, and even 13 hours for liraglutide. And you have, of course, exenatide twice a day, once a day liraglutide, once a week Trulicity. What's also relevant, particularly to the patient, is the delivery device. So as far as the exenatide and liraglutide are concerned, they are multi-dose pre-filled pens where you can actually adjust the dose. Whereas with dulaglutide, you have a single dose pre-filled pen, either available as 0.75 milligram or 1.5 milligram. Reconstitution is not required for any of the injectable GLP-1 receptor agonists in our country. You need, of course, to attach the needle for liraglutide and exenatide, but not so for Trulicity. You don't need, again, to prime the pen. And incidence of injection site reactions are around 2% for both dulaglutide and liraglutide, and a little more reported, about 5% in trials which are more than 16 weeks for exenatide. And important thing is the eGFR. You can use both liraglutide and Trulicity for up to a GFR of 15. For exenatide, the threshold is an eGFR of up to 30. Now, if you look at the efficacy, the glycemic lowering efficacy of GLP-1 receptor agonists in general, remember these comparisons which are shown on this slide are from different trials, and you cannot, of course, compare efficacy across trials, strictly speaking. But if you first look at short-acting GLP-1 receptor agonists, in this case, what the comparison is between exenatide BID, shown in green, versus either a liraglutide once a day, shown in this scarlet, or you have exenatide once a week, shown in blue. And in general, I can tell you the glycemic lowering efficacy of long-acting GLP-1 receptor agonists is superior to that of short-acting GLP-1 receptor agonists, primarily because long-acting molecules work over 24 hours and more predominantly also reduce the fasting plasma glucose in addition to lowering the postprandial. So you have a continuous action over 24 hours. With short-acting agents, you get a peak and then you get a trough, which is very close to zero concentration. That explains the difference between the A1C lowering for short versus long-acting. If you just compare long versus long, and you look at the left part of this panel, where essentially you're comparing liraglutide here, usually in a dose of 1.8 milligram daily, versus either exenatide, this is once a week exenatide, you have albiglutide. By and large, you can see that liraglutide would be considered as a gold standard for A1C lowering. But amongst the once a week agents, It's only the dulaglutide where you can see over here, the third one over here, where the A1C lowering is it's non-inferior to liraglutide. So this is a very significant finding that the A1C lowering with once weekly dulaglutide is non-inferior to daily liraglutide. Now, if you look at the right panel where they're looking at once weekly semaglutide in orange versus hashed orange, that's oral semaglutide, that seems to be doing the best as far as A1C lowering is concerned. Probably as per this diagram, you can see that uh, dulaglutide is similar to liraglutide for A1C lowering. Semaglutide seems to be a little better, but of course it's not available in our country. Now, if you look at the fasting plasma glucose, this is a no contest between the short-acting agents and the long-acting agents. I told you already, long-acting agents would, of course, control the fasting plasma glucose to a better extent. Now, if you look at the long-acting agents in general, you can see that dulaglutide is as good as liraglutide for lowering of fasting plasma glucose. Again, the difference between semaglutide seems to be doing better than dulaglutide, that's subcutaneous once a week semaglutide versus dulaglutide. So again here, semaglutide seems to be doing a little better compared to either liraglutide or dulaglutide once a week. But of course, we are concentrating on this because this is what's available in our country. Now, as far as weight effect is concerned, unlike the glycemic lowering, where there is very little inter-individual variability, as far as weight loss is concerned, you can get a lot of inter-individual variability. So some people can lose a lot of weight, some people lose no weight at all. And again, if you look at the short-acting versus the long-acting, you find that there is little to choose between the two types of agents as far as weight loss is concerned. Now, if you look at the long-acting agents in general, now here in this particular trial, that is liraglutide 1.8 daily versus dulaglutide 1.5 once a week, which I'm highlighting here. It's numerically, you can say liraglutide seems to be doing a little better. And of course, it also is just a bit statistically significant. But on the other hand, again, the semaglutide, you seem to get a better weight loss compared to the agents that we have in our country. Now, if you compare once a week Trulicity 1.5 milligram versus 1.8 milligram liraglutide, the frequency of nausea which was seen in the AWARD 6 trial is virtually the same from baseline to week 26. We all know that people with type 2 diabetes are about 2 to 4 times more likely to develop cardiovascular disease compared to someone without a type 2 diabetes. And this is just the timeline of the various CV outcome trials with GLP-1 receptor agonists. The very first trial which really came was the leader trial, you can see, which actually showed benefit for the 3-point MACE. Elixa with lixisenatide did not show benefit, it just showed non-inferiority, which it set out to achieve. Then you have the SUSTAIN 6 trial with once a week semaglutide, which again showed a benefit for the 3-point MACE. Freedom, I won't discuss, the drug itself was withdrawn. Excel, again, failed to show superiority, just showed about inferiority. Harmony again did not show any superiority. And then you have the Rewind trial with dulaglutide. Pioneer, of course, is the one with oral semaglutide, which failed to show benefit. It showed non-inferiority for the 3-point MACE. And this is, I would just now show you, is a very significant trial, 9,901 patients. And the primary endpoint was the 3-point MACE. Now, if you look at the Rewind trial and compare the design with other CV outcome trials, with the various other agents, you find that the age of patients you can see are all comparable. But what is important is the gender. The percentage of women in the Rewind trial was 46% versus anywhere from 31 to 39% in the various other trials. As far as the prior CVD percentage was concerned, this is again a very significant difference. Some trials with GLP-1 receptor agonists actually had 100% patients as a secondary prevention cohort. Other trials had anywhere from 81 to 85% patients with prior CVD. But look at this figure, 31% only in the Rewind trial. This is more like what we see in our clinical practice. Of course, all patients had a comparable BMI. All of them are heavy in all these trials, around 30 to 32. And you can see the mean A1C, which is very, again, significantly different in the Rewind trial, though the inclusion criteria said less than 9.5. But in the other trials, the A1C, mean A1C was, the best was 7.7, but by and large, they had A1Cs from 8 onwards up to 8.7, whereas in the Rewind, it was 7.3. And because of a lower baseline risk profile of these patients in the Rewind trial, this is an event-driven trial, which therefore goes on for 5.5 years, compared to other trials like, for example, Harmony trial just went on for 1.6 years, 1.3 years. And that allows us to have a greater exposure per patient years to the drug to look for adverse events. So this is important, the women, the prior CVD, and the mean A1C. These are three things on which the Rewind trial stands out from other CV outcome trials, and of course the mean follow-up. Now, if you look at the annual MACE rates by trial in the placebo arm, why is this important? This is important because it informs us about the background risk of the patients. If you have a lower MACE in your placebo, it means your patients are at a lower background risk. So remember, all other trials had very relatively high MACE rates in the placebo arm, which goes to show that they had recruited patients at a high risk to begin with. Whereas Rewind trial, the figure was just 2.7, which is again stands out from the other trial, which means that the baseline risk of these patients was pretty low. And if you look at the bottom line, the 3-point MACE, this is comparing dulaglutide versus placebo on top of standard of care, as is done with CV outcome trials. There was a relative risk reduction by 12%, despite majority of patients not having an established cardiovascular disease. And if you looked at the subgroup analysis, these effects were consistently shown in patients with and without established cardiovascular disease. Now, if you break up the components, you find that by and large, the cardiovascular death is not so much affected. You can see the p-value here. Neither is the non-fatal myocardial infarction. What seems to improve and drive the 3-point MACE composite is the non-fatal stroke. So if you summarize the Rewind trial, these were patients with type 2 diabetes, high cardiovascular risk, and that risk was stratified based on age, whether they were more than 50 years of age, 55 or more than 60, and they were randomized into either subcutaneous dulaglutide 1.5 milligrams once weekly or matching placebo, and they were followed up. You can see the primary endpoint, which I already told you, that's a 12% relative risk reduction. This is the CV death non-fatal MI, which is not so statistically significant. What seems to stand out is non-fatal stroke. What is also equal in both the arms is the heart failure hospitalization or urgent visits, the composite microvascular outcome, that remains clinically or statistically significant, and the composite renal outcome largely driven by onset of macroalbuminuria and GFR reduction by more than 50%. So the conclusion of this trial was dulaglutide superior to placebo in reducing cardiovascular events in middle-aged and older people with type 2 diabetes with a previous cardiovascular disease or those who have cardiovascular risk factors. So if you summarize the cardiovascular outcome trials with various GLP-1 receptor agonists, the one that are highlighted in red are those that actually showed benefit, beginning with the LEADER trial with liraglutide. Then you had the subcutaneous semaglutide trial, SUSTAIN 6. You had the Harmony outcome trial with albiglutide. The Rewind trial, again, highlighted in red, and I showed how it's different from other CV outcome trials. So these are the 4 trials which stand out for benefit, and this is again depicted somewhat differently as per the hazard ratio for different GLP-1 receptor agonists and other agent classes as well. If you look at GLP-1 receptor agonist classes shown in red, you can clearly see that the benefit is, as I said, for LEADER, SUSTAIN 6, Harmony, and Rewind, that's dulaglutide. For SGLT2 inhibitors, strictly speaking, it was EMPA, followed maybe by Canvas, and Declare actually could not show benefit for dapagliflozin because of the maybe the patient profile that was recruited. And DPP4 inhibitors failed to show any benefit. They do, of course, show safety for cardiovascular events. This is a slide I'm not going to go into. It's shown so many times. The important thing to remember is If you have a patient with established atherosclerotic cardiovascular disease or a patient at a high risk, if it's more of a pipe disease, the agent of choice would be a GLP-1 receptor agonist with a proven cardiovascular disease benefit. That's again something which you have to underline. Not all GLP-1 receptor agonists have proved to have cardiovascular benefit. You of course have a choice of SGLT2 inhibitors in this setting as well, and maybe they would be preferred over GLP-1 receptor agonist in the setting of a heart failure or a CKD. If you have to choose a second agent, again that would be a GLP-1 receptor agonist. Now, of course, you can have nice molecules, but what's the experience in the real world? Whether patients adhere to what you prescribe to them, whether they skip their doses, that's counted as adherence, and or whether they stop their treatment altogether, which is counted as persistence. So this is a European real world data from 6 countries, including 5 European countries and Canada, which is showing persistence with various GLP-1 receptor agonists at the end of 1 year after the index dose was started. And you can see that once a week dulaglutide, shown in light blue, shows the best persistence amongst all the other various GLP-1 receptor agonists. And this probably has to do with the fact that it's once a week. It's a very simple device, which I'm just showing over here. It's designed keeping patients in mind. It's very hassle-free. You don't get to see the needle, though of course you can feel it. And it's just a push button type of a device, very simple to use. And that I think contributes to greater adherence and persistence. And of course, you need to consult the package insert before you really prescribe the drug, and patients also are advised to consult this insert before they start therapy. I think I'll conclude my talk here. Thank you so much for having me here, and it was a pleasure speaking with you. Thank you.
Thank you so very much, Srirang. We see the star of the evening, Dr. Sanjay Agarwal, who is present finally after a nap. And I'm sure it was a Sunday afternoon nap, must be cold in Pune. He's also wearing a sweater. Sanjay, you are supposed to originally chair this session. The stage is all yours.
Thank you very much, Arvind. My apologies for joining late. And our next speaker for the evening is going to be Dr. Bhavna Sosle. She's going to be talking to us about benefits of combination therapy with DPP-4 inhibitors and SGLT2. I'm sure everybody knows Bhavna. She's a very dynamic young lady who's been in the forefront of diabetes research today in India. She's the director and consultant diabetologist at the Daikon Hospital in Bangalore. Over to you, Bhavna, for your presentation.
Thank you so much. It's good to see you on Sunday afternoons. Let me share my screen now. All right, so I'm going to get straight to the topic. Over the next 15 to 20 minutes, we're going to look at what the benefits are when you actually combine a DPP-4 inhibitor and an SGLT2 inhibitor. So we know over time our practice has evolved. We've gone beyond looking at just, an A1C of 7 for everyone to saying you need to individualize therapy. We now know that using multiple agents in combination therapy right from the start, as early as possible, even at lower HbA1cs, is beneficial. We give individualized targets to all our patients, and we prefer to treat target right from the beginning. And the guidelines, of course, have evolved to look at atherosclerotic cardiovascular disease, heart failure, and kidney disease, and to incorporate therapy based on all of this as we treat the blood sugar levels. So let's take a case as an example. So we have here a middle-aged man, not too long, diabetes for 2 years, and hypertension for some time. He's on metformin, on antihypertensive therapies, and HbA1c, sorry, my computer wants me to update. I'm going to say remind me tomorrow. Okay. Before it starts something on its own. Okay, so we have a middle-aged man and he has diabetes for 2 years, hypertension for 6 years. So metformin is on antihypertensive therapy. HbA1c, as you can see, is high, so out of control, and he's obese as well. And what do we know about his labs? Well, we'll come to some of his other labs also in some time. The question clearly is, well, he's not under control, so what do you do next? And we know over time that if you want an A1C reduction of more than 1.5%, it's not really good enough to just add a single drug. So ideally, we need to be adding more than one drug. So a young or middle-aged person, you'd want his HbA1c to come to about 6.5. Ideally, if you can get it lower than that without hypo, that would be great, but definitely a target of 7 at least at the upper limit. So you definitely need two drugs. Whether you choose to use the two drugs separately or as a fixed drug combination, I think is sort of left to you. But let's see what happens if you actually combine different drugs. If you look at the different pathophysiological pathways involved, there are so many different things you can do. But metformin cannot correct all these defects. It can correct some of the defects. If you add a SU, then it corrects another defect. If you add DPP4, a couple of other problems are sorted out. And if you add SGLT2 inhibitors, then you're targeting through the kidney, you start to lose more and more glucose in the urine. But if you combine both the DPP4 and an SGLT2 inhibitor, you realize that several of these pathways can actually be targeted together at the same time. So while you still may not hit everything, you sort of target most of the pathophysiological pathways involved with both these two drugs used in combination in addition to metformin therapy. So even the guidelines do advise us to add more than one agent when we need to attain a much higher level of glycemic control. So if the amount of HbA1c reduction we desire is more than 1.5%, it is necessary for us to use combination therapy, because adding just one additional agent is not going to get your patient to target. Most agents reduce A1C by maybe 0.5 to 1%, unless of course you're using insulin, where the insulin dose could really be increased to whatever level is required. So we're not going to go into this slide again, but there are certainly benefits in terms of looking at patients and their comorbid conditions when we start therapy. But in addition to that, and the compelling cardiovascular benefits, adding these two drugs in combination also helps the patient lose weight, and we can also reduce the risk of hypoglycemia. So how much HbA1c can we actually expect, how much drop in HbA1c can we actually expect when we use a combination of empagliflozin or linagliptin? So this is what studies have told us. So when these two drugs are used in combination, whether you use a lower dose or a higher dose, that is EMPA 10 and Lina-5 or EMPA 25 and Lina-5, you can see an A1C reduction of between 1 to 1.8%. So the higher the baseline A1C, the greater is the drop. And if the baseline A1C is slightly lower, then the drop is also slightly lesser. So you see obviously in this slide that using the two drugs together makes a much bigger difference than adding just plain EMPA by itself or Lina, irrespective of what dose of EMPA you have used. So this is a study, this is a meta-analysis which has looked at different DPP4 plus SGLT2 inhibitor combinations, and it has studied to see when you use this FTC, do you actually get to target much more than using just a DPP4 inhibitor alone, or do you get to target much more than using just a SGLT2 inhibitor alone? And what we see in this slide is it is obvious that when you use two drugs, you are going to reach a much better HbA1c level, and you're going to get to much better glycemic control. So FDCs are advisable, especially if you require a much greater reduction in HbA1c. Now, in addition to this, we know there are other benefits of using SGLT2 inhibitors in terms of reducing blood pressure and body weight. And we see all these benefits even when the fixed drug combination is used. So when patients are on EMPA and Lina combination, whether it's 10 or 25 mg, it can lose between 2 to 3 kilograms of weight. And the systolic blood pressure and the diastolic blood pressure also drops by 2 to 4 millimeters of mercury. Well, so these are the other labs that we've now got. We've seen Vijay. We know that he needs to get a target. We know he needs two drugs. We know the benefits of adding SGLT2 and DPP4 inhibitors, and we know how much A1C he's likely to drop to over time. But that's not enough, of course, because we need to screen everyone for micro and macrovascular complications. And his ECG tells us he has LVH. His echo is otherwise normal, so no diastolic dysfunction also, so that's actually good for him. He's a known hypertensive, and you see that diabetes, hypertension, his UACR is high. And the GFR, again, on calculation is actually low. So below 90 is actually low. And this is an issue. And this is something we need to consider, because we need to remember that over time, with age also, the GFR is going to decline. So anything that we use that can actually slow down this decline in GFR is beneficial to our patients. So what do we know from the CV outcome studies of SGLT2 inhibitors and DPP4 inhibitors? Well, we know from many of these studies, I won't go into details of each of these studies, that there is a benefit certainly with all the SGLT2 inhibitors, especially in reducing heart failure hospitalization. And with the EMPEREG study, in the EMPEREG study, we also learned that there's a reduction in cardiovascular death with the use of empagliflozin compared to placebo. Well, now we also have SGLT2 inhibitors being tested and used in individuals without diabetes. And we've seen heart failure studies like the EMPEROR-REDUCE studies, which has looked at individuals with heart failure and reduced ejection fraction. Irrespective of whether patients have had diabetes or not, empagliflozin has actually shown that there is a reduction in the primary endpoint, which is cardiovascular death and heart failure hospitalization. So we know that in addition to people with diabetes, there are certain other benefits, and these drugs could also be used and extended to another set of people without diabetes where there are specific indications. What about linagliptin? Because we're talking about two different groups of drugs here. And with linagliptin, we know from the Carolina, I don't have a slide on Carolina here, but we know from Carolina that linagliptin is safe and it does not increase the risk of cardiovascular events. Carmelina was also a cardiovascular outcome trial with linagliptin, and this included mostly recruited patients who already had chronic kidney disease and albuminuria, or they had a high risk of cardiovascular events. So even in this high-risk population, in Carmelina, linagliptin was safe, and cardiovascularly it was neutral. So what about the kidney next, right? So that was the other thing that we were thinking about. When we looked at the data from Carmelina, linagliptin actually significantly delayed the progression to albuminuria. And in those who had albuminuria, there was actually a reduction in the UACR by more than 50% in individuals who got linagliptin compared to placebo. This was after correction for all the other confounding factors. So this is something important to remember. And we know that linagliptin can be used in any level of GFR and even as the GFR declines. Well, in terms of SGLT2 inhibitors, of course, we can't use that as the GFR drops because then there's no efficacy. But we know from data from several of the studies that there are actually benefits of using SGLT2 inhibitors in terms of renal outcomes. So even secondary analysis data from the EMPEREG study has shown us that in addition to reduction of 3-point MACE and cardiovascular death, heart failure, hospitalization from EMPEREG and EMPEROR-REDUCE, there's also reduction in time to dialysis, doubling of creatinine, and mortality, that is renal outcomes, actually reduced with the use of empagliflozin compared to the standard of care arm. The secondary analysis has also shown us that the GFR slope, the decline in the GFR slope is actually much slower with the use of empagliflozin compared to standard of care in the EMPEREG study. So what do we want really for our patients? For example, Vijay, we want good glycemic control, of course, and we want to prevent complications. Now, if he already had heart failure, well, then you close your eyes, you give him an SGLT2 inhibitor. He doesn't have heart failure, that's good. But maybe that's something I want to prevent in any case. And we already know that he has hypertension. We already know that he has kidney disease. His GFR is low. So we still have to consider that based on these individual factors, a use of an SGLT2 inhibitor with a DPP4 inhibitor. Remember, we want him to lose weight. He's already obese. So these basic patient factors are taken into account can help us choose molecules for treatment. Now, one may always think about the cost, and these two drugs have been expensive for several patients in India, and that is true. but there are a several number of individuals for whom it is also affordable. So when we think of costs, we need to not just think of direct costs, but we need to think of indirect costs. That is the cost of treatment of complications, the cost of not being able to work, you actually lose your job, you stay at home, and of course you're dependent on someone else. So all of these indirect costs come in. So if you take that into account, the incremental cost of adding this combination therapy is actually much lower compared to the cost of treatment of complications. So where do we really stand today? So we've got our patient here who has hypertension, who has diabetes, who has obesity, and LVH, and he also has microalbuminuria. Well, we don't want him to progress. We don't want him to have microalbuminuria. We don't want him to have an MI or heart failure or some other event like that. So the ideal thing is to really stop this from progressing right to the end or to even dialysis or mortality. So where do we stand in terms of evidence from clinical trials? Well, if you're looking at just diabetes per se, we know we can expect a good drop in HbA1c by using combination therapy in patients with just on metformin. We know that SGLT2 inhibitors help to lose weight, DPP4 inhibitors are weight neutral, the blood pressure can fall slightly. So these are all basic benefits that we want to get. In addition, we already know he has albuminuria, and linagliptin is safe. It can help to reduce the albuminuria levels, and so can empagliflozin based on data from the EMPEREX study. In addition, of course, if someone already has baseline heart failure or cardiovascular disease, there's definitely evidence in reduction of cardiovascular death with the use of empagliflozin. So we've got data with respect to heart failure, with respect to cardiovascular death, renal safety, and we know data with both empagliflozin and linagliptin is quite robust. This is really the end of my talk here, and I would like to stop sharing my screen and we can take questions. Yes.
Yeah, I think, thank you very much, Bhavna. Excellent presentation, very informative. Do we have any questions from the audience? I can't see it in my chat box.
No questions have come from the audience. I think we all are there, and Sanjay, you can start off. We'll all join.
All right. So I think we've got Dr. Bansi, Dr. Srirang, and Dr. Bhavna out here. And I think the key factor that we're really looking at is kidneys, heart. These are the two areas that we really want to stress, whether it comes to GLP-1, whether it's SGLT2 or the DPP4. And I think all three have made the case to say that which of these molecules can be used given the situation. So Bansi, let me ask you the first question. That you spoke about remogliflozin, and you did present a lot of good data about remogliflozin. In clinical practice, where do you really structure the molecule? You know, which class of patients would you really feel that I should use a remogliflozin in this patient?
So if you just want to ask me where I will use the Remo only, maybe before 2 months or 3 months, when the Remo was only available to us at a lesser price in compared to other SGLT2, then my answer will be very clear cut that, you know, those patients who can't afford and to whom I have to write SGLT2, probably my first choice will be the Remo. Now in last almost 6 or 8 weeks now, we have multiple SGLT2, particularly dapagliflozin, which has been now made available to our country by multiple pharmaceutical company. So now to choose that where I will be using Remo only, the answer will be very difficult. So I don't know where I should use only Remo. There is no extra advantage over the molecule which is already available at the price of 10 or 12 rupees. So I will not say that, you know, this is the place where I would like to use the Remo. But yes, the existing patient who are continued with the Remo, and if they are okay and happy, then I may not change for it, but not that I will use the Remo at that particular place. But SGLT2 uses, we all know that it should be a choice of therapy with the patients who have existing cardiovascular disease. Yes, Dr. S.R. wants to make some comment.
No, I don't want to make a comment. I'm asking you a question to Dr. Banshi. Banshi, the cost of DAPA, which has got reduced, are all generics. And we know generics will also go through PKPD studies. Remo is a original research molecule. Of course, it was started by GSK and later on taken over by Glenmark in India, and then it's co-marketed by others now. How do you compare a generic DAPA, which has not gone through the tests, versus a original molecule like Remo?
So I believe that I don't know about Arvind this case that they are not doing PKPD sampling. Before that, the originator in India, there are only 3 company, MSN, which is making the drug, Zydus, and one more company which is making the, I think, dapagliflozin, and most of others are buying the DAPA from them only. And they have to have the PKPD study before getting DCGI approval. So I don't think one company can have with originator without a PKPD sampling, they can have they can market the molecule. This is what I believe. Yes, definitely the generic medicine which are they are bringing the just off patent whatever the molecule which is available to them, they will not have to do any phase 3 or phase 4 clinical trial because it is already established molecule. In compared to that, the remogliflozin, because it was a newer molecule, they have a robust clinical trial and randomized clinical trial. Phase 1, phase 2 clinical trials was there. There was phase 3. It had only a molecule which was compared directly with DAPA, which I had shown you the data, and then there was a real world data of inspired study which had been also shown. So yes, that type of data you may not have with the generic drug, but originator have all those data, so which is available, I think, and they have to do the PKPD sampling. But still, I want to know more from you. I don't think any company can bring out any molecule without having any PKPD sampling from the originator.
Srirang, yeah, go ahead, Arvind.
Go ahead.
Arvind, go ahead.
Okay, now I have the president of RSSDI and the secretary of RSSDI in this panel, so I would like to ask them a question, because whatever question I asked Banshi is there in the minds of all the practitioners across. Now you have a virginal molecule which is available, and then a DAPA crashing the prices and coming down in the form of generics. Can there be some study planned very quickly by RSSDI about actually a generic DAPA? How good is it when it is compared to the originator, or a generic DAPA versus remogliflozin, so that at least the doctors are aware? Because you can't ask the companies to do this kind of trials. It has to be started by a group of people who need this kind of answers. I don't know how RSSDA will look at it, but just a question.
But Arvind, when the DCGI gives permission to any generic, they have to show a non-inferiority to the original molecule. Unless they show a non-inferiority to the original molecule, they cannot introduce it in the market. So the generic always has to go through a non-inferiority study, and that's when they get a permission by the DCGI to launch. So I'm sure these studies are already existing, and we can't reinvent the wheel, because it's not going to help in any kind of a way that whether you're going to have a generic study versus originator, and what is the linearity of relationship between the two from the RSSJ standpoint.
I'm sure also the gliclazide, or we have originator molecule gliclazide, and then there are 10 companies who have made the gliclazide in India, same modified release, sustained release, even in combination. And I'm sure all those must have PKPD. And there is no such study which is available out other than the originator or the who are manufacturer. I don't think the RSSDA have done in past any such type of study. So I don't have any idea.
Because
I think it is
well,
out
let
of
me
the
ask the same
scope of
question
RSSDA.
to Sri. Yeah, I'll ask Godbole about this. You're very right in Sanjay asking the question that the PKPD studies are there with DCGI and they have cleared it, but safety efficacy studies are not mandatory.
They have to go through all these studies to compare it with the originator. Only then they get the permission. So safety, efficacy,
So
everything is studied by that. Even the PKPD.
PKPD has to be compared, yes, but safety, efficacy, I really don't know whether there were any trials,
Safety
because
efficacy
20
study is
companies have
not to be
already
done
released.
because it is it is not a new molecule. It is the molecule of existing molecule. Only they are making just a duplicacy. They are generic medicine. So all generic medicine have to show their PK/PD only, I think.
Shriram, let me ask you a question. With all the great data that we've got of GLP-1 molecules, it's all in the, I mean, we all accept it. Yet our prescribing information, if you look at the number of prescriptions that is there, even amongst the diabetologists, is very poor as compared to, okay, cost may be one constraint, injectable reasons may be another one. Do you think this entire scenario will change with oral semaglutide when it comes into the market, and the GLP-1 will get a bigger push given the fact that it may be oral? Or is it just the GLP-1 that people are not really prescribing for whatever reason?
The cost is, of course, a constraint, and oral semaglutide is not likely to be any less expensive than subcutaneous, the GLP-1 receptor agonist that we have. The other constraint is injectable. So those people who are afraid of the prick may like to go for oral semaglutide. But if you have a once weekly prick, I don't think that makes much of a difference. I believe the important reason why not much of GLP-1 receptor agonist gets prescribed in our country is actually because possibly physicians decide the cost for the patient. I think we should stop doing that. I think we should leave the financial decisions to the patient. We just place evidence before them. If the patient can afford, let him take a decision. Doctors should not decide for their patients whether a patient can afford or not.
I agree there. So I think we decide that, okay, will the patient afford or not?
Yeah, we shouldn't
I think,
decide that.
yeah, I think that's correct, absolutely. Bhavna, you've presented some excellent data about the combination, fixed drug combinations. And we do find that, the combination works very well in reducing the albumin urea, as well as, benefits in the cardiovascular status and all these things that are there. Again, I come back to you that how much is the contribution of DPP-4 really in this entire combination when you find that there is an overlap of effect of SGLT2 and DPP-4, and majority of the effects are actually from the SGLT2, very little from the DPP-4. So is it really required to be there?
So I completely agree with you, but I think we don't always need to use both the drugs together. So I think if you need to get those cardiovascular benefits in more, I would always prefer an SGLT2 inhibitor or a DPP-4 inhibitor. But if your A1C itself, the reduction you need is much higher, then you're probably going to need both the molecules together. I think that is really where you think of two molecules at all in the first place. If you really need an A1C reduction of below 1%, you'd probably think of just using one of the two drugs, and there the contribution of the DPP-4. If you're thinking of CV outcomes and renal outcomes, probably would your pick would be an SGLT2 inhibitor.
So do you think that just as we keep talking about the use of sulfonylureas in practice today, do you think over a period of time the DPP-4 will also lose its relevance? And with the GLP-1 and SGLT2 ruling the roast, DPP-4 may become irrelevant after a while?
I don't know, but I already see that there are a huge number of patients now who can afford an SGLT2 inhibitor because it's become generic, and it's become first-line therapy just because the cost is so low now, and it's on par with teneligliptin and vildagliptin, which is off patent. So I don't know. We'll have to wait and see.
Arvind, what's your
The
take?
companies won't be happy, but we'll see.
Do you think the DPP-4 will phase out? Given the very data that is not so good, it's all a non-inferiority data, neutral data, A1C reduction of hardly 0.4 to 0.6. What do you think?
Well, I'm not going to say anything at this point of time, but then if I have to go back and quote what Dr. Eckel said, the present American Diabetic Association president, he made a comment that DPP-4 just reduces the glucose by 0.5, 0.6. It doesn't do anything more. Well, these are his words. So I think we have drugs which are doing much more than that. Well, we need something that does not cause hypo and which has an action on the beta cells to produce some amount of insulin. The problem with sulfonylurea has always been hypoglycemia. And if you want to really avoid hypo, which is still a threat, DPP-4s will continue to stay as probably the third add-on, starting with metformin, SGLT2, and probably ADP4 after that, and sulfonylurea to follow later. And Sanjay, there are also some questions on the chat box. If you want, I can read it out.
So there is one that has 56 years old. This I'll open up to the panelists. Long uncontrolled.
No, I mean about that, I can quickly read it out because I read it 4 times to understand that question. This is to Dr. Banshi. I really don't know Banshi, but this is open to everybody. Okay, this is from Dr. Bimal Baumik. He's from Bangalore. He's a very senior physician. So he wants to know that in all the trials of SGLT2, they were actually measuring serum beta hydroxybutyric acid levels, and he wants to know whether the remoglyphosine studies also measured beta hydroxybutyric levels, and if they have measured, he would like to know what was it.
No, in the study of Remo, also the ketone bodies were measured. Beta hydroxybutyric acid was measured. It's not like that. And it was comparable with the euglycemic diabetic ketoacidosis, one of the side effects with the patients in an inspired study, which they had a real world data. And in their clinical trial, randomized control trial with the phase 3 trial, when it was compared with dapagliflozin, it was comparable with the incidence of euglycemic diabetic ketoacidosis. So it is to be measured, and it has been measured also.
Can I add to that? Because
Yes.
we were a part of that study as well, which compared the head-to-head remogliflozin versus the original dapagliflozin. So yes, so they did measure the beta hydroxybutyric acid levels, and then we also kept measuring the serum bicarbonate and lactate almost every month for all the patients, and there were actually no changes in the levels of adverse events and DKA reports in either of the arms. So I don't know what the average levels were from the study. That's something we have to go back into the study detailed report and look at it. But there were no warning signs there. And it's also being measured even now in the combination remogliflozin with vildagliptin versus Empel in other studies ongoing. So we're continuing to measure that even in that particular study.
I think if there are no other questions.
No, there is a one question. There is a 56-year long uncontrolled diabetes. This patient is on Mixtar and Glargine with teneligliptin, metformin, voglibose. What should be added? Now, I don't think it should be added. Now, make the patient on basal bolus therapy with gliptin and metformin if it is a type 2 diabetic patient. This Glargine and Mixtar combination itself is a bit irrational, and already on teneligliptin, metformin, voglibose, and now they want to add GLP-1 and SGLT2. Yes, it can be added if patient have an established cardiovascular disease. I would like to add SGLT2. If it is an obese patient not getting control, then GLP can be also added. Then I have to remove teneligliptin, but no more voglibose. This is my advice, but we can ask the panelists.
No, I think if you ask Srirang Godbole now, he will say I will add a GLP-1 because he.
I mean, I told that both the things. If it is the weight is a primary concern, the GLP. But out of these two, I will start adding one. But teneligliptin is to be removed and voglibose is to be removed. And Mixtard and Glargine combination is not proper.
Let me ask you a common question that people do get asked. If you're using a GLP-1, a lot of people say, okay, continue DPP-4. So in your practice, do you remove DPP-4 or continue DPP-4?
No, if I have to use a GLP-1 receptor agonist, I just stop the DPP.
Because there are reports that they have used and try to keep the endogenous GLP-1 also going.
No,
So
I stop the DPP-4 inhibitor.
Arvind, what do you do? There are reports.
Well, my usage of GLP-1 is extremely low, but what I have understood is if you are using GLP-1, there is no role for DPP-4 in that patient. So don't use a DPP-4 if you are using GLP-1.
So you don't enroll for a BA class if you are already doing a PhD.
I definitely agree with you. Because the levels of GLP-1, what you achieve when you inject is very high. You don't need another DPP-4 inhibitor to achieve that much of
You do
GLP-1.
find people do that, in prescriptions, and you keep wondering whether
Does
there's
the-
a rationality to it and whether there is some scientific basis to do that.
Sanjay, then you may see even the glimepiride and gliclazide. That does not mean that. Regarding the uses of DPP-4, will it go less or it will phase out? I don't think so, because the elderly patient, it is very safe without
Very safe.
any hypoglycemia. And as we know that clusters, which we are classifying, that many of our patients who are developing diabetes after the age of 55 and 60 only, and if they have established cardiovascular disease, we don't want them to have hypoglycemia. So even we want to use a CV safe DPP-4, and definitely they may be on DPP-4, I mean SGLT2 also. And GLP-1 usage, as Dr. Godbole was talking, that it is a cost, maybe one issue for India, but even the cost may not be the problem for some Middle East countries and in US, but still the users of GLP-1 is less. I think probably the GI side effect, and many of the patients would not like to have that. They don't all the time they feel fullness, or feeling of fullness may be one of the reason that even you start them patient on GLP-1 who might be affording, but still after some time they come back and they tell that, doc, can you change the molecule? It is not suitable, or I feel some GI side effects. So it's very commonly what we see.
Or I'm eating less and my wife is not happy about it. That's usually the most common reason.
But the feeling of fullness itself is, patient is not eating, so they feel they are not well.
So since Srirang, you said that SEMA, I mean, we know from the data that it's not very good in terms of cardiovascular outcomes. I mean, MESA outcomes.
So yeah,
right?
Oral semaglutide has no evidence for CV benefit as of now. There are still ongoing trials, but as of now, there is no evidence for benefit. There is evidence for safety, but not benefit.
Yeah. Do you find it will find a very strong place for obesity rather than CV outcomes? And consider the fact that I'd heard recently the presentation, a combination of SEMA with amylin causes almost 19% reduction in the weight, and that's phenomenal. So do you think that will ultimately end up being more of an obesity drug?
Yeah, unless it really comes up with the CV benefit data, it's likely to be boxed into, for obesity, or maybe for people who like to use a GLP-1 receptor agonist in an oral version. That's all the two indications I think will stay on, unless you come up with real good CV benefit data. Henceforth.
And how many times have you used dulaglutide for weight and
No, never. I don't use dulaglutide for weight. I don't think it's a weight loss molecule. No,
Victoza is better.
Yeah. Any day, liraglutide is better for weight loss.
I think, do we have any other questions? Those I'll hand it back to Arvind for continuation.
Thank you so very much, Sanjay, for that. I request the panelists to stay back because we have a great lecture coming from the Harvard group of Dr. Alison Goldfein and Rohit Kulkarni, which is actually called the Jugalbandi, and this is about where we are today with using stem cells to delay or reverse diabetes, and then insulin regulation of beta cell function. I think I will request Dr. Krishna Sheshadri to now come in at this point of time. We close this program. I'll just hand it over to Bhavna. She may have something to say, and then Krishna Sheshadri will take over. Thank you so very much, Sanjay. Thank you, Srirang. Thank you, Banshi. Thank you, everybody, for being there.
Thank you very much. Thank you.
All right, so I request Dr. Krishna to start the next session on translational medicine. Dr. Alison and Dr. Rohit are ready and have joined us.
Right. Wow, looks like, we're starting early, and just to give a background of this translational medicine Jugalbandi that we have. Is Rohit here?
Yes, I'm here.
Yes.
Hi, good morning.
Rohit,
Good evening. Good evening, I should say.
Very dark hotel in Bangalore many years ago, and this conversation about why it is important to why most of the talks in India are only clinical, and we don't have enough basic science focus, and how it's important to start bringing this in, and that's how we started. And a couple of years later, we had this first Jugalbandi between Rohit and and Allison, and I was involved as the translator, or if you want to use that pretty name. And it's very interesting that in the 10 or so years that have happened since Bangalore's uh, waste products have been flowing into the Rishabhavati and then the Kaveri. We have come a long way, and that that people look forward to translational talks. Rohit gets googlies from people in India asking about whether this mouse was used or what was happening to this cell, and did you do a knockout or a knockdown? I think we've come full circle, and these translational talks are really the hit of many of these programs. And so I look forward again this evening's session. Rohit Kulkarni needs no introduction to India anymore. He is he's in Howard Medical School. He's a professor of medicine and physiology and the head of the section on islet and regenerative biology. He's the director of the PNF program at Joslin Center, and holds the Margaret A. Congleton Lingo Chair. Among others, he is the recipient of the Ernst Oppenheimer Award from the American Society, the Albert Rennell Prize of the ASD, and Julio Santiago Memorial Lecture. And over a period of time, his interest has been in NAFLD and hepatic metabolism. Rohit, all yours.
Thank you very much, Krishna, for the introduction. And I presume I just have to share my screen. Is that working now? Can you guys see?
Yes. Yes. Sir.
Okay. Well, thanks very much, Krishna. Again, it's a pleasure to be part of this group. And as you rightly mentioned, we go a long way back, and it's always been an integral part in my career to push for the science to be a very important component of clinical all the physicians and their approaches to treat patients, because I'm sure you'll agree that Banting and Best working on dogs, and right now the vaccines work being done by basic scientists on viruses in a lab far away from the clinic plays a very important role in translating issues to treat patients. So it's always important to use that component to inform clinicians. So I hope that you guys will continue doing this, because it's so important for us to keep that on the forefront of translational medicine and treating patients. So I just wanted to participate in this meeting to give you an update on where we stand with stem cells. So I thought I'll divide my talk into three parts, make a case as to give you a little bit of background about stem cells for those of you who are not completely aware of it, make a case as to why we want to do this in diabetes, and then give you an update on where we stand for since over the last many years I've been visiting Bangalore and providing some insight into this. So I'll tell you what is happening right now, and then close with the challenges that remain in the stem cell field. And I'll try and finish early so that I can make way for the next session. Just to thank all the people who did all the work. Shown on the left is my lab, and the top left are in black are the people who contributed most, Sevim Manoj and Adrian Teo, who all are now independent investigators and collaborators. So I just wanted to give you a little bit of background. I'm sure many of you have read about this or heard about it, that stem cells have people who worked on stem cells received the Nobel Prize uh, in early part of this century in 2012. And John Gurdon was among the first to do that. You can see that he waited for a long time, 44 years or so, to get his Nobel Prize. But he was the first to have this exciting thought that if he could take a nucleus from in a frog and remove the nucleus and put it into a cell, he could generate the entire phenotype of that particular toad. And so he showed that in the 60s, but it took about 44 years for Shinya Yamanaka to come over and demonstrate that in fact you can just take a human skin fibroblast or a blood cell, and then you can reprogram it. They call it reprogramming it by putting in transcription factors, and then that makes it into a stem cell, and that stem cell can be redifferentiated into any type of cell in the body. So that's a remarkable achievement, and that has really driven approaches in clinical medicine and has really jumped onto clinical translational work over the last several years. Here's an example of a human stem cell colony, things that we see in my lab very routinely and many other labs. Essentially, very compact cells, which are shown here, and background of fibroblasts on which they grow pretty well. So the question then was, is it appropriate for us to think about stem cells in diabetes? Just to give you a little bit of this background, I won't go into great detail because I'll touch upon this in a little bit of time. So shown here is the reprogramming approach. I hope you guys can see the pointer. Where adult cells can be reprogrammed by using the transcription factors, using a multitude of different approaches, episomal reprogramming, peptides, RNA, or viral approaches. And then you can make adult stem cells. And so you must also, you might also remember that when George Bush was the president, we had a huge issue about using stem cells, embryonic stem cells, which had ethical implications. And now we use adult stem cells, also called pluripotent stem cells, which can be differentiated into the 3 different components, and then those can be differentiated into adult cell types, which are of importance for diabetes. So that was the approach, that you can potentially use these for transplantation, or you can model them in a dish, or use them for drug screening. And what is the case to be made for diabetes, and what are the targets in diabetes? So, but just to make the point again, I'm sure that this has been discussed, and many of you are aware, being in diabetes and endocrinology. But you can see that when we're all born, we are born with a certain amount of beta cells. And as we grow older, the number of beta cells increase. And it is thought that by the first or second decades, you have a certain number of beta cells, which is around 100%. So when one becomes obese, these beta cells can keep increasing, and they can compensate for the insulin resistance, which coexists with obesity. But you don't get a diabetic because the beta cells are able to compensate. So you can see that they go from 100 to 150. Successful compensation, there's no diabetes. But it's only when you start failing to compensate that this red line starts dropping, that you then develop diabetes. And this could be because of beta cell death or dysfunction. So this is typically what happens in type 2. But in type 1, you can see that you're already born with a lower number of beta cells. And again, this is a theory that you're born with beta. That has not been conclusively shown. But if you're born with a lower number of beta cells, and then you have more number of cells dying, that would lead to a poor compensation, And then you fail to reach the 100% mark here as you grow into an adult. And on top of that, you have an autoimmune attack, and that leads to beta cell birth problem, a beta cell death problem, and also considered MODY. But the important distinction here is that there's no insulin resistance or diagnosis. So both of these scenarios argue that beta cell is the chief culprit here in all forms of diabetes. So if you're able to somehow regenerate beta cells, that would lead to overcoming or reversing the course of diabetes. And so that is really the argument that beta cells is a major target. And of course, there are people who argue that hepatocytes, adipocytes, and muscle can also be important, but I think the general consensus now is that beta cells are critical. And is there evidence? There is hard evidence. As long ago as 1955, you can see quantitative estimation of pancreatic islet tissue in diabetic patients. Ogilvy and McLean actually weighed the beta cells a long time ago. And you can see in the controls compared to diabetics, the weight of beta cells is way down. Alpha cells are no different. So clearly, again, arguing that the beta cell mass is lower. And more recently, Butler's group has shown again that individuals who are obese, they show an increased beta cell volume, shown here, and those who are getting impaired glucose tolerance, in spite of being obese and the compensatory effect, they're showing a decrease, and lean and obese diabetic individuals show a decrease in beta cell mass. So there's no doubt that beta cell mass is lower. So how can we regenerate beta cells? One is by replicating pre-existing beta cells. This has been shown conclusively by many groups, including my own group here at the Joslin. You can differentiate them from progenitors in the ductal epithelium, also called neogenesis. They could be transdifferentiated from acinar cell types or hepatocytes to beta cells. And then you have differentiation of stem or progenitor cells, and that is where you have potentially a pinch of stem cells that could play a role in generating more beta cells. And after Yamanaka and Gurdon's landmark achievement, stem cells has taken off in a big way, at least definitely in the diabetes field. So as I mentioned, the stem cells, embryonic stem cells, can be differentiated into multiple adult cell types. But as I mentioned, compared to the embryonic stem cells, you have adult cells, which we can take fibroblasts from an individual or blood cell, then convert them to pluripotency, and then develop them into different cells like cardiac muscle cells or pancreatic insulin secreting cells. So in addition to beta cell, there's also there are also efforts to convert induced pluripotent stem cells, or iPSCs as they're called, into different cell types. So clearly beta cells are among the top, among the targets, but you also have neural cells, which can be used for neuropathy and stroke, retinal cells for retinopathy, cardiomyocytes, cardiovascular disease, complications of diabetes, and nephropathy is another complication of diabetes. But you can see that even in type 2, in addition to the beta cell itself, there are efforts to develop hepatocytes, adipocytes, and skeletal myocytes. And each one of these have been progressing at a very fast rate. I won't go into this, we have just discussed this. So in the context of the beta cell field, the efforts of many labs, including commercial companies like ViaCyte, which I'll get into in a few minutes, have engineered approaches to develop precursor cells with the hope that you can transplant them into diabetes, individuals with diabetes, and also potentially those with complications. And there are several articles here to argue for where we are headed, and it is moving in the right direction. So here are 3 different articles where labs have generated human pancreatic beta cells. So on the left is Tim Kiefer's group, which is among the most followed the protocol is very popular among the scientists. Then you have Doug Melton's group and also Matthias Hebrock's group. So each one of these have engineered skin cells to be generating insulin-producing beta cells. So I want to spend a few minutes on the complexity of this before I go into where we stand with the current state, because understanding this will give you an idea as to why we are at the current state. So the challenge is that the pancreas, as opposed to hepatocytes or adipocytes, which are single cell types in that environment, mostly single cell types. I'm not talking about endothelial cells which supply the cell, the cells within a tissue, but the pancreas has got two components, as all of you are aware, the exocrine and the endocrine. And then you know that the exocrine makes up over 98%, the endocrine makes up only about 2%. But if you look at the development of these cells, starting from the inner cell mass all the way from birth, it has to develop into the definitive endoderm and goes on through these different stages all the way to stage 8, where you have these mature beta cells which are responding to glucose or potassium chloride or GLP-1. So this is a long process, takes about 9 months, right? When you after conceiving, it takes 9 months. So it's a complex process. But what we have now converted this 9 months is into 5 weeks. Those few examples I gave you is even in my own lab, we can take a skin cell and now within 5 weeks, we can develop them into beta-like cells. So you could argue that we are missing many things here, because why does it take 9 months in the normal state of affairs, whereas we are now truncating it to 5 weeks? So clearly, we are trying to short circuit this and develop them into mature cell types, and we must be missing some steps on the way. So over the last 5-8 years, we have realized that yes, we are missing many of these steps, and that's why we're still a little bit stuck. So this last stage here is a question mark, because we have not reached the final stage of mature beta cells, and therefore we call it beta-like cells. And I'll tell you why that is. So here is the challenge that we have, that soon after days post-coitus, that is, after you begin to track these cell types, you can see that you have a number of transcription factors. So the list below each of these cell types is a list of transcription factors which are either present or absent. And so the absence of certain transcription factors allows the activity of other transcription factors. So you have activators or repressors, and each one of these is playing a very important role to push this cell type to diverge into different cell types. So for example, at this stage, you have a biliary duct, and at this stage, you have the pancreatic bud, which then goes on to develop into the tip progenitor, into the Essner cell, and the trunk progenitor goes on to develop into, again, a different truncation here, where it either develops into a duct cell or a beta cell. So all these different transcription factors are critical, and we are trying to generate this in the lab in a very short time period. And so that is the challenge that we have in finding the final beta cell. So going back to this, my group and other groups have tried to modify this approach. And so shown here at the top again is where we are at, the stage 8. And at the bottom is an example for you to see how the stage 1 all the way to stage 7 has been engineered by using all these different chemicals that we have used to replace the transcription factors. So for example, FGF7, fibroblast growth factor 7, a vitamin C is used to push the stage 2 to stage 3. Different types of chemicals here, retinoic acid, ALK5, D3, which is one of the thyroid hormones, pushes the stage 5 towards stage 6. So this has come with trial and error and a little bit of educational guesses, but the challenge still remains that we are using this approach in multiple labs to push towards getting this mature beta-like cell, and we have reached all the way up to stage 7. So I know that you might be getting bored with all this, what is happening, but you guys need to understand this, because here's what you guys want me to talk about. Okay, well, what's happening? Tell us about the clinical trials, right? YSight, what happens when you put them in a patient? So YSight is one of the companies on the West Coast, which has been working on its own, as well as taking tips from academic labs to come up with how to generate stage 7 cells. And here's the breakdown of what they've been doing. So this timeline is from 2005 to 2020. And as I mentioned, 2006 was when Shinya Yamanaka showed the derivation of the pluripotent cells, and they immediately went into commercialization, and they could show by 2008 or 2009 that you can derive these stem cells, put them into mice, and then you can cure the mice. So that was possible. So there's something going on in vivo or within the body which matures the cell type. So you can put stage 6 or stage 7 cells into mice, make them diabetic, and the mice get cured of the diabetes because something in the body of the mouse will mature the stage 7 to stage 8 cells, and they become glucose responsive. Let's fast forward 2014. They went on to show the iPS-derived beta cells in vitro, human beta cells, and they had the first IND and clinical trial. And just have to mention that there's a long gap here because they did not report any of this. And the reason why they didn't report was it was not successful. So they used a number of patients who had brittle diabetes. So selection of patients is important. Those individuals who are unable to control their diabetes were the first clinical recipients of these stem cell derived beta-like cells. But unfortunately, none of them showed a response in the right direction. So then they moved forward with 3 different approaches. One is called the encapsulated approach. So shown here is an example of these cell types, which within an encapsulated container, and they've developed 2 other additional components here. One is shown here. In addition to just putting beta cells, you got to put blood vessels in as well. So they have this PEC plus blood vessels, which is shown here, that allows a better blood supply to these cells because some of these cells in the middle might be getting damaged. So these trials are going on right now. So just last year, they were able to detect circulating C-peptide in these patients implanted with the PEC. And we are still awaiting what happens to the rest of the patients in 2020. But I just need to hasten to add here that diabetes is not fully reversed. So they can show the presence of C-peptide, but not been able to show whether the insulin that is being produced is able to bring down the hyperglycemia. So I just wanted to stop there, and that's where we stay. We stay in the context of diabetes, that we are awaiting these clinical trials by the commercial companies, but there are other labs like my own lab who are using these stem cells approaches, trying to figure out what is the last stage. The last stage is how do we make it glucose responsive. So they look like beta cells. Everything is beta-like, but the only thing missing is response to glucose, which is the most critical thing when you want to reverse hyperglycemia. But there are other applications of stem cells. For example, in my own lab, we are looking at MODY, maturity onset diabetes of the young, for example, in HNF1 beta. I won't go into detail, but just one example that you can take fibroblasts from patients with MODY. You can derive the beta cells from those individuals and study those beta cells in great detail, which otherwise is not possible. So you could begin to look at what are the functional defects in these individuals. We can also look at complications. We have derived beta cells from patients with long-standing complications, the medalist group and the Jocelyn, individuals with more than 50 years of type 1 diabetes, and we can learn more about how their complications can be countered. So there are other applications of stem cells. And the final one is genome editing, where again, my own lab and other labs have looked at how you can take a cell type, edit the particular defect in that cell type, grow them in large numbers in the bench, and then put it back into the patient. So this is in theory, but some of these approaches are moving more towards clinical challenges. So are we there in terms of trying to go to a shop and then ask for a specific cell type for an individual? We are not there yet, especially in the context of diabetes. Many challenges remain. I'll give you a couple of them. First of all, getting enough numbers. So let's say you got all these different cell types. Can we get enough numbers? Yes, that is possible. We can get large number of these beta cell types of that particular individual once we convert the stage 7 to stage 8. The other important thing is, what are the long-term effects of these cell types? That is something we don't know because we have never tried it. Appropriate delivery of cells. So let's say you have all the beta cells and the beta cells are working perfectly. Where do you put them in the patients? Do you put them under the skin between the interscapular region? Put them on the arm? Do you put them in where the pancreas is, which has the portal circulation? So the portal circulation becomes an important factor here, because we know that the first tissue that the insulin secretion hits is the liver, where it shuts down glucose production. So can we put them into the portal circulation? That's a challenge. Can we put them in the omental pouch, for example? So the YSide guys I just mentioned have been putting them into just on the back where the cells are easy for access, so that you can take samples at a given time to biopsy them for making sure that the cells are not getting carcinomatous. So it's important for us to consider the appropriate delivery of cells. And finally, I think the off-target effects, right? We want to make sure that the cell type that we have is producing the appropriate hormone or having that particular function. And that we don't know yet because we have not done these experiments. So I think that we are still in the process of trying to figure out off-target effects. But I just don't want to leave you with the feeling that we won't do much. But two examples, I think I'm running out of time. Two success stories is generation of these spinal neurocortical stem cells, which can be used for injury, macular degeneration, or Stargardt's macular dystrophy. So there are two examples where stem cells which have actually helped in these individuals. And so I think I'll stop there and running a little bit over time. Thank you very much.
Thank you. Thank you, Rohit. I think before we bring Alison in, let's take a couple of questions. I don't know if there are any in the chat box, but I want to start off this with a pregnancy is an important state of adaptation of the beta cells, right? And while many of us talk about obesity as a compensatory mechanism, probably pregnancy is something that's even more physiological. And are there any lessons to learn from pregnancy, changes in pregnancy in the beta cell, and how does that apply to our understanding of, let's say, neurogenesis or regeneration of the beta cell?
Yeah, that's a great question, Krishna. I think that's an extremely important point, that we have a lot to learn. We continue to learn from pregnancy because that's a classical example of, of two individuals, right? Essentially, it's two individuals. One is accepting of the other in terms of the immune system as well, and you find that the mother is producing more beta cells to compensate for this large relative insulin resistance. So there is a lot that we have learned in that context, but I don't know whether we have really hit hit any specific point which we can move towards the translation. We know that lactogenic hormones are playing a big role. We have used lactogenic hormones to generate more beta-like cells from stem cells. So they do coax the replication of these cell types, but they don't seem to be important in that last step of maturation. They can replicate the beta cells, but they don't necessarily make it glucose responsive. So I think that last factor is still continues to be missing, whether it's something in the fetus itself, which is making that, which we don't have access to, or whether it doesn't, go across the placental barrier. But that's an important point.
What do you? I mean, if you were to wear your long focal lenses, where would you see the future of this going? In the sense that, do you think that the pluripotent stem cell that's being made right from the beginning and manufactured all the way till the final steps is going to be make it ultimately into clinical practice, or do you think that we will grow a part of it in the lab and then let it mature inside the body and where it's protected and encapsulated?
Yeah, that's a good question. The feeling in the field right now is that we're almost there in terms of trying to find the maturation of that final step. So if you are able to do that, the challenge for us continues to be beyond that. So let's say we achieve this point of the final step of maturation. The challenge continues to be, how do you put it in? Where's the optimum site? And what is the long-term effect of these? How are we sure that, let's say that, are we happy to give it to our own kids who have diabetes, right? That would be the ultimate test. So are we sure that these cells will not become teratomas? So those are the points that we are trying to address going beyond this maturation. Maturation is still an important point, but 5 years later, we'll be talking about, is there some kind of a marker will tell us that these cells are not becoming non-beta cells? Because the first thing we don't want to do is do no harm. So we want to make sure that they don't become teratoma. So is there some kind of a marker that tells? So some of us have started working on those aspects as well to try and make sure that the long-term off-target effects are not being a major factor. So I feel that in a few years, we'll have this maturation stuff worked out, but we'll be struggling with, where do we put it in, how do we put it in, and how do we make sure that we give confidence that these cells don't become anything other than beta cells.
The last question is from this end, and we have to move on. And that is, Dr. Powers and of course the organ donation network, that work that was going on actually showed that that when the alpha cell is placed close to the beta cell, its behavior is very different when you have a bunch of beta cells and the alpha cells are somewhere around. Now is that a consideration when we look at stem cell therapy for diabetes, growing it in the lab? Do you think we should also put the alpha cells along with this?
Yeah, I didn't get into that part, but you're right. The alternative approach that others are thinking, including Al Powers and others, is the organoid approach. That the entire islet forms an organ, right? It's like a small structure of its own. It's got the 80% of beta cells, 20% of alpha cells, a smattering of delta cells and PP cells and ghrelin-producing cells. So maybe we should start with forming the organoid right in the beginning and then transplant the whole thing into, but that is still far, far away, because trying to first of all, getting alpha cells has been reached, but getting them into the organoid structure and the right mix of cell types is still something that is not reached the stage yet.
Thank you, Rohit. It was wonderful. And may I bring in Alison Goldfein at this time? Alison is a friend for many years, formerly worked at Johnson Diabetes Center. Right now, she's at Novartis, but more importantly, an accomplished clinician who can take what Rohit does into clinical care and then provoke Rohit back into thinking, how can I work this out? So I'm going to leave the two of you together, Rohit and Alison, and and whenever required, I will come in. At the end, we will, of course, have a discussion. Rohit and Alison, it's yours. In India, Jugalbandi means two maestros doing their own thing together and in collaboration. Rohit and Alison.
Dr. Krishna, thank you for the very warm invitation. We're going to just hold a discussion that's very similar to the way in which we have worked for many years together to advance our understanding of biology. That translational medicine is thought of in 4 major bins, from the original basic scientific discovery and typically through to clinical insights, implications for practice, and then for population health. But what I really want to point out is that there's a lot of journeying back and forth between observations that you can make in the clinic and bring these to partnerships to better understand the underlying biology. And this is just going to be one example of this sort of a back and forth discussion, an iterative process to understand biology. Rohit, I'm going to actually ask you to explain a little bit about the regulation of glucose homeostasis and how it's possible that insulin signaling at the level of the beta cell might actually be important, and why this is something that we should care about in people.
Yeah, thanks very much, Alison. Good to see you. Are we sharing the slide? Is there something?
I am sharing it according to my screen.
I don't
Are you not seeing it?
Krishna, are you seeing it?
No, we can't see her slides. We can see her. And well, now we can see you. But...
You can see me. Well, I have share screen on, and my option is to hide the screen. I can try it again.
Well, your video has gone off now.
All right. Rohit, you better pull up the backup because I now don't have the share screen option anymore.
You don't have that? Okay, let me see if I can do that.
Sometimes if you could just move your cursor around, the options pop back up. Sometimes they get hidden and they go into your screens.
Can you guys see this now?
Yes.
Is that okay?
Yes.
Okay, great. Yeah, thanks, Alison. It's fun to chat about this again, considering the recent developments. So I guess that's the disclosure slide.
Yep.
So,
and this was where I was simply making the point about the journey, the translational journey is bidirectional here. And that you and I have lived at the T1, T2 intersection between clinical insights and basic scientific discoveries. And then I was asking you to please go into the insulin resistance and beta cell dysfunction that underlie type 2 diabetes and how these might be connected.
yeah, so as you mentioned, Alison, I think I'm sure this slide is something that most of the audience has been looking at, but I just wanted to bring attention to the bottom left where the islets are also regulated by insulin itself. So I just want to go to the next slide where we have shown this in the mice. I mean, I think that Dr. Goldfein has put mice or men on each slide, so you guys can know whether we're talking about mice or men, but mice or humans, I should say. So we started this journey a long time ago in 1998, 1999, when others showed the presence of the insulin receptors, and we went on to show in my own lab that these receptors are indeed expressed on the beta cells, and that they have all components of the signaling pathway, which is important for cellular function, similar to what you see in hepatocytes, adipocytes, and so on. So shown on the right are those points here that glucose and insulin can phosphorylate many of these proteins, and that insulin is able to regulate calcium and stimulate insulin secretion in isolated beta cells. And then we went on to show also that when you knock out these receptors or substrate proteins, for example, if you knock out insulin receptor substrate 1, you get large islets. You knock out insulin receptor substrate 2, which is in the signaling pathway here, you get small islets. So clearly telling us that there's a direct relevance of these proteins in the beta cell. So the question then what Dr. Goldfein asked was, what would happen if the beta cell itself is insulin resistant? And then one way to do that would be to remove this insulin receptor. So you don't have insulin action in the beta cell, and therefore, in theory, it would be insulin resistant. And we went on to show in my own lab, this is 1999, that these mice called the beta cell insulin receptor knockout, or the Burko mice, when you inject them with glucose, compared to the control, which show this acute phase secretion and a second phase secretion. I'm sure all of the clinicians are aware of the acute phase release of insulin after a meal, for example. This is blunted in these mice with the insulin receptor knockout, and the second phase is also reduced. Again, arguing that if you just take away the insulin receptor only in the beta cell, not in the muscle, liver, or adipocyte, there is a defect in these animals, and they become glucose intolerant. So shown here is a glucose excursion of the control in yellow. You inject glucose, it goes up to 300, comes back almost to normal, and excursion is much higher in the knockouts. And this appears to also be reflected by a reduced beta cell mass, which is quantified here as insulin content, suggesting that taking away the insulin receptor has all the hallmarks of type 2 diabetes: loss of first phase secretion, glucose intolerance, reduced beta cell mass, reduced insulin content. And so we began to look at what is the effect of exposing these beta cells or these mice to insulin, and see whether that itself has an effect. That is, insulin is able to stimulate its own secretion, a positive feedback loop. And so we went back to my lab where we exposed these islets or beta cells to either no insulin or to 100 nanomolar insulin, and we tracked the insulin release as % content. And you can see that when there's no insulin, there is a small bump after you stimulate them with glucose. But when you pre-bathe these islets or beta cells with a higher level of insulin, the insulin secreted after glucose stimulation is much higher. And we could do this over a period of time, all the way up to 72 hours, shown on the right side. And we chose this 72-hour time point because when I was discussing with Allison, who used to be just down the corridor, she mentioned that if you wanted to translate this to humans, we have to expose this for a long period of time, right? Not for a few minutes, but for hours, and therefore the 72-hour time point. So here the data was now ready for being translated to humans. And after a lot of discussions with Allison, also she got excited, went on.
So I think this is very novel, Rohit, because to show that you could stimulate the beta cell function. But while long exposures may more closely mimic longer duration physiologic differences, it's very hard to manipulate the insulin and glucose levels in people for 72 hours for 3 days at a time. And 100 nanomolar insulin is really beyond the physiologic levels and is into a high pharmacologic level. So I asked you to go back to the laboratory and see whether or not conditions that I might be able to do in people would still provoke this a magnitude of response that might be measurable.
Right. So we did that. On the left, shown in the yellow, is the 10 nanomolar insulin, and you can see that you still get a response when you lower the dose from 100 nanomolar to a 10 nanomolar insulin. We showed that with 72 hours on the right side, as well as on 4 hours, shown in blue. So we had addressed the 2 points that Allison had raised, the lower levels of insulin and the time duration. of having an effect. So we could then begin to think about how we can design an experiment in humans.
So I am ready with this information that you provided from the animal and cellular work to try to take this into people to understand whether insulin signaling might be important in the human beta cell. Next slide. I have a series of hypotheses then that we worked on together that we would test, that the beta cell is indeed insulin responsive and insulin will enhance glucose-induced insulin secretion in healthy people. That dysfunctional insulin signaling at the level of the beta cell could be one mechanism underlying the blunted insulin secretion in patients with insulin resistance and type 2 diabetes, in which case the beta cells in people with diabetes and insulin resistance syndromes will have reduced insulin augmentation of glucose-stimulated insulin secretion. And this is a lot, so we look at the first hypothesis first. Can we show that in healthy people, the beta cell is an insulin responsive tissue? And in order to do that, I need to be able to change the insulin concentration in my patients, but be able to separate the endogenous insulin, the insulin that they make, from the exogenous insulin, the insulin that I would be giving in order to alter the conditions of pre-exposure. And so I used aspart insulin, also known as Novolog, and there are assays where you can immunologically distinguish between the endogenous and exogenous insulin. And what you can see on the left is that there's good agreement between the ELISAs and the RIAs for the endogenous insulin. But if you look at the exogenous insulin, you can see that the RIA detects it, but the ELISA test will not see whatsoever the insulin that I am infusing. And this was run at a 1 to 10,000 dilution and is not seen by the ELISA assay at all. So if I measure insulin, I can now measure endogenous insulin, and I can not see the exogenous insulin that I'm administering to my people. Next slide. So having worked out those details, we're going to take this into the clinical setting. This is what these infusion studies look like in real life. Next slide, please. And the schema of what we were doing would be to expose patients to either insulin or saline as a time volume control for 4 hours. If we give them insulin, we have to give them glucose to keep their blood sugars stable. And then we have to give potassium chloride to prevent the potassium from moving intracellularly. And then at the end of the 4 hours, we had an 80-minute stimulation of additional glucose, 8 or 10 milligram per kilogram per minute, or whatever it took to keep the blood sugars stable in the patients, whether they were pre-exposed to high or low insulin conditions. Next slide. And what you can see is whether you take the 4 hours of pre-exposure, the isoglycemic period of time, or during the graded glucose infusion, we were able to match these patients' blood sugars very closely so that any effect that we have on the insulin response to the glucose is due to the pre-exposure condition of having the insulin on board or not. And we studied 8 individuals who were young, lean, and had normal blood sugars and normal insulin sensitivity. Next slide, please. And what we were able to show was that the pre-exposure to insulin in turquoise, when they were given the glucose, the same patients had higher insulin secretion rates in response to glucose following the pre-exposure to insulin. Next slide. We were able to confirm this by looking at C-peptide. C-peptide is one of the fragments made during the conversion of the proinsulin to the mature insulin molecule and is a measure also of beta cell function. And you can see that with pre-exposure to the insulin, the amount of C-peptide produced was higher in these healthy insulin-sensitive individuals. Next slide. One of the things that we know, though, is that insulin can suppress free fatty acids. So you can see at the basal period in these individuals at time 0, their free fatty acids on the 2 days were the same. But after we exposed them to the insulin, you can see that the blood sugar, that the free fatty acids dropped. And then after we asked them to make insulin with glucose, if they made the insulin, their endogenous insulin suppressed the free fatty acids, and that these levels were lower. So one might ask whether or not that drop in free fatty acids at time 240 after the high insulin was contributing to the appearance of increased beta cell function. Next slide, please. So the question we asked is, what is the role of the free fatty acid change in the insulin regulation of the insulin secretory response to glucose? If you replace the free fatty acids, would you increase insulin secretory response? Because free fatty acids, as you can see here, are another fuel for the beta cell. Or is the suppression of the free fatty acids necessary for the apparent augmentation of the insulin response to glucose? Are they lipotoxic, so that that's actually what's accounting for this difference? So next slide, please. We repeated the exact studies that I showed you before, but this time asked the group of healthy volunteers to come back on a third day. Next, advance. And on the third occasion, we gave them intralipid in order to maintain their free fatty acid levels. So we could ask specifically whether that augmented glucose-stimulated insulin secretion was regulated by the change in free fatty acids. Next slide. You can see that in the sham conditions where we gave the saline, again, you have no suppression of the free fatty acids at 240, and they go down when you make insulin. On the insulin conditions, you see the drop in the free fatty acids after the 4 hours, and that remains low when they start making their own insulin and with the continued insulin. And in the intralipid condition, we were able to maintain the free fatty acids just slightly above these patients' normal range, but within the physiologic normal range of a large number of people. Next slide. Again, we repeated our findings that in the setting of the isoglycemia, the endogenous insulin secretion was higher in response to glucose following insulin pre-exposure. And when we added in the free fatty acids, next slide, advance, you can see there was no difference in the increased insulin secretion following the pre-exposure to insulin. So that tells us that that was not modulated by insulin suppression of free fatty acids. Next slide, please. So in summary, our data suggests that pre-exposure insulin augments the glucose-stimulated insulin release in healthy people. So my question to you, Rohit, is, does this have anything to do with the insulin processing itself?
Right. Yeah, thanks. And you know, I think Alison always asks me this complex question, so I'll have to go back and figure out what's happening to proinsulin processing. But I think that is a very important question there, because we want to figure out how is insulin regulating this, and is this having any effect in the processing. So just to give you a little bit of background here, you can see that proinsulin gets converted by prohormone convertase 1, and then by carboxypeptidase E, which is shown here, and then combination of prohormone convertase 2 and CPE to insulin. And it's got two different pathways where it splits the 33 to 33 proinsulin, there's 3132 proinsulin, which is makes up 90% of the pathway. But you also have the other one where you have the cleavage at 65-66 proinsulin Lizard site with PC2 acting in the initial step and PC1 with CPE. So we then began to ask whether, we asked then if the insulin receptor knockout of the beta cells is altered, is the proinsulin being altered because of changes in any of these enzymes. And clearly, one way to look at the pancreas section. So taken here is from a control mouse, in this case, the insulin receptor knockout, and you can see the proinsulin in green. I'm sure you can appreciate that it's way increased compared to the control. So that told us that when you just knock out the insulin receptor, there is some defect in processing. So the processing is likely not completed. You don't get mature insulin. And we showed that with quantifying these data here. We took out islets and we looked at the proinsulin content, again showed it was higher. We also did an HPLC of the high performance liquid chromatography, and we could show that in the insulin receptor knockout, there's an increased amount of proinsulin compared to control. And all this was because of a change in the expression pattern of PC1, which is prohormone convertase 1 and carboxypeptidase E. So in the Burco, you can see that the amount of PC1 3 is reduced and CPE is reduced as well. So both of these were contributing to poor processing of proinsulin. So what does this do? Is there a problem now with the processing of the proinsulin? Does it begin to have an effect on the intracellular milieu of these beta cells? One example we know is that when the hormone is being processed within a cell type, if you go back to your biochemistry and physiology, that the hormone gets processed in the Golgi apparatus, endoplasmic reticulum, and then forms the full hormone. So when the processing is blunted, then you would promote what is called as endoplasmic reticulum stress, which is a concept which has come up over the last decade or so. So if there's a proinsulin overload, then there would be a change in this endoplasmic reticulum before it gets converted to the full hormone. And this happens also in other cases like MODY. And indeed, when you look at the beta cells from these knockout mice, there's increased amount of endoplasmic reticulum or ER stress and cell death. So these markers called BIP and CHOP are increased in the insulin receptor knockout mice. The endoplasmic reticulum is dilated and the mitochondria are enlarged, all signs of ER stress, and that can be quantified, shown on the right here. The final question that we wanted to know was, okay, you've got all these defects. How do we rescue it? Can we put back the insulin receptor and we rescue the effect? That would be the classic demonstration that it's because of the insulin receptor defect that you found changes in the beta cell phenotype. So indeed, when you put back the insulin receptor, shown on the left here, so here is the control, you have the knockout, here's another control, which is the mock virus, and then you put back the insulin receptor using a virus. You can see the insulin receptor, in fact, is much higher than the control, but the important thing is it's put back. And then you look at the amount of proinsulin shown on the right. So in the insulin receptor knockout or the mock, the amount of proinsulin is higher. And when you put back the insulin receptor, the proinsulin goes down. And so by putting back the insulin receptor, we have rescued the proinsulin defect. What happens to the reactive oxygen species, which is a part of the ER stress and oxidative stress response? And you can see that at low or high glucose, the rise in reactive oxygen species between the Burco and the mock is rescued when you put back the insulin receptor. You can see that the last bar goes down. So essentially, what we have done here is to rescue the defect by putting back the insulin receptor. So the last part of this argument I wanted to bring up because of the paper which is going to come out in Nature. I'd like you guys to read it. I've written a news and views on that, discussing with Alison. But just to give you an oversight of why this becomes so important, in the normal situation, you have the beta cell, which has an insulin receptor on its surface, and it leads to normal insulin signaling, glucose-stimulated secretion, maintains normal glycemia. Through all these processes, which we have published, other groups have published, maybe about 100 manuscripts now. What the Nature paper tells us that is that in the beta cell, as opposed to the hepatocyte, there's one additional molecule which is regulating the insulin receptor, and it's called IGF receptor like 1. In the normal situation, the IGF receptor like 1 is blocking the effect of the insulin receptor. So let's go back to what we had reported like about 20 years ago. So 20 years ago in my lab, we knocked out the insulin receptor. And I just showed you the slides before that it leads to dysfunctional signaling, it leads to glucose intolerance, and then it leads to reduced beta cell mass. So clearly the insulin receptor is important, but there's been skepticism in the field because when you talk about the insulin receptor, everybody talks about the hepatocyte, the adipocyte, and skeletal muscle. Nobody talks about the beta cell. But this new paper with this discovery that IGF receptor like 1 is expressed only in the beta cell. It's not expressed in the hepatocyte. So if you were to knock out the IGF receptor like 1 and you remove this block and you allow for overactivity of the insulin receptor, then it leads to increased insulin signaling, improved glucose-stimulated secretion, and increased beta cell mass. In fact, it leads to hypoglycemia and improved glucose tolerance. So these data are telling us that what we had observed 20 years ago and then translated that with Allison's lab in humans is really important for us to consider because insulin signaling in the beta cell is critical. Don't ignore the beta cell and just focusing on the hepatocyte, adipocyte, and skeletal muscle, because this finding is coming back in a big way for clinicians and everyone else to consider how we can enhance insulin action in the beta cell to improve glycemia.
So just to bring it back to people, I think the next question is whether or not we can actually demonstrate that insulin signaling is actually attenuated in individuals with type 2 diabetes. So certainly if you take islets from humans who have type 2 diabetes, you see altered expression of insulin signaling molecules, lower insulin receptor, lower IRS1, IRS2, PI3 kinase, AKT2, and increased SHIP, which is an inhibitor of insulin signaling. So all of this suggests that these processes biologically are relevant in people. Next slide. So advance one more just to show you then we were focused on whether or not beta cells in people with type 2 diabetes and insulin resistance syndromes will have reduced insulin augmentation of glucose-induced insulin secretion. Next slide. And here I show you again our healthy volunteers and the increased endogenous insulin secretion that you see after you pre-expose these patients to higher insulin levels. And in the next slide, you can see individuals who are have impaired glucose tolerance, who have higher insulin response and have not fallen off the curve to have lower, you can see, but there's no augmentation when you pre-expose these insulin-resistant people to insulin. And in the lower side, you can see in the final panel, individuals with type 2 diabetes with new onset disease, and you can see again, they have a diminished insulin secretory response to glucose compared to the healthy controls, and less insulin pre-exposure induced augmentation of their insulin secretion. Next slide, advancing it one. And you could say, why are the patients with diabetes not worse? It's because there were some differences in weight and other factors impacting their insulin resistance. And if you put people all together, this is also work being done in this area. M is an index of insulin sensitivity, and you can see the more insulin sensitive people are as you go from left to right, the more insulin secretion they have induced. So again, this is now strong data supporting that across the spectrum of insulin resistance, insulin can regulate insulin secretion. And next slide. This has also been documented by yet another group showing the influence of hyperinsulinemia and insulin resistance on in vivo beta cell function. You can see the normal glucose tolerant group with the steep curve and the impaired glucose response group showing very little insulin-induced secretion rates as across insulin sensitivity. So all of these together, next slide, suggests that insulin itself can augment beta cell responsiveness to glucose and will enhance glucose-induced insulin secretion in healthy people. And dysfunctional insulin level signaling at the level of the beta cell may be one of potentially other mechanisms underlying blunted insulin secretion in patients with type 2 diabetes and insulin resistance. So this is really a very novel pathway to potentially regulate beta cell function And there's increased and recent work suggesting new proteins that may help communicate this pathway. Rohit, can you help us just pull together then a hypothetical model?
Yeah, so this is the model that we are really excited about, especially with the new paper that has come out, which again cements the long-standing view that insulin signaling is critical in the beta cell. So, in development of type 2 diabetes, there is insulin resistance, and the insulin levels start going down, and the beta cell dysfunction goes over a period of time, which leads to hyperglycemia. But I think what we are showing here is that insulin resistance in the beta cell itself will promote hyperproinsulinemia, which in turn has an effect on ER stress, and that would lead to these alterations in beta cell dysfunction and hyperglycemia. So this component here, I think, is important for us to think about. And there are some studies where starting insulin very early plays an important role, but whether we can develop that into a therapeutic is something we can discuss in the question stage. But here's thanks to Allison's group at the top and my group at the bottom. As Allison has mentioned, we need to make sure that people are wearing masks. This was taken before COVID-19, so please make sure that you wear masks and practice social distancing. Thank you very much.
Thank you, Rohit and Allison. This has become a classic in our circles because I see this as a discussion and see how over the years has it evolved. Now, can I throw in and ask you a question? So, a lot of information, especially about diabetes in Indians, coming in, and I refer to the article about the tale of two Indians that was presented, that was published recently. One of the questions I have is, now, what if a population was sort of pre-programmed to beta cell dysfunction? And how does this model fit in that, that there is already an existing beta cell dysfunction that is pre-programmed, and how does beta cell insulin resistance work into this? Can I have both your answers, please? I'm pushing you on this one.
I'm going to go first because it would be very hard to follow Rohit. And that's that, again, the pathways that regulate the insulin signaling, we all express, different proteins to different levels or have potential variants in them. So it's very possible that some of those are more prevalent in different groups. That could be looked at both at the expression level and the functional level, and these could certainly all be tested among the population, but I would say the answer is incompletely understood at this time. Rohit?
Yeah, that's a good point, Krishna. I think that with this new finding of this break on the insulin receptor, we have a tool to begin to really manipulate the beta cell insulin receptor only, because as I mentioned, this IGF receptor like 1, which has been discovered, is expressed only in the beta cells, not expressed in the hepatocyte, adipocytes, and skeletal muscles. So if we can begin to target only the beta cell in the context of this particular molecule, then whatever therapeutic we're going to give will be hitting only the beta cell, and that would enhance the effect of insulin action in the beta cell only, and thereby that would allow the skeletal muscle adipocyte to work on as it usually does, but in the beta cell it would be allowing overactivity of the insulin receptor. So we are doing this experiment in a humanized mouse model where we transplant islets from healthy controls and diabetic individuals and targeting this particular molecule to see whether we can enhance insulin action in this beta cell insulin receptors and thereby improve their function.
One more question is, let me get Lou's question in. Would mutations in IGF LR1 cause MODY? Would we have seen it already in linkage studies? Rohit?
Yeah, so we have searched for that, and maybe, I don't know whether Lou has looked at, this paper has not come out, so it's unlikely Lou knows about it, but we have looked at the data sets that we have in type 2. There is some association of this mutations or variants of this particular gene with metabolic disorders and type 2 diabetes. In fact, Alison and I were discussing about this. Nothing distinctly linking with Modi, but whether it itself could be classified as a Modi, we don't know yet because it's just emerging now.
Rohit, and one more question to you. So one of the, when you look at the evolution of the insulin abnormalities in type 2 diabetes, the first is of course the loss of the first phase response. And the question is there a difference in, is the insulin resistant in the beta cell responsible for both, for just a synthesis, alteration in synthesis, or is it also the release of insulin, for example, docking and merging with the cell membrane? Maybe both of you can take this.
Yeah, so as I showed you, when you knock out the insulin receptor, the proinsulin is being affected. So the processing enzymes are being affected. There is an effect on prohormone convertase 1 and carboxypeptidase E, much more on CPE, which we distinctly showed in the data set. Now the question is whether it links to the distal events where you have the granule formation and the release of the granules, like the snare proteins and the VAM proteins. That there is still not much clarity. We think that there is an effect on calcium flux clearly, but whether that translates to any of those other molecules downstream is not fully understood.
To bring this home, last question to both of you. So this combination of work between a clinician and a basic scientist, I think that's probably a dream come true for you, and a dream for many of us that pretty much remains unanswered. But for future generations of medical students and scientists, where would you think? What would be your advice to them? What is the future of working together, and how important it is for the future of science in general and for medical students in particular? So I think we both have enough, except Alison, the two of us have enough white hair to answer this question. Alison, of course, looks like she'll never have one.
All right. So I think that the future, of the work, as an individual work is to continue to understand the pathways and how we might manipulate that to be therapeutically important to people. But I think from a broader message, I would say anytime you see something that you don't understand, we are not working in a silo anymore to ask the questions, to bring your clinical observations. Many really important medical observations begin in the clinic. And make sure that you're discussing these with others, and reach out globally now to people who you may not know, who may be able to help you understand an individual patient's disease. It may spring an entire line of research that could be really important for the care of others. So I would say that from the point of view, there's much that we haven't understood that we touch upon about insulin signaling and beta cell biology, within the scope of what we're doing. But the more important is to really raise questions from your clinical observations when people are not falling into the buckets that you would expect. To me, those are, or presenting with unusual manifestations of the disease. Those are the ones first to raise questions on. Only on a global scale, you could even say, why does one person respond to one therapeutic intervention and not another? And how can that take us back to understand the underlying biology? So ask questions.
So maybe I just can interject here also to mention that, the highlight for me has been this association with Alison, because this is what is science all about, right? Science, clinical medicine is under the purview of science. And so having this interaction between scientists and clinicians is what is so critical. And I think that in India especially, things need to be done. And I would point the finger to the white-haired folks on the panel, as well as others in India, where I think this has to be pushed even further in India. And you guys need to be doing it. We can come and give a talk, but the guys at the policy level, you guys need to be pushing this. And I've been saying this for the last many years, but I want to emphasize again that trying to inculcate this clinical scientific intersect and making it important, make it relevant right from the beginning of training, goes a long way to push this, because you'll just need to identify one or two folks who might go on to make great discoveries. But this has to be inculcated. So I think I'll stop there. Thanks.
Thank you both. My other hat is a medical educationist, and I can tell you that the National Medical Council, previously the MCI, in its undergraduate regulations, has now actually provided time to go take a project, to do research, to ask questions, self-directed learning. I think those are good first steps. But I think the most important thing is also the way we start questioning our students instead of asking what. More of why and why not seems to be the way. And it's not anything new. It's Bloom's taxonomy from the 60s. That why and why not probably are more important questions that we need to ask our trainees rather than how and what. With that, I see some more senior people than I am, and I'll hand over to Prasanna, Dr. Mohan Du, and I just saw Arvind in a Zorro mask, but that seems to have disappeared. Thank you, Rohit and Alison. It's just wonderful. I hope I can meet you soon and take this forward. And thanks for bringing this translational medicine classic for almost 10 years into India. We really appreciate this cause that you've done to science. Thank you.
Thanks very much.
I think before Prasanna Kumar comes in, may I request Dr. Mohan to say a few words about the passion that Dr. Rohit and Alison has for some kind of serious research to start in India?
I think Rohit hit the nail on the head when he said we have to start early. And the problem in India is that whenever we go even to our teachers, this happened to me all the time, but I was an exception in some ways. But when we go to our teachers and say we want to do research, they'll say you first finish your MBBS, and then they'll say finish your MD, and then you finish something else. And by the time you're 30 years old, 35 years old, there's no fire in the belly for research. And that's where, unless we catch, and I'm very happy that Krishna mentioned that now in medical colleges, they are giving time off. I think not only they should give time off, they should give credits, they should give postgraduate merit points for this, and probably money and financial help as well as grants. If all that is given and research is kind of made a priority, I don't think we have enough, we have lack of brains or lack of interested students. It's just that they're not given an opportunity. And who knows that we might have another Rohit or another Alison coming out from our own students.
I think before Prasanna Kumar starts, a word about what Prasanna always used to tell us. He would always say MD means money doctor, PhD is a poor, hungry doctor. Prasanna, with that, you can always take over and then continue to moderate the next session.
Good evening, everybody. Welcome for this session on precision medicine in diabetes. It's a very important aspect of diabetes, and very few people are working on that. And very few doctors are aware of precision medicine, which is probably a medicine of the future. We have three stalwarts to speak upon that. First, I have Lou Philipson, who is speaking about precision medicine in young onset diabetes. Professor Lou Philipson is the James Tyree Professor of Diabetic Research Care in Department of Medicine and Pediatrics at University of Chicago. He is the founding director of Kohler Diabetes Center, served as the 2019 President of Science and Medicine of ADA. He received Banting Medal for service as part of the 79th Annual Scientific Session. And in 2018, he was inducted as a lecturer laureate of the Lincoln Academy of Illinois and highlight of the honor of the state of Illinois. Over to Lou Philipson for his talk on precision medicine in young onset diabetes. Can somebody give him the screen sharing, please? Yeah.
Okay, I'm unmuted, but I'm not sure what you're seeing. Let me see if I can. See.
We can see your slides. Yeah.
Okay. Do you see the slide itself or the
No,
the
you
whole
have
show?
to make. No. We need the slideshow. You have to change. Otherwise, we are seeing in a small.
Yeah, this is good. This is good.
Yeah.
It's okay like that?
This is not good. This is the...
Yeah, not good. Well, hold on 1 second.
Why?
Let's see.
I think you have to go to the slideshow. Krishna, mute and speak on the phone.
So, How about now?
Yeah, this is
Perfect.
fine.
Very good, very good.
Okay, great. Well, I can't thank you enough, all my friends who are part of the organizing of this amazing effort to encourage science and the international spread of information. So I'm just delighted to be part of it from Chicago, where we're having our own COVID issues, and I may say a few words about that as we go forward. I've been very clinical the last 2 weeks on the consult service, so not a lot of patients, I think, for India, but I've been seeing 25 to 35 patients a day the last 2 weeks, many of them with COVID, and I'll probably insert a few words about that experience. So I'm going to be speaking today about this intersection in two of my favorite subjects that, in fact, Dr. Mohan is also very involved in almost completely, in terms of both the idea of precision medicine, where we're pleased to have the representation of the good doctor from Chennai involved in this international effort, and also the importance of genetics and understanding the differential diagnosis of diabetes in young people and young adults in particular, but as I've said lately, children of all ages. This is the take-home, these two slides are the take-home messages from what I'm trying to say today, to really understand, first of all, what we're talking about with precision diabetes medicine, which is a very big effort, really essentially both the United States, Europe, India, rest of Asia, Africa, China, all involved in this effort. And what is it and how are we doing it? The second point is to understand a little bit more about dominantly inherited diabetes, but also the differential diagnosis. When a young person has diabetes, it's not probably going to be one of these things, but it's useful to think about. And how a correct diagnosis of diabetes is always critical and part of our understanding of what precision medicine might be. And then once we understand that, how this can be used to optimize care and quality of life. I'll actually quote Dr. Mohan here that he and I have been practicing medicine since the 80s, and the genetics of people around the world haven't changed, and yet diabetes has exploded. So clearly genetics alone has not changed, but the underlying genetics may partially explain the increase in diabetes in various ways. And in particular, the study of monogenic diabetes in young people has helped us understand the utility of specific kinds of therapies. And we're only really beginning to understand how some of the newer agents like GLP-1 agonists may also help some of these key syndromes. So to just take a minute or two to understand precision medicine and what are we talking about here. So it's been now an evolving concept. Here are two of the, at this point, classic papers, which are all of a couple of years old in understanding precision medicine. The first one by Fittipaldi, McCarthy, Flores, and Paul Franks is also quoted in our website on the American Diabetes Association. And I've had the pleasure of working very closely with Dr. Franks in Malmo over the last year and a half or so to further this international effort that is going to be featured in an upcoming conference which Dr. Mohan is helping to organize. Andrew Hattersley and his group at Exeter has also been key in understanding both the genetics and the implications for how we understand, perhaps, can we use simple clinical measures, to quote one of his papers, to further this idea of specific treatments for specific manifestations of diabetes. This consensus report recently was published, and I was pleased to have a small role, published simultaneously in Diabetes Care and Diabetologia. You can see various international groups have been sponsoring these studies. The report, I think, has captured a lot of interest, and as I say, a second follow-on set of studies for comprehensive reviews of various aspects of precision medicine is coming on. In a nutshell, it's stepwise idea for incorporating and building evidence for quantifiable, implementable, probabilistic outcomes based on data. So this is practically revolutionary when it comes to diabetes. And we're not talking only about genetics, and while genetics is important, it's really just one of the beginnings. We're talking about understanding risk factors, regulations, patient engagement, education, such as we're doing today, and how to translate this to the clinic, but then also importantly is patient feedback. All of these things are really critical. Now, some of you have seen this slide not once, but many times already. This young lady entered my life now, 15 or so years ago, and it was a intersection of both basic science and clinical accident, I would say, that led this change in my life and those of many other people because of meeting this young lady. I had already been studying the particular channel. So this is an ion channel idea that is critical in insulin secretion in beta cells. And that study from early parts of my career helped me understand the importance of some papers that had recently been published by the Hattersley Group and several others, Susuma Seno, the Bryans around the world. So when I met this young lady who had diabetes essentially from birth, we immediately understood, even before the paper had come out, just like Dr. Kulkarni told us about a paper that's about to come out today. I had seen this paper in 2006, just a few months before. And we realized that this young lady might have a mutation in a gene that was actionable. We were able to identify that because of our proximity to Dr. Graham Bell's lab and other people in Chicago who quickly were able to do the genetics. And at that point, we were able to switch her from insulin to pills. So that was a big insight, and it's really changed our lives here in Chicago and many people around the world to really focus on understanding how rare forms of diabetes can impact our treatment. So most of diabetes is really polygenic. So type 1 diabetes, which is at least in some populations, clearly highly linked to the HLA locus, and so related to many other kinds of autoimmune diabetes. So for better or worse, we call it type 1. We don't know what causes it. We don't have a great treatment. But in the United States anyway, it's accounts for about 50,000 new cases a year. In India, about the same number of cases, but percentage-wise, of course, much, much less. And because of the immediate need for insulin, if there's not insulin available, people will die very soon. What we're seeing in the time of COVID is delayed diagnosis. And we have in the hospital, just in the last 2 weeks, several people with new diagnosis or recurrent admissions with A1Cs 17 and above, something that many people have not seen in decades. Type 2 diabetes with some aspects of insulin resistance, at least in the West, in the United States, linked to obesity. These two, which again, polygenic etiology, in many cases unknown. Dr. Mohan is, I think, going to talk about some new ideas in heterogeneity of type 2 diabetes, which is something we're very interested in, combining genetics with phenotyping. So these two things are, as you well know, most of what we see. But when we see folks with unusual forms of diabetes, we have now a new kind of analysis of syndromic versus non-syndromic forms. And frankly, now that I'm is steeped in this aspect of thinking, plus my clinical responsibilities, I don't see hardly any patient which I would say now is typical. Everyone is atypical in some interesting way, but to have everyone fit into some sort of predetermined set of criteria becomes increasingly difficult. So we have this idea of monogenic diabetes with dominant inheritance contributing to both very early onset diabetes in the first few months or year of life, with later onset as adults. And in some cases, when it's missed, we can make these diagnoses much later on in life. So together, these account for only a few % of cases. I do need to mention that occasionally papers will come out with different statistics, and I saw one just yesterday from a group in South Africa. It's very important to understand what is a mutation that is pathologic versus simply a variant in one of the genes associated with diabetes. And we'll come back to that in a moment. That first case I mentioned illustrates the key aspects of this integration between basic science and clinical medicine. This is a cartoon that I think, again, is at this point quite old, so it's been repeated multiple times, but the idea is the insulin secreting cell is kind of an electrical switch that integrates a large number of signals from the outside into the interior of the beta cell, allowing immediate action like electrical activity, which then changes the state of the depolarization of a cell, just like a neuron or a muscle cell, and that leads to insulin secretion in a nutshell. And that these key channels that are either regulating potassium or occasionally calcium can be broken. But as we heard, then receptors, the insulin receptor or potentially IGF receptor-like activity also transmit signals, but also things like GLP-1 and then metabolic signals, which are organized, for example, by glucokinase. The overlap is impressive. So this is already an old paper, which, it's entirely 4 years old, which attempted to list some of the major genes which are present in both type 1 and type 2 diabetes. And you can see that there's an overlap. Dr. Prasanna Kumar once told me about a case he saw with a GLIS3 mutation, so overlap with, or a potential GLIS3 mutation. I don't know that we ever nailed that down, but the idea that there's overlap in type 1 versus type 2 diabetes. What's interesting too is one of our new research efforts is looking at genes that are monogenic autoimmune genes. So several groups around the world have been very interested in this, the Hattersley group, of course, as well. We've recently found a case of this gene. I don't know if you can see the cursor, but SCAP2 is a gene that is involved in monocyte and macrophage function and was linked to type 1 diabetes. But now we have at least one individual who has multiple autoimmunities, including type 1 diabetes, because of a mutation in that gene. You can see in this overlap between monogenic diabetes and type 2 diabetes that that's a lot of the issue. So some of the variants that are, say, causing some of the MODY genes are also now increasingly understood to be important in type 2 diabetes. So a second case is this one. I've mentioned this before, so some of you who've seen my talks may remember some of the slides, but this is when I met her, a 58-year-old woman who had diabetes since she was 19. And we have this confluence of numbers that her age was 19, her BMI was 19. So by Western standards, quite thin at diagnosis. So what kind of diabetes is that? Most practitioners in the United States would see someone like this and say, she probably has type 1 diabetes. But in fact, she didn't need insulin right away. She was diet controlled. She was on oral agents for a while, including one of the early thiazolidinediones. And then as she had children, her doctors didn't know what to call her. So gestational diabetes, which of course was not correct, type 1, which was also not correct, and maybe a subset of type 2. But she had been transitioned to insulin, and as often happens, she had gained quite a bit of weight over that time and had developed some insulin resistance as she increased her BMI from 19 to over 40. When she saw a new doctor, he took a family history, which is one of the themes of my talk today, and found that here she is with, if you can see here, the arrow, both of her sons had diabetes, and then multiple other relatives, including her mother and maternal aunt, maternal uncle, and their children. So when he thought about this, he decided to do genetic testing, and sure enough, she had a mutation in the gene called HNF1 alpha, which also has been associated earlier on with a thing called MODY3. This mutation causes a deletion or a truncation in the protein. So clearly an important and powerful change in at least half of the genetic heritage in this person. So the take-home message is that BMI doesn't tell you everything, and in this case, it hardly tells you anything. The patient's family history was the clue. Genetic testing was needed to be done to make the diagnosis. The response to low-dose sulfonylurea is classic here, but still a little bit controversial and may not always work. In this case, sulfonylureas were started. A1C dramatically improved. She lost weight without insulin and without worrying so much about hypoglycemia. She's lost a tremendous amount of weight. And interestingly, her children were ambivalent about genetic testing because their identities were locked up in being or in having type 1 diabetes. So I think at least one of her children has now been tested. But still in all, it was an interesting psychological aspect, psychosocial aspect. So these diseases are heterogeneous. They are at least 14 different genes. We look now for over 200 different genes in our standard panel, and really with the decrease in cost, which Still is steep, but we found it now expedient to test all of the genes rather than any particular panel and just look sequentially at the ones that might be of interest. And I've mentioned these other points, the idea that in diagnosis can actually be at any age, onset can be obscure in the case of some of the forms of MODY. Most of the time there is no autoimmunity that's detectable. And again, the set of genes are overlapping. Now, if we understand the role of basic science, HNF1 alpha has been of tremendous importance in, for example, liver cancer. So certain kinds of liver tumors are also associated with mutations in HNF1 alpha. That doesn't seem to happen in MODY3 at all, but there are adenomas, there are benign adenomas in the liver that happen in some people with some of these mutations. So it does suggest that the importance of making the diagnosis goes beyond diabetes. If these, since it's known that the adenomas are benign, but sometimes can bleed, that can really help looking for liver adenomas in some people with MODY3. These are some of the mutations that are known, and the transcription factor here is shown in several different, in the cartoon, with several different important areas. So there's domains that lead these transcription factors to bind to each other. And if you can imagine, I think of these things as tied up as a string of pearls, and at least a dimer, so two proteins have to bind to each other and also bind to DNA in order for this transcription factor to turn on important aspects of both the liver and the beta cell metabolism. Now, this is a map we made a few years ago, so it's incomplete, but what we've come to understand is that many of these variants are actually benign. So, for example, in the paper I just read yesterday, 6 of these red dots were analyzed in a population in South Africa. None of them are known to be pathogenic for the actual manifestation of diabetes. A few of them are associated with various forms of type 2 diabetes. But there are a large number of variants, and this is only a partial list. So it's amazing that more of us don't have MODY, but it shows you the fidelity as we go from one generation to the next. Now, one of the key aspects of MODY3 is glucoseuria. So some of these children can be picked up in a sports physical. They, for example, may be going to a football tryout and get a urine test. They have a decreased threshold for the appearance of glucose in the urine. And we have known then since now the last over 10 years that HNF1 alpha directly controls expression of SGLT2, a gene, which of course is highly resonant since we have a whole new family of genes that block SGLT2. There is some concern that further block of SGLT2 in these folks could be a problem for urination, for water flow, but so far there has not been a systematic study of whether SGLT2 blockade is good or bad in these subjects. We recommend caution. I also mentioned that's been something repeated quite a bit in sort of inside baseball, if you will, is that HNF1 alpha determines CRP levels. So if that's been used as a marker for cardioprotection, it will be falsely low in people with HNF1 alpha and 4 alpha. Now, how many genes are there? This list is 14. As I said, some of these are wrong. Dr. Kulkarni is going to talk about MODY8 in his talk in a moment, if I'm right, and he's talking about exocrine, endocrine, pancreas interactions. MODY8 is one of those things that I rather wish would not be called MODY at all, because it's a pancreatic acinar enzyme, carboxyl ester lipase, which is critical for acinar pancreas, but only indirectly affects the beta cell, but that only is actually a critically important area. But to me, it includes many other important areas, like all of cystic fibrosis, a family that's been described lately with the elastase 1B mutations from a group in San Francisco and Chicago, and any other form of pancreatitis. So if CEL is an example of a rare gene that exposes tremendous interest in this crosstalk, which we'll hear more about, between the acinar cells and the beta cells themselves. So some of these other genes are unfortunately we're not going to have time to do that. I'll mention just one other, which is glucokinase, since in our panel, it's one of the more common genes that we see. In these folks, again, diagnosis can be in any age. There is elevation of fasting blood sugars, but there is no particular progression. It's very mild, and you can see the pedigree here. And the typical figure for glucokinase shows that glucokinase is critical here for fixation of glucose inside the cell by leading to phosphorylation, and then metabolism happens. So with a decreased function of glucokinase, there's a sluggish response. Typically, again, for these mutations, there's a large number of variants. Most of the ones that are actually causing MODY2 affect enzyme function in one way or another. Normal glucose phosphorylation capacity is very linked to normal blood glucose. So here it's shown in milligrams per deciliter, a weird unit that we use in the United States. And the MODY2 effect, you can see, is right shifted. So however you measure the units, there's a decrease in activity, but eventually insulin secretion is close to normal. In those unfortunate individuals who have two mutations, there's no activity at all, and they can have neonatal diabetes. We've advocated, along with many others, that if this entity can be identified, it's a huge win because there's no change before and after insulin secretion as shown here. So the pink color is before, the blue is after, and this is a CGM recording, continuous glucose monitor in this one subject, showing essentially unchanged glucose levels after the insulin pump was removed, and this was 5 years ago. Certainly we know that A1C tends to go up with time, and this is one of the biggest wins that we find in identifying individuals. At least in the UK and the United States, we think that some impressive number of people, at least maybe 1 in 1,000 of everyone, might have a glucokinase mutation that actually causes some particular impact. So we have these two mutations that I talked about today, or two genes, glucokinase and HNF1 alpha. This table from one of our recent papers lists a couple of key points about them in terms of the differences in fasting, differences in presentation, the rarity of complications in glucokinase. Really has told us over and over again that in that case, treatment is not necessary for the most part, except perhaps in pregnancy, and that HNF1 alpha is sensitive to sulfonylureas. The classification of these forms of monogenic diabetes has been distributed into these sorts of ideas, everything from gene expression to ER stress and a variety of other areas. You can see on the right, this exocrine pancreas, which relates to CEL, CFTR, and perhaps even hemochromatosis. In children, again, in most of these, it's typically insulin secretion that is the problem. And I've left out disorders that affect insulin action. So we're seeing more and more, I'm going to skip this slide, we're seeing more and more importance of the insulin receptor itself, and perhaps with continued searching, we'll see a role for the IGF-like receptor 1. It's still complicated. I mean, even though the price of genetic testing has dropped considerably and panels are available, this is not easily done in most parts of the world. So efforts are being made to better understand how to do that and how to get sequencing cost-effective everywhere. But it's still a question of incidence. In our own registry, the far and away the most common mutation that we've seen in now almost 4,000 subjects is the glucokinase mutation, followed closely by HNF1 alpha, and then a variety of mutations in other kinds of conditions. And those are the summaries so far. For those of you interested, Boris Drazen and myself and a few other people put together a book about a year and a half ago, which is a series of case reports. We're also engaged in a study called Radiant for identifying more kinds of atypical diabetes, which has been extremely interesting, but we've just started. We think that understanding new forms will be very important. So if there's one message today, it's to take a family history insofar as that's possible. It may not tell you that there's a genetic cause, but it tells you that diabetes is a familial issue, whether it's environmental or genetic, and that the family unit and larger units of social integration have to be something that we focus on. So again, when you see a young person with diabetes, it will be mostly type 1, at least in the United States, but type 2 diabetes continues to increase in young people, say under 18 and around the world. I've mentioned some forms of these monogenic things, which may not be common, but are incredibly interesting and tell us a lot about diabetes. I want to thank the people who funded some of this work and our colleagues around the world, including, of course, the group at Exeter, my friends in Japan and at Oxford. And I will also thank all the subjects of our research, and I will end there. So be safe, have a healthy new year.
Every time I hear anything on Modi, I learn something new. Next, Rohit Karni speaking about exploring crosstalk between exocrine and endocrine to explain Modi. Kulkarni has already been introduced. So I request Rohit to start his talk.
Thanks, Prasanna. I think I need permission to share the screen. Can you guys see this?
Yeah, we can see this slide.
Go to full screen, please.
Yeah.
Go to the slideshow mode.
For some reason, it's not going into that.
Okay.
Is that better?
Yeah, that's okay. Go ahead. That's fine.
For some reason, not able to move to the full screen. I don't know why.
It's okay. This is good enough.
Yeah. So thanks again for the invitation to talk, and Dr. Philipson has already given you some introduction about the Modi, so it makes my talk that much easier. But again, I wanted to go back to this clinical scientist approach, where we have taken this upon ourselves to look at what is the underlying cause of Modi 8, and I want to give you an example of how we go about addressing the mechanism of the defect in these patients. So as Dr. Liu has already mentioned about Modi, but I just want to emphasize the CEL, which is shown here at the bottom, Modi 8, which is because of a mutation in the carboxyester lipase gene, or the CEL gene. So that's the one that I'm going to talk about. Has all the other features which generally agree with what is considered to be the set of diseases called as Modi. So the mutations in the CEL, the variable tandem repeats, cause a syndrome of diabetes and pancreatic exocrine dysfunction, originally reported by Paul Nolstad's lab and Anders Molven's labs. And the Nolstad lab and my lab has been having a long-standing collaboration over the last 10, 12 years or so, with a lot of fellows coming to the lab to train and to focus on this particular disease. The individuals with this particular mutation typically have a childhood onset exocrine pancreatic dysfunction, but they develop diabetes in adults. And what has been a challenge is, why do these patients develop diabetes? And that has been a conundrum. And as Lou mentioned, most of these MODY genes have defects in the beta cells, but here's an example of a mutation in an exocrine cell, which has an effect on the endocrine cell. So here's an example of crosstalk between the two, and the challenge for us was what was the defect. So just to give you a little bit of the background, the mutant protein is more prone to aggregation. It has been shown to form intracellular aggregates in acinar cells. So shown here on the right is the wild type or the normal protein, which has these tandem repeats, and the mutant gene, sorry, this is the gene, and the mutant gene here is the one which has the defect in this area. The overexpression of this particular mutant protein in acinar cells has been shown to cause a variety of defects, but it's still not clear as to what causes this effect on the beta cell. So that was the aim of this project, which we started maybe like 4 years ago or so. So a very smart postdoc in the lab, Seven Karman, she began to do experiments, a very ambitious project where she wanted to look at the crosstalk between these two cell types. So essentially shown in this cartoon here is a crosstalk which one can plan by growing acinar cells, shown in this cell culture top here, and the beta cells, which is in the outer layer. So these two cell types are being cultured in the same dish with the same culture medium. And you can manipulate these cell types by either having a normal cell expression, which is the carboxyester lipase, or the mutant cell expression. So the acinar cell here is either having a wild type or a mutant. And the question we're asking is there something that is going from the acinar cell to the beta cell to cause a defect? And one way to do that is you do this culture, and then you collect the culture media, and you look at the protein in the media, or which is bathing the cells. And you can see that the cell protein levels, which is the normal, is expressed at high levels in the culture media, but the mutant protein is very low. And then you look at what's happening in the cells. So normally the cells should not contain this CEL protein because it's expressed on the acinar cells. But you can see that when you grow these cells together and the acinar cells are expressing the mutant cell protein, the mutant CEL is expressed in the beta cell, and that is shown on the Western blot on the right. So this is really exciting to us. So this is telling us that the beta cells, when they're in close proximity to the acinar cell, the protein from the acinar cell is getting transferred to the beta cell. How can we show it in a different way? We can do it in another experiment where one can look at the amount of mutant protein which is being transferred in the context of the same cell type. But you can take the previous one I showed you, all being cultured in the same dish. So here I'm showing you the acinar cells being grown in a different dish compared to the beta cell. But you're taking the media from this cell and putting it into the beta cells. And we again see the same thing, that the mutant protein is being taken up by the beta cell from the culture media, again shown by Western blotting on the right side, showing the protein uptake. So these two experiments are telling us that the beta cell is receiving this protein, which in normal conditions it will not, as shown on the right side here. How many beta cells are taking up these mutant proteins? So again, Sevim went back to using HEC293 cells, which is a more efficient donor cell in the context of transfection. So instead of acinar cells, she took HEK293 cells, which are another cell type. But we have also done this with acinar cells. And then she did a cytometry to look at the expression of these mutant proteins. And shown here is the untreated cell in the far left compared to the control, which is the blue, and the green, which is the mutant. So you can see that the green is shifted to the right, suggesting that the amount of cell being taken up is much higher. And shown here is quantification, the number of cells which are taking up the mutant protein. Up to 12% of beta cells are taking up the mutant protein compared to the wild type or the empty vector. So this is clear evidence that up to 12% of the beta cells are able to transfer the protein from the cultured media into the cells. What do these proteins do? So she went on to look at immunostaining, and she can show that the mutant protein, which is shown here and stained for in green, the CEL is the carboxyester lipase. This is the wild type protein. So even when it takes up the normal protein, it's very homogeneously distributed. But I need to emphasize that you have only a fraction of these cells that are taking it up. But in the mutant protein, where you have more beta cells, it is expressed as punctate particles in the cells. Now, this is very curious to us, that the mutant cells are forming sort of aggregates inside the cell. She went on to do another experiment where she looked at the agrosome. Agrosomes are these aggregates of aggregates of proteins. Again, you have the controls on the far left, different types of controls, where you can see that the aggregates are homogeneously distributed, whereas the mutant, first of all, is also is punctate, but also in larger number. And that, again, can be quantified on the right. So just to, this is another approach which gives you an example of aggregation of these proteins. On the far left is a control, is a positive control where you're causing misfolding of the protein. So MG132 causes misfolding of the protein, and it also forms aggregates. And you can see on the far right, it's very high. The mutant protein also forms aggregates, very similar to the positive control. So this gave us a clue that the mutant protein is forming some kind of aggregates, probably misfolded protein, which is formed in these cells, and it could be causing beta cell dysfunction. She then went on to do an experiment to show that it is by endocytosis. So using cold treatment, cold is a way by which these these proteins can be internalized by endocytosis. And you can see in the wild type on the far left at 37 degrees or cold, there's not much protein being taken up. But in the mutant case, at 37 degrees, you have a large amount of the protein being taken up. At 4 degrees, it is blocked because endocytosis is inhibited, and that leads to a decrease in the amount of protein. So these data tell us that endocytosis is the process by which the mutant protein is being taken up by the beta cell. And so is it causing any dysfunction? She went on to then do two experiments, which I'll go through very quickly because of the lack of time. One is to show that the protein which is being taken up by the beta cell forms a soluble fraction as well as an insoluble fraction. I won't go into great detail here, but we have approaches to look at weighing the amount of the salt in the gel. We can figure out whether this protein is soluble or insoluble. And you can see that the mutant, but not the wild type, has a large amount of this protein which is insoluble. And this protein, furthermore, is resistant to degradation. So I've shown you that it is endocytosed, it's forming an insoluble fraction, and it's being resistant to degradation. But what is it having an effect on the beta cell biology? So one example is that accumulation of this protein leads to beta cell growth arrest or alterations in apoptosis. The second example also is that because it leads to growth arrest, there's a number of these cell cycle proteins which are blunted, CDK1, CDK2, and so on, which are important for cell cycle progression. And shown on the right is a marker of cell apoptosis or cell death, which is P16. So all these are markers indicating that the cell cycle progression is being altered. I mentioned ER stress in my talk earlier on, and one other effect of these accumulation of this mutant protein is causing endoplasmic reticulum stress because of the increased amount of mutant protein in these beta cells. But I'm sure you're wondering about beta cell secretion. So here is the effect on secretion. When you have this mutant protein being taken up by the beta cell and looking at the insulin secretion, in the controls, you have this nice glucose-stimulated secretion, which is blunted in the mutants. And the insulin content is lower as well, as shown by the stimulation index. I won't go into great detail here, but I'll be happy to answer the questions. But what we have done in this experiment is to take cells which are from the patient's fibroblasts and then derive beta-like cells and acinar-like cells and then transplant them into a mouse, because you can't do this in humans. So you take beta-like cells from the mutant and the beta-like cells from the acinar cells, put them into a mouse, let them live for about 12 weeks, and then see what's happening in the grafts of these beta cells. And just to quickly show you here that the mutant cells, which are containing the mutant protein in the beta cells, have reduced proliferation of these beta cells compared to the wild type. So if you're confused by all this I've told you with a lot of these data, please just look at this cartoon, because this is what I've shown you with all the experimental work. What we did was we took cells, acinar cells, which contain either the wild type mutant or the mutant protein, and we put beta cells alongside these acinar cells, and then we studied the beta cells, and we could show that this mutant protein gets into the beta cell through the culture media. And this mutant CEL protein is forming aggregates inside the beta cell, which leads to ER stress and growth arrest, and therefore beta cell dysfunction. So we think that this is one good example of where one can dissect the mechanism by using advanced stem cell approaches and gene editing approaches as well, to show that there is a transfer of this mutant protein from the acinar to the beta cell, which leads to a defect and causes diabetes. So the next question for us is, how are we going to address this in terms of therapy? But this is an example, this is on unpublished work arguing for the mechanism of action of the defect in patients with MODY8. I just want to mention that this is the last slide, acknowledgement, and the person who did this was Sevim, who is now moving on to an independent career. Very, very ambitious and exciting project, which I was happy to share with. And I think I'll stop there.
Thank you, Dr. Rohit Kulkarni, for an excellent talk. And we move on to we'll come back to you at the end along with Professor Lou Phillipson for questions and discussions. The last talk in this session is by Dr. V. Mohan. Is type 2 diabetes one disease or several diseases lumped together? Dr. Mohan is Chairman and Chief Diabetology at Mohan's Diabetes Specialty Center, Chennai. He is President and Director of Madras Diabetes Research Foundation. The patron of RSS Day recently has been elected that, and is the past president of RSD. Over to Dr. V. Mohan for his talk.
Thank you, Dr. Snapmar. I hope I can share my screen. Is the screen visible?
Yeah.
Yeah. Okay. Good. So after those two brilliant talks, I'm going to come down to something which is very basic and very clinical. This is a question whether type 2 diabetes is one disease or several diseases lumped together. And of course, I must thank this brilliant team arranging this meeting, the ADORE meeting. My good friend Dr. Arvind, Dr. Sanjay Reddy, Bhavna Sosle, Dr. Prasanna Kumar, Krishna Reddy, Krishna Sheshadri, and all others. Congratulations for yet another brilliant meeting. I have no conflict of interest to declare. So the question is, are all people with type 2 diabetes the same? I would submit to you at the beginning itself that type 2 diabetes is what we call as a waste paper basket diagnosis. For every other form of diabetes that you listen to, you just listen to MODY8, a cell CEL type of diabetes, or the MODY1 or the MODY2 or the GCK or the syndromic ones which Lou Philipson presented. They're all definite forms of diabetes, and to some extent type 1 diabetes also fits in there. But when you excluded everything else, endocrine diabetes, chronic pancreatitis, and every other form of genetic diabetes and so on, what you're left with is type 2 diabetes. And so it's a diagnosis by exclusion. If it's not this or that, it must be type 2 diabetes. And therefore, it's not surprising that we've known for many years that type 2 diabetes is quite heterogeneous. So it also varies by BMI, age at onset, response to medication, susceptibility to complications. We just heard from Lou Philipson, somebody having a BMI of 19. We also know that BMI is not even useful for diagnosis of MODY, because we had somebody with MODY with a BMI of 40. So likewise, we have published many years ago BMI 18 and having type 2 diabetes with fairly good C-peptide responding to oral drugs and so on. You can have BMI of 50 also with type 2 diabetes. Age at onset, my youngest type 2 diabetes patient was 7 years old, and we can also have type 2 diabetes setting in after 90 years of age. Response to medications, we all know that. Some respond well, some don't respond well, some develop complications, some don't. Some have side effects to medication, others don't. And of course, susceptibility to complications. I've seen patients who after 2 years come with florid retinopathy, loss of vision, and they're only 18 years old. And by that time, they already developed kidney failure. So obviously, they could not have had more than 18 years because they're only 18 years old. And according to the history, they're only 2 years old. And the other end of the spectrum, we have people who have finished 60 years of diabetes, not all that greatly controlled, and yet don't have any complications of diabetes. So we know that's really not one disease that we're talking about. But this field really took off with this publication by Alquist and colleagues, led by Leif Group from Scandinavia, really path-breaking, because they then identified different subgroups of diabetes based on clinical criteria as well as some genetic studies which were done. So the variables that they used to classify was GAD antibody, presence or absence, age at diagnosis, BMI, HbA1c, and they used two markers, one as a marker of beta cell function, HOMA beta, and the other as a marker of insulin resistance, HOMA insulin resistance. This is replicated in 3 independent cohorts in Scandinavia. And based on this, they came up with these 5 subtypes of diabetes, of which the first one, which they described, was based on GAD antibody positivity. So straight away it tells you that it's not the classic garden variety of type 2 diabetes. You could call it a variant of type 1. You could call it as latent autoimmune diabetes of adults. They called it as severe autoimmune diabetes, or SAID. And therefore, if you have GAD antibody positivity, you have young onset diabetes, low BMI, insulin deficiency being the main feature, most of them needing insulin for treatment, so that's SAID. But they had 4 other varieties which one could actually fit into what we call as type 2 diabetes. One was characterized by severe insulin deficiency being the main feature, very similar to the severe autoimmune diabetes, except that by definition, GAD antibodies were absent. So it's early age at onset, low BMI, insulin deficiency being the main factor, and GAD antibodies being negative. At the other end of the spectrum was the opposite. The severe insulin resistant variety may come at any age, but is characterized by severe obesity, acanthosis nigricans, signs of insulin resistance, and a high BMI, and definitely a much better beta cell function and classic signs of insulin resistance. In between was another type which they called as MOD, or the mild obesity related diabetes. So these are people who might have obesity by, if you use the definition of BMI, but there are no signs of insulin resistance. So this is, in other words, what we used to earlier call as the healthy obesity, or the metabolically healthy obesity. And different names have been given for that. And finally, of course, just based on age, the fact that patients are older and they have milder types of diabetes, the 4th variety was called as MARD, or the mild age-related diabetes. And by definition, these people were getting it much older. Now, when we wanted to look at whether, of course, these were then replicated in many populations. I know that in the United States, they have replicated very similar to this. When people started replicating, what most people did was they left out SAID completely. But they said we're dealing with the different disease. We're talking about type 1, or we're talking about LADA. So we're not much interested in this. We know what that is. We are more interested in the common garden variety. So I must say that in the US, there's one study from China which replicated this. A second study which I've seen recently saying that they were not exactly the same. In a Portuguese population, they found some differences. In a Mexican population, they found very similar to this. Found some differences, but some similarities as well. So to cut a long story short, in many populations, it has been replicated, but in some, they found some differences. Now, we wanted to see whether it replicates in Asian Indian population. Why? Because we know that our type of diabetes, and Lou Philipson has very often referred to this, that the South Asian diabetes seems to be quite different from what has been reported in the West. And these are some of the differences. Much lower age at onset of type 2 diabetes, where you get classical type 2 diabetes occurring in the 30s, 40s, and 50s. We have always seen 10 to 15 years earlier, the diabetes seems to set in our population, type 2 diabetes. We are much thinner when we get diabetes. So the BMI is much lower than what is seen in the West. High insulin levels and insulin resistance, but also on the other hand, a rapid decline in beta cell function, the characteristic dyslipidemia, and many other factors which I'm not going to go into because they've been well described, the so-called South Asian phenotype, or we call it as the Asian Indian phenotype. So with this phenotype being there and the age at onset itself being so much younger, we said, how would our MARD be, for example? How would and we find this rapid decline in beta cell function. So would we find everyone having SID, or would there be other varieties? So as part of this program called as the INSPIRED project, INSPIRED stands for India-Scotland Partnership for Precision Medicine in Diabetes. It's funded by the National Institute of Health Research, NIHR, in the UK, and it's a collaboration with the University of Dundee in Scotland with Colin Palmer, Ewan Pearson, and others, and our group in Chennai. So the first thing that we did was, we did exactly what the Scandinavian group did. We took the same parameters, clinical parameters, used the same K clustering, the same bioinformatics tools, and we said, do the clusters as they exist in Scandinavia exist in Indians. Now what I've circled here on top is a Scandinavian, and everything fits like a T, and therefore the 4 clusters that they have described in type 2 diabetes is very appropriate to the Scandinavian population, no doubt about it. But when we tried to fit that in to our Indian population using the exact tools that Leaf Group and colleagues used, we found that we just could not. We tried several iterations of this, but we found that it was going all over the place. For example, what they found as having low A1C, in the SIRD group, we found as having the second highest A1C. If you look at the age at onset, I mentioned that the MARD is an old age related disease. Their MARD is at 67 years. Our MARD is at 50 years. Whereas look at even their SIRD and the SID is at 56 years. So if you look at the age, there is no correlation at all between what we found. And you can go on and on. The HOMA beta and the HOMA IR did not fit in, and so on and so forth. So after trying this out, we said the Asian Indian phenotype seems to be affecting this clustering, and what they have described may not be exactly possible for us. And there are certain characteristics of the Asian Indian phenotype which they have not taken into account at all. For example, the low HDL is one of the most characteristic features, in my opinion, of the Asian Indian phenotype. That is not considered at all. So we said, okay, if you're going to do this again, let's start with our own idea of clustering. Of course, we took most of the parameters that they used, but we added our own. And this was published in the BMJ Open sometime ago, about a couple of 2 or 3 months ago, as the INSPIRED project. Now, samples for this, we did it in 2 ways. The first cohort was a large sample of over 20,000 patients who came from our electronic records of our own patients. As you know, we have over 500,000 registered patients in our electronic records now across many states of the country. And patients who are attending newly diagnosed patients, as was taken by the Leaf Group analysis, we took the same, the wide range of age group, their typical type 2 diabetes. We had ruled out GAD was negative, they had C-peptide and so on. And then duration of diabetes less than 5 years. So it is fairly representative of India, although some parts of North India were only Delhi to represent North India. But the east of India and South India was very well represented. So what we found was, so we took many of the characteristics which they had described, like age at onset, BMI, waist, HbA1c, and so on, but we added triglycerides and HDL. Now, while we had the HOMA data and the HOMA IR beta and the HOMA IR in the initial analysis, when we started doing it in our population, we used fasting C-peptide and stimulated C-peptide, but this is what we do routinely in our cases. We had more than 120,000 patients in whom we had this data, and therefore we felt we could use this particular data. Now, what we found when we did this analysis using these criteria was that two of the subgroups, that is the severe insulin deficient variety and the mild age-related variety, were very similar to what was found in Scandinavia. However, we found two new types which were described for the first time in this Asian Indian group, and that is the insulin resistant obese diabetic, what we called as IROD. It's different from SIRD, and I won't go into that. In the paper we have described why we called it as IROD, because it's very different from the SIRD reported. But then we found this new one, which is a combined insulin resistant and insulin deficient variety, the CIRDD. They had features of both insulin resistance as well as insulin deficiency. So in summary, we found two of the clusters being the same as in Scandinavia and two of them being novel as far as the South Asians are concerned. Now, when we looked at the results to see whether it fitted in exactly. Just to show you a few, if you look at the MARD, this is the oldest of the four groups. If you look at the body mass index or the waist circumference, lowest in the SID variety, the insulin deficient variety, and highest in the IROD variety. That did not come out like that when we looked at the Scandinavian clusters and used what they did. HbA1c we found was the highest in the SID variety and next in the SIRD variety. Again, if you look at the C-peptide, it fits in exactly. You can see that the lowest C-peptide is in the insulin deficient variety and the highest is in the IROD variety. And even if you use HOMA beta and HOMA IR, we got the same results. So we are fairly confident that this was replicable. We did it 2 to 3 times. The iterations were done again and again, and we got the same clusters over and over again from this large database that we looked at. So having been convinced that this seems to be the cluster which is replicable in our population, we then looked at whether there were any differences between males and females, gender-wise. And we found that this is the data in the males, and here is the data in the females. They're almost identical. So gender did not seem to make any differences as far as this clustering was concerned. We then looked at, okay, what if we had initially used 5 years, so from diagnosis? What if we reduced it to 3 years? What if we reduced it to less than 1 year? The idea being that you need to do this clustering or this classification to subtypes at the time of diagnosis, not after 30, 40 years. What is the use when people have already been treated in different ways? They put on weight after insulin, the clusters have changed, so we must do it. So we made it into less than 5 years, less than 3 years, less than 1 year, and we found that they still remain stable. So we're getting increasingly confident that this was correct. Then we said, okay, this is all from a private center. There could be socioeconomic bias in this. It could represent an upper middle class or a higher income group. If these clusters are really true of India, it must be reproducible in a nationally representative sample covering the whole country. Luckily for us, we have the INDIAB study. The ICMR INDIAB study, as you know, is a representative sample of the whole country, all the 28 states, 2 union territories, and the National Capital Territory of Delhi. We have almost completed the whole INDIAB study. It's taken us 10 years to complete the whole study. It's of course one of the largest epidemiological studies ever done in Asia on diabetes. Now, from this, we use the same criteria. So we used the diabetes at newly diagnosed ones, and the sample size what we got was 2,204 from the published 15 states. We've already published when you're halfway through 15 states, so we use that. Now, when we went to INDIAB, we've tried one more experiment. Not everybody will have C-peptide estimations. So we said, can we take one more risk now, leave out the C-peptide, use age at diagnosis, BMI, waist circumference, HbA1c, triglyceride, and HDL. Now this every clinic, every diabetic clinic would have. So we said we'll keep the C-peptide separately, but now we will look at just these. And then we found that we had the exact same results. We were able to reproduce it exactly in the whole Indian population. Again, if you look at the parameters that I said, the MARD had the highest age, and then the BMI, and so on. One factor I didn't tell you, which I can go back and show you here, is that one of the characteristics things that we found was in the SIRD variety. In the SIRD variety, we found that they had the lowest HDL. HDL is low in all Indians, but the lowest HDL was seen in the SIRD variety, and the highest triglyceride. Look at the triglyceride in the SIRD variety compared to the triglyceride in the other groups. This is the triglyceride 351 in the SIRD variety. So this variety, which we have newly described, seemed to be the most typical of Asian Indians, and that's why probably the other groups didn't pick it up. They have very low HDL and they have very high triglyceride. Let's see what happens when we look at it in the whole India cluster. You can see again the SIRD variety, the lowest HDL. Now the HDLs here are even lower because this represents rural, urban, poorer states, and all of them put together. But again, very strikingly, the triglycerides standing out in the SIRD variety and the low HDL coming out very significant in the SIRD variety. Now we asked the question. So after showing this, we said, okay, there's something called as the Jacquard Similarity Index. And with more than 0.75, it means that the clusters were stable. We got 0.92 or something. So they're extremely stable, and we knew that we had replicated it in India. Now comes the next question. So what's the point in doing all this? What's the clinical relevance of doing? Is it just an academic exercise? We were interested in two things. How easy or difficult is it to treat the diabetes and get it under control? And number two, is there any correlation with the prevalence of complications later on, or the incidence of prevalence of complications in relation to these clusters? Now, what the LEAF group study had shown was that the thin variety, the SID variety, they were more prone to retinopathy, whereas the more insulin resistant obese variety were more prone to diabetic kidney disease or nephropathy. We found the same thing. So as far as retinopathy is concerned, taking MARD as the reference group, a 56% increase in the hazards ratio for retinopathy in the SID group, whereas it was not there in the IROD group. However, one surprise was that they did not have the SIRD variety. In our SIRD variety, retinopathy also came out. Remember that this group also has insulin deficiency. And therefore, the two groups which had insulin deficiency was more prone to retinopathy. As far as nephropathy is concerned, what the Scandinavian study showed was that they are more prone to diabetic kidney disease. Again, we found that the SIRD variety had more, but this is only including microalbuminuria. If you take CKD, which is the real marker of kidney disease, the highest was in, if you look at the MARD variety, the SID did not have an increased propensity to diabetic kidney disease, just like Scandinavia also showed. But if you look at the insulin resistant variety, it was definitely higher, it was statistically significant. So we confirmed the findings of LEAF group and others. But look at this, the SIRD variety, the one we described, has an even higher propensity to develop diabetic kidney disease. So this new entity has dyslipidemia, and they are more prone to both diabetic kidney disease as well as to diabetic eye disease. Now coming to the last part, which is the how easy is it to treat. Now, as one would expect, the most difficult to treat would be the insulin deficient variety. And I remember this in a retrospective study. We didn't know that they had SID earlier, so we didn't start insulin for them earlier. But the blue line here represents the time it took to reach HbA1c of 7, and what percentage of people here reach that HbA1c of 7%. It was lowest in the SID variety. This was also confirmed a LEAF group that is very difficult because we just give them metformin, we treat them in the usual way, and that's the whole point about the study, that unless you treat them differently, you're not going to get them under control. And this kind of comes back to us that when we as clinicians find that they don't respond to some form of treatment, we should ask ourselves what type of diabetes or what type of subtype do they have. The easiest, of course, was the MARD, because they had the mildest diabetes in the first place, and they got under control very easily. Now, very close to the SID variety was the SIRD variety. So you can see that the SIRD variety, since they have insulin deficiency again, they were also very difficult to get under control. So I would now put it to you that in a diabetic clinic, using just 6 simple variables, age at diagnosis, BMI, waist, HbA1c, triglyceride, and HDL, using a formula, one should be able to segregate type 2 diabetes into 4 subtypes. We believe that the treatment would be different. We are currently looking at a very large sample size, multi-center, where we're getting samples from all over the country, and we are trying to replicate it to look at the treatment. And there are some signs which are emerging, which I'll probably be able to present in my next presentation. So to summarize, ladies and gentlemen, for the first time in India and South Asia, clustering was done in individuals with type 2 diabetes using clinically relevant variables. 4 replicable clusters were identified, 2 of which, the severe insulin deficient variety or SID and the mild age-related MARD, were the same as in the Scandinavian cluster. However, 2 were novel and unique to the Asian Indian population: the insulin-resistant obese diabetic IROD and the combined insulin-resistant and deficient diabetes. This novel cluster of CARBD is of particular importance because it's characterized by both insulin deficiency and insulin resistance. It's also characterized by difficult to control hyperglycemia, and there's an increased risk of both kidney disease and retinopathy. And therefore, we believe that this is a most unique form of the Asian Indian, and obviously much more work needs to be done. Our current work in this is to correlate it with various genetic studies. We have done GWAS in a large number, so we're trying to correlate this, and this will probably be published. And then we're also looking at treatments to see how did they respond, which drugs did they respond, how many of them responded to SGLT2s, who are the ones responded to metformin, sulfonylurea, DPP4, insulin, and so on. So I'll stop there and thank once again the whole group for asking me to make this presentation. Thank you.
Thank you, Dr. Mohan, for an excellent presentation. Now, all 3 presentations are open for discussion if there are any questions. I would like to start, Dr. Mohan, you said that type 2 diabetes is something like a waste paper basket with so many heterogeneous groups. If you look, diabetes in the young is also heterogeneous. Even if you take type 1 diabetes, is also heterogeneous, whether it's onset, antibody positivity, progression of the disease, complication. When you start seeing large number of patients, you start wondering that are we putting all type 1 diabetes into one? So I think when you start looking at, like you did, that not believing that every subtype is safe, there are differences, not only from the point of view of the investigation, even complication, as you said, nephropathy, retinopathy. I think it is true in type 1 diabetics also. Initially, we think diabetes is only 2, type 1, type 2. Then we see so many types. Maybe as our knowledge goes on improving and investigation, that you see heterogeneity in every disease, what you see, unless you go deep into that. That may be the reason. Thank you for that.
If I can respond to that,
Yeah, please.
you're absolutely right. That's the beauty of diabetes, endocrinology, biology, medicine in general, that nothing, no 2 cases, our teachers used to teach us that no 2 mitral stenosis is the same. One will have a loud first sound, one will not have a loud first sound, one will have opening snap, one will not have opening snap. So anything you take in medicine is like that. That's the beauty of medicine. That's why you cannot just have, that's why 2 + 2 is never 4 in biology. It can be 4 rarely, but it's usually not 4. But having said that, see, it is still a waste paper basket diagnosis type 2. I'll tell you why. Because in type 2 diabetes, at least you have something. C-peptide is absent. In 1 year, 2 years, they'll burn out completely. So that is characteristic of type 1. Okay. GAD antibodies, if they are present, then okay, a significant number. One of the antibodies, one of the 4 antibodies, at least 90% will be positive. So something. 10% is not. So that's the antigen negative. Of course, in relation to the outcomes, they may differ, but at least you have segregated them based on these principles. MODY3, it's HNF1 alpha mutation. You found even within that there'll be heterogeneity. Some will develop complications, some may not develop complications. That's different. But at least you have a genetic marker. What is the marker that we have for type 2 diabetes? We don't have a marker. So it's not this, not that, not this, therefore it's type 2. Even within the SID and with the SERD, they're only groupings. They don't really mean, when the patient sits in front of you, you'll find that's completely different. They don't even fit into any of these 4. So that's the beauty of biology. But having said that, chronic pancreatitis, if you have a big stone in the pancreas and they're thin, this FCPD, okay, at least you've got a marker for that. That's why when you had other diseases like protein deficient variety and so on, they fell off because we didn't have a marker. We didn't know how to diagnose it. That's the problem with type 2 diabetes.
Correct. I think the same similarity in polycystic ovarian disease. Last 40 years, we are telling polycystic ovarian disease is a waste paper diagnosis because it's a conglomeration of syndromes, it's a conglomeration of signs, and there is no something like one. Is it a pituitary? Is it hypothalamus? Is it ovary? Is it what is it? Nobody knows what is it. And there is nothing like one single treatment to treat PCOD. We end up start treating only the symptoms rather than anything.
If you probably go deep into it, you might find 4 subtypes.
But people have tried 50 years on genetics of PCOD. They wasted their time. Nothing has come out after 50 years of it. Dr. Kulkarni, your talk was very interesting. But you said that the crosstalk between the pancreatic exocrine and endocrine cells, I said beta cells and SNR cells, is it unidirectional or bidirectional? And you see the protein that is secreted by SNR cells goes and then into the beta cell. If you start looking other way around, is there something like we are knowing in endocrinology paracrine function, that when there are two cells adjacent, they talk to each other and maybe the protein is the one. And how does it go? Second thing is, when we see in type 1 diabetics, recently you can measure the volume of beta cell, inanite cell, alpha cells. A lot of them has shown at the beginning of the disease, 30 to 40% of the islet cells, the beta cells are gone, but the alpha cells increase. And what is the relation? Because 30% of type 1 diabetics have exocrine dysfunction, asymptomatic. I'm not talking of symptomatic. So also 40 to 45%, and then a very sensitive test. I'm not talking of 24-hour fecal fat, even alpha trypsin and all has shown 40 to 45%. We also have published 1 or 2 papers to say 40-45% have it. Question is, when you treat the asymptomatic exocrine dysfunction in diabetic, whether it has got effect on the beta cells and what is the relation between the two?
Yeah, great questions, Prasanna. I think this also tells you why we need more research and why we need more people to get involved in research, because there are so many unanswered questions. So going back to your original one, the effect on of the acinar cell and the beta cell, the reason why you have only 2% of the whole pancreas made of endocrine cells is because if you look at evolution, the digestive enzymes reduced it to that minimal level of the endocrine population, which is supposed to be appropriate. So that goes back a long years ago. But there is data that the acinar cells express insulin receptors. So clearly there is an effect of insulin on the acinar cell as well. And in fact, in my own lab, we are doing an experiment where we are removing the insulin receptor from the acinar cells and looking at what happens to exocrine function. And I hope that I'll come back in a year's time to give another talk. But the second, the question that you asked again is important in the context of type 1 diabetes. Individuals with type 1 diabetes or insulin deficient show a reduced volume of the whole pancreas. The entire pancreas now has been measured by multiple groups, including the group at Harvard, Diane Mathis and Jason Gaglia, where patients with type 1 diabetes show up to a 30% decrease in the entire pancreas volume. That could be ascribed in one way to the reduced insulin itself, because as you know, insulin is a growth factor. So when there's a reduced growth factor in the entire organism, it reduces the volume of the whole pancreas. But does it have therapeutic implications? That's a good point you raised finally, that when you treat exocrine dysfunction, what happens to the beta cell? Now that is an important observation to be made much more cleanly. The challenge is you don't look at these functional effects when you do these treatments. For example, you don't measure C-peptide or acute phase insulin response in those individuals who are undergoing exocrine cell dysfunction. So that needs to be done to look at that more carefully. So there are implications. There's a lot of work needs to be done. The exocrine pancreas has completely been neglected in the field. And I think it's coming back slowly now to argue that there is crosstalk, and you really can't neglect the contribution of these two cell types, which teleologically it makes a lot of sense. They're coexisting with each other, and the functional relevance needs to be made.
Dr. Mohan?
So just to respond to that, Rohit. Perhaps the only exception would be diabetes secondary to chronic pancreatitis. I know you have taken a genetic cause of exocrine pancreas and therefore MODY-8 and so on. But another very well studied field is diabetes secondary to chronic pancreatitis, either alcoholic chronic pancreatitis or tropical chronic pancreatitis or other causes. There, of course, there are some, there is in the literature some effect of by giving, pancreatic enzyme replacement, whether the glucose control improves, A1C improves, and stuff like that. So that may be one field where it's quite close to what you're studying.
Dr. Kulkarni, you said that because insulin is a growth hormone, as it reduces in type 1 diabetics, maybe the whole pancreas size comes down. If that is true, it should apply to every organ. The insulin effect is not just on the exocrine. And we know that type 1 diabetes, at least 95% is immunologically mediated. If so, is there any homogeneity where this antibody also cross-reacts with the exocrine function? And is that the reason why 30% of type 1 diabetics over a period of, not that at beginning, also develop exocrine dysfunction? Are we sure that it is so cell-specific autoimmunity, or there are certain things which we do not know is responsible for exocrine dysfunction, especially in type 1? Type 2 is a different ballgame altogether.
Yeah, I mean, those are great questions, Prasanna, and I hope that we can answer these questions with further study. I think the point you made about the specific effect on the exocrine pancreas, the question is open whether other tissues are also showing an effect, and if not, why is it so specific to the exocrine pancreas or the pancreatic volume being reduced? Is it special in some ways? Is there some other signal from the beta cell which argues that once the beta cell is reduced, then the whole organ should reduce as well, independent of the insulin receptor defect? So that is something which needs to be answered in another organism potentially. And but going back to the therapeutics in terms of looking at the effect of exocrine replacements, like Dr. Mohan mentioned, those are all great opportunities to ask and to get more information in an area which is lacking sorely with clinical data as well as research. So I think you bring up very important points, and I hope that one can pursue these in terms of research at multiple levels.
Could I mention that one of the recent papers from our group, the senior author is Manami Hara, who came from Graham Bell's lab. Manami published a paper just this year, started with work in my lab from 10 years ago on the flow of blood through the islet into the acinar pancreas. And that really was astounding. We had done some fluorescent tracking of red blood cells through the islet in live preparations of mice, showing that in fact it isn't like a nephron, it isn't a glomerulus, so it isn't one flow directly through and out, in fact tracks through the acinar pancreas. So Dr. Kumar says that the insulin concentrations in the acinar pancreas could be phenomenal, and so in fact uniquely high from every other organ. So that is something Dr. Kulkarni and other people will be looking at, is a crosstalk back and forth. Now, in terms of other molecules, I think a lot depends on whether they're secreted stuff. So if we think about insulin mutations, which are also potentially secreting damaged proteins, many insulin mutations that cause neonatal diabetes are in fact not secreted. So what you have is loss of insulin, which I might slightly disagree and say that type 1 and type 2 diabetes could be very similar. Dr. Mohan's group of the insulin deficient, insulin resistant individual, which I definitely see in my practice in both Asian and non-Asian individuals, these are the most difficult people to treat. And so in this case, many of my colleagues are giving not only insulin, but SGLT2s cautiously off-label, GLP-1 agonists, and occasionally we've added now thinking about thiazolidinediones to reduce this insulin resistance, which is on top of severe insulin deficiency. Those people may also have a dramatic acinar pancreas defect. So I think we're entering an exciting new area to think about this, again, a potential bidirectional effect, but also in in areas of non-secreted proteins.
Thank you, Lou Phillipson. I think there's one more session where Dr. Arvind is waiting. I would like to thank all the speakers, Professor Lou Phillipson, Professor Kulkarni, Dr. Mohan, and all the participants, and thank you very much. Over to Dr. Arvind.
Thanks very much.
Thank you, Prasanna. Thank you, Dr. Mohan. Thank you, Dr. Lou. Thank you, Rohit. I think the lectures were wonderful. I think we have learned a lot. One quick question to Dr. Lou before I leave him, because our knowledge partners of the Chicago Medicine. Many times when we finally pick up a case of MODY, the question that comes from the patient is, how long can I be on oral hypoglycemic agents? When will you start injecting the insulin? I don't have an answer. Do people ask
unfortunately, yeah, so this is a perfect question. We don't know exactly. So one of the advantages of our group, say over several other groups around the world, is that we do have permission to recontact our group of monogenic patients all over, mostly the United States, but and now we've expanded outside the United States as well. So there is a feeling that in HNF1 alpha MODY3, the sulfonylureas may last indefinitely. We have people who are picked up late and they don't seem to respond completely to the sulfonylureas. And it may be that once the beta cells are damaged over many years, they don't come back. I also have a sense, and I think other people as well, that HNF4 alpha MODY1 does not respond as well to sulfonylureas. And certainly MODY5, HNF1 beta, doesn't respond hardly at all to sulfonylureas. So I think this is an area of very importance. A few of us are thinking about setting up a study to reinvestigate the role of GLP-1 receptor agonists in various forms of MODY and to see whether that could work. There's essentially no information, and Dr. Mohan will speak to this point. There's essentially no information, I don't think, in 1 beta, HNF1 beta, very little in 4 alpha. So this is something that I think an international group to get enough patients to understand how GLP-1 receptor agonists could bypass some of the genetic defects, I think that could be very exciting.
Just one last question, Lou. What about MODY12, ABCC8? Because we see that response beautifully like HNF1 alpha, like MODY3. Do you have a large series? We have quite a lot of cases who respond very well to.
Yeah, so I don't think anyone has a large series. You may have one of the largest in the world because
10 cases is large for MODY.
Yeah, so 10 is a lot, unfortunately. So we have a few, and the problem is some of the late studies in ABCC8 mutations, those people in fact have a mutation such that the beta cells are basically dead. So it's almost like a mutant protein situation, and it's not a signaling problem. So if you have a mild signaling problem that is a little bit like the KCNJ11 people, they will wake up. Those cells will respond beautifully to sulfonylurea. So I think, again, so it's all about having enough ability. It's about money, right? You have to be able to sequence. So I'll just end by saying, by adding my voice to this notion that we have to increase our education and our attractiveness of research careers. If it's only the poor, penniless physician, or I forget what PhD stands for now. We said it was piled higher and deeper in my day, but my son is one of those people who has now finished his MD PhD and looking for residencies, in his case in pediatric hematology. But the issue is he's 30 years old. So we have to figure out how to accelerate the training. You don't always need a PhD to do bench research. And the idea is to combine a clinical acumen with the important scientific problems and to support those people for the next generation of careers. So I just add my voice to that wish.
Thank you.
Thank you. Thank you so very much. I think with that we end, and Lou will not forget to take the family history. That's a promise. Can I have the slide?
Can I say something?
Sundar wants to say something. Yeah.
Yes, please.
Can I say something? No, fascinating. But I still remember in medical school, one of our professors said, he said, "Doctor, you read the textbook. The disease does not read the textbook." So, you know, it is what it is.
That's a good one. Sundar is my classmate, by the way. We studied together.
Wow, that was not known. Okay, can I have the introductory slide of Dr. Sundar Madaliar? The last talk of the day, and that the finale is going to come from Dr. Sundar Madliar, and he'll be talking something new, and it's about herbs, chemicals, and the diets to insulin and beyond. I mean, how the diabetes treatment through the ages have actually evolved, and that's what he's going to be talking. Professor Sundar Madliar is trained in India, UK, and the United States, and is currently the clinical professor of medicine at the University of California in San Diego. He's a board-certified endocrinologist. He is active in seeing patients and teaching, has focused his research on the clinical aspects of diabetes and treatment. He is an investigator in several ongoing landmark studies, including the NIH Diabetes Prevention Program Outcome Study, the NIH DCCT EDLC study, and the NIH GRADE study. Dr. Madliar has published more than 200 original articles in peer-reviewed journals. He's a fantastic speaker, very passionate speaker, very down-to-earth person, and all of you will love to listen to Dr. Sundar Madliar. Dr. Sundar, the virtual stage is all yours.
Okay. Thank you. Can you see my slides and hear me also?
I can hear you, but not the slides. I think you have to share the slides.
Oh, okay. Sorry. Yes, I have to do one more.
Share screen. As you come down next to the chat, there is a green colored share screen with an arrow going upwards. Yes.
It says I cannot share while the other participant is sharing.
No, yeah, now you can.
I am sharing.
I think
now?
you're, yes, yours is on, yes.
Okay. Am I sharing now?
This is you are sharing, but it's presenter's view. You can go to the full screen view.
No. Hang on. 1 second. This is the latest version of PowerPoint, which always.
Yeah, it does that. Yes.
Okay.
Yes. Now it's perfect.
We're good. All right. Thank you, Erwin, for the nice introduction. And all I can say is, wow, what a scientific feast you have organized. And for me to follow in the footsteps of Lou Phillipson, Rohit Kulkarni, and Mohan is going to be very difficult. But I thought, let me take you through the centuries. Today we know, Mohan was talking about Moody 12 and HNF, all these things. But how did we get here? What did we use to treat patients with diabetes? So first, my conflict of interest disclosures. I have 4 objectives. I will review the evolution of diabetes treatments through the centuries, and you'd be surprised to know what we treated it with, right? From, starvation diets. Insulin was a landmark. Then, of course, after that, we had a whole slew of medications. And I think the other major landmark in diabetes was the FDA guidance in 2008. And last but not least, I'll try and, look into the future if I can. So if we look at the textbooks, they say that Arethaeus of Cappadocia around 50 AD was the first person who described, and he actually coined the term diabetes, which actually means siphon, that the water flows through you. Galen, about 100 years later, said the kidney is the root of the problem, and he kind of guessed that. But if you really want to know the first description of diabetes, which I went looking for, and I've shared this slide many times before, and this is a stamp issued by Egypt in 1971 for World Health Organization Day, issued, and this depicts the physician Hesi Ra, 3000 BC. Now this is almost 1,000 years before the Egyptians could build pyramids, and nearly 2,000 years before Tutankhamun. And Hesi Ra was a physician to the pharaoh Djoser in the 3rd dynasty of the First Kingdom. And he wrote something called the Ebers Papyrus. Now, Ebers actually is a German Egyptologist who bought this in the bazaars of Luxor in the 1800s. And this is what he wrote. And this is from one of the original translations. Many chapters. The chapter on the urinary system describes something very much like diabetes with polyuria and all. And he says you can treat it by giving a rectal injection of olive oil, beer, you can anoint the phallus, or you can even give a mixture of fresh milk, beer, green dates, put it all together, combination treatment, and that condition would be resolved. After this, of course, we know Charaka around 300, 400 AD described the concept of prameha and madhumeha, the sweet urine. And of course, I looked into this Charaka Samhita, and this is from the original, papers, and people have translated it. And it's quite fascinating how they described it. Now, they say people suffering from prameha are of two categories. Those who are obese and strong, just like our type 2 diabetes, and those who are emaciated. This looks very much like people with type 1 diabetes. So this is so many thousand years ago, they also figured out what was going on. And look what they said. Those who are in the latter category should be given nourishing therapy. And those who are in the former category and they should be treated with elimination treatment. And what does he say? The oleated patient should be given various recipes described as kalpasana with a view to eliminating the waste both upward and downward. Wow, that was, I think, really fascinating treatment, which was, one second, if I can just, which was postulated so many thousands of years ago. And then over the centuries, what did we have? They were using various chemicals, various herbs, until the 1700s, when John Rollo, he promulgated the meat diet, and he wrote a textbook with 2 cases over there. And then after that, 10 years later, Apollinaire Bouchard is kind of considered the father of diabetology. And what did he say? Well, he resurrected the Rollo treatment, and he was the first to say, individualize your treatment for patients. And he forbade milk because he says it's got carbohydrates. And he told patients, eat as little as possible, masticate very carefully. He said, you need to exercise. You need to check your urine daily to guard against the return of the sugar. And he prescribed, of course, the usual chemicals, sodium bicarbonate, chalk, magnesia, citrate, all of that. And the book is available on Amazon for anybody who wants to buy it. It's in French and it's available. Then we come to the father of medicine, Sir William Osler, 1892, and this is his textbook from then. What did he say? He said, I recommend a dietary prescription of 65% fat, 32% protein, and 3% carbohydrate. And this is a real keto diet, except he said, abstain from all that fruits and garden stuff. So that was quite a thing. And he also said, avoid worry, lead an even, quiet life in an equitable climate, use flannel or silk near the skin, take a cold bath daily and a Turkish bath, and get moderate exercise. But then what did he say? He said, only one drug is really good. Opium stands the test of experience as a remedy which can limit the progress of the disease. And then a few years later, in 1913, we had the 1900s, Frederick Allen, who influenced Elliot Jocelyn a lot. And this is what he wrote in his book. No other carbohydrate should be given other than oats. No meat now. He gave an oat and butter diet. Oh my God, this must have been really kind of diets. But that's all they had. And at that time, they did not know type 1, type 2. That was only Himsworth in 1933 who described insulin-sensitive and insulin-resistant diabetes. Now, Elliot Jocelyn, and his book in 1916. And this was also published in the Canadian Journal. See what he said over there. When I'm asked to see a patient of diabetes, I tell the physician, don't change the diet or omit all the fat till I see the patient. And then when the patient comes, he omits all the fat. After 2 days, the protein is omitted. Then he halves the carbohydrate until 10 grams of carbohydrate are reached. I know yesterday Dr. Prasanna Kumar was talking with Krishna and saying 30 grams, but Jocelyn said 10 grams. And then the patient is sugar-free and then fast. 6 years later, of course, we got the discovery of insulin. And this is one of the original vials from the Connaught laboratories of the University of Toronto. And I looked this up. The original patent was sold from the University of Toronto to Eli Lilly for $2. Then, of course, we had a lot more medications. In the first 73 years, we didn't get much, just insulin, sulfonylurea, and bigonides. And then we had 12 classes of medications, and the latest one in 2013, of course, is the SGLT2 inhibitors. Why do we have so many medications? Because as Dr. DeFranco described, we've got all these defects in all these organs over there. And the good thing, of course, is we have 12 classes of medications to treat all these defects over here. And of course, today we found out in the beta cell, we have the acinar cell, we have the alpha cell, delta cell. Diabetes is complicated because we have insulin, been with us almost 100 years. In 2 years, we celebrate the centenary of insulin. And all of this, and this I submit, and Dr. Mohan and Rohit and all were referring to it, is we saw diabetes as blood sugar. We didn't see the surrounding milieu which corresponded to it. And of course, we went after the blood sugar. Glucose control is good. It's very good. But I'm going the other way, sorry. But the problem is it has effects on microvascular complications, but really no effects on cardiovascular disease. And I was fascinated with Dr. Mohan, all these kinds of, the insulin deficient people are the ones who get retinopathy, and those who are insulin resistant, they get more of the kidney disease and all that. Why is that? What is different with the glucose and then the complications? And it is fascinating me, and I have my own hypothesis, which I'm thinking of updating. But this is another definition of diabetes, going away from hyperglycemia. And Miles Fisher from Glasgow said, diabetes is actually premature cardiovascular death associated with chronic hyperglycemia, blindness, and renal failure. So he also says there's hyperglycemia, blindness, and renal failure, but the crux is premature cardiovascular death. And of course, I think people have criticized the FDA, but I think we should be grateful for them, for their guidance. But their guidance said, because of the rosiglitazone fiasco, the muraglitazar, they said, for the first time, we want you to show for a diabetes treatment, it should not increase cardiovascular risk. They didn't say superiority, they said non-inferiority. And of course, we learned a lot from the CVOTs. We found actually not only are they non-inferior, they are superior for MACE outcomes, non-fatal MI, CV death, and stroke with empagliflozin first and then liraglutide. And then we found there are effects far beyond MACE. And I won't go into where did MACE come from? Who coined the term MACE? It came in 1993, and they coined the term MACE for non-fatal for events which took place when they were doing stenting. It had nothing to do with medications and drugs. It had all to do with when you do a procedure, that's where people get an MI, a stroke, and all that. That's where it came. And for want of a better term, the FDA used MACE. Heart failure was not in the original MACE. And now Deepak Bhatt and his colleagues have described MARE, major adverse renal effects. And then MARS, major adverse renal and cardiovascular outcomes. So the field is really expanding. But I think we all agree now, heart disease and kidney disease are interconnected. And I think in my updated hypothesis, retinopathy is also going to come into this. They all have a common link, in my opinion. And of course, we all know patients with chronic kidney disease, they don't get time to die of their kidney complications. They don't even have time to get onto dialysis. Most of them actually die of heart disease. So the cardiorenal benefits, just to quickly sum it up in the CVOTs, is DPP flows, of course, I will not go into. Their only renal benefits are actually on albuminuria progression, but otherwise nothing more. GLP-1 also only on MACE benefits, no CHF benefits, and albuminuria benefits for renal. But SGLT2 inhibits, they have hard endpoints, MACE, heart failure, and progression to end-stage kidney disease. For me, I know people will disagree with me. Albuminuria progression from 30 to 300 to 600. Many people keep going back and forth. Something like pre-diabetes, diabetes, normal glucose tolerance. Many people keep going back and forth on that. Are there any differences between the SGLT2 and the GLP-1 agonist? Nobody really can do a head-to-head study, but the best data is from a meta-analysis from Zelnicker's group, and they said GLP-1 receptors and SGLT2, they reduce atherosclerotic MACE to a similar degree in patients with established cardiovascular disease. Of course, except in the VERTIS study, but sotagliflozin has these benefits, and SGLT2 inhibitors, of course, market benefits, including etugliflozin inverters and also progression to chronic kidney disease. So in my opinion, I think the GLP-1 receptor agonists, their effects are mainly on the pipe, the atherosclerotic pipe, and that the benefits may be due to improvements in A1C, blood pressure, weight loss. There are GLP-1 receptors on the endothelial cells, lipids, anti-inflammatory effects, and endothelial effects. But SGLT2, more than the pipe, it is on the pump. The heart is a pump. The kidney is a pump. They're all pumps over there, and it has profound effects on them. And actually on heart failure, GLP-1s actually may have detrimental effects. That was seen in the FIGHT study, which was published in JAMA, and the LIFE study. Is it related to heart rate increase? We know if you increase your heart rate, that's not good for heart failure. Not much, maybe 2 to 8 beats per minute. This has really never been studied in detail, but they have profound benefits. And of course, heart failure, as David Bell described it, frequent, forgotten, and often fatal, very poor prognosis with people with heart failure. And SGLT2 inhibitors prevent hospitalization for heart failure and progression to kidney disease as a primary outcome in patients with and without diabetes. This now questions the whole paradigm we have said is diabetes, hyperglycemia, and I know I was listening to Dr. Krishna's talk yesterday. So many pathways, protein kinase C, myoinositol, and all these inflammatory pathways. But when you don't have hyperglycemia, people without diabetes, how does an SGLT2 inhibitor, improve heart failure, improve kidney disease? Of course, we know that this was first seen, the DAPA heart failure study, people who had HEF-REF. Of course, we're waiting for the HEF-PEF studies to come. But DAPA reduces worsening heart failure, CV death 18%. How many drugs do this? Statins did it in 1994 when the 4S study was published. All-cause mortality by 17%, which how many drugs can do that? Yes, the ARNIs and all are coming in, but these are independent of everything else. And of course, progression to diabetes by 32%. The Emperor Reduce study also showed that in people with and without diabetes, these people had a lower ejection fraction, similar CV benefits, but really no CV death benefits. DAPA-CKD, again in patients with the eGFR around 43, independent of diabetes, the composite endpoint reduced heart failure benefit, CV death, all-cause mortality in this very high-risk population. How can a diabetes drug reduce all-cause mortality? I mean, it's done it. Credence study again, but this is patients with diabetes, again, reduced end-stage kidney disease by 32%, MACE and CV death, and sorry, it's very cold over here. I put the heating on. Sorry, my slides are moving in the other direction. But I think the cardiovascular outcome trials have led to a paradigm shift in diabetes management. And what is that paradigm shift? Now, Bruce Neal wrote this editorial in JAMA. He said, SGLT2 inhibitors are actually a novel cardioprotective and now renal protective therapy that also improves glycemia. And he said, they incidentally lower blood glucose. It's a real paradigm shift, at least in my opinion. And they were developed for the treatment of diabetes, but it may be that patients with heart failure, kidney disease have at least as much to gain. What's the future? Well, I know your audience yesterday and today really we have seen so many things. Rohit has given us so many fascinating aspects into transplantation. So just for the heck of it, I went back to a paper by Silvio Nzuchi and Majumdar, published in 2013, 7 years ago. But look at that. SGLT2s were not even approved then. These were new medications. And now, of course, in 7 years, they have changed the way we treat diabetes. There are other drugs over there. FFAR agonists never really came. Dual PPAR agonists never really came. Today, I think the glucokinase activators are coming back, and they have to be specific. There are some specific for the liver, there's some specific for the pancreas, because as we know, and when you look into the, the previous talk, glucokinase is in the liver and in the pancreas. It does two different things. In the liver, it stores the glucose as glycogen. In the pancreas, it makes insulin. So nature has intended all this to happen. And the other thing, and Rohit and all was there, the islet does not have a beta cell. We have forgotten about the alpha cell, the delta cell, the epsilon cell. All of them are working. And I think there are injectables and there are oral antagonists. Unfortunately, the first person who postulated glucagon receptor antagonist therapy, Roger Unger, just passed away this year. He was waiting for a Nobel Prize, which never came. But he's the first person who showed in animals, if you block the glucagon, you cure diabetes in an animal model over there. Is that telling us something? Of course, more questions and answers in my talk, but I just thought I would show you this journey. Improvements in technology for type 1, insulin pumps, CGMS, the artificial pancreas, and Jyoti Dev gave a really great presentation on all this over here. The sensor augmented pump therapy. We're going to get, the pump has got dual things in it. It's got glucagon and insulin in the pump. Islet transplantation, potential cure. And I know Rohit has gone into the pluripotent human stem cells. We in San Diego, this is 3 years now, we did the first studies with ViaCyte. Unfortunately, it hasn't progressed much, but it's still going on. I just picked this paper up last week, fecal transplantation, and this is a new study just published in Gut, fecal microbiota, because they're the things, somebody said, you are what you poop, and fecal provanella goes up, all these things, and I know Dr. Krishnan Seshadri is very much interested in the gut microbiome, and in a randomized study, it really halts progression of type 1. And then, of course, there are all the monoclonal antibodies, teplizumab in patients with high risk for type 1. And just last week, golimumab, all of these are doing, of course, they've got side effects over there. We must not forget, we have to aggressively pursue prevention in type 1 in diet and lifestyle. And I know the previous thing, role of precision medicine. I mean, it's going to come down to that. But I think the more answers we try to get, the more questions come up. And I think we have come a long way in 5,000 years. And I have a slide which says that, and I would be interested to see what Rohit would say. Insulin is a very ancient hormone. Insulin is present in fish. We can track insulin back 600 million years to the telost fish. And tilapia is a telost fish. It's still alive today. The tilapia fish, you take out its pancreas, it gets diabetes. So insulin is very important teleologically. And you would think that a person who gets type 1 and the beta cells are destroyed, that's a major thing. Of course, insulin over the years in all the non-vertebrates has got growth things. And in vertebrates, of course, it's a metabolic thing. But from Hesira, we've come a long way. We came from Charaka, how we described Madhumeha, the sweet urine, the meat diet in 1797. It's kind of coming back with the protein and the keto diet. I think Dr. Nita Deshpande talked about all that. The oat cure with Frederick Allen, the keto diet from Jocelyn, the discovery of insulin. Insulin's still there today, and we are still perfecting the art of insulin. And I know Dr. Prasanna Kumar, I was very impressed yesterday with your talk, and he said, why don't we put a dermal insulin, 500 international units? Fascinating talk over there. And I think the third paradigm after insulin and the FDA guidelines was the SGLT2 inhibitors. And Michaela Diamond, when the drug was first introduced, she said SGLT2 inhibitors for diabetes, turning symptoms into therapy. And of course, Subodh Verma and his colleagues said, do the SGLT2 inhibitors cover it all? The pump, heart failure, the pipe, atherosclerotic kidney disease, the filter kidney disease, diabetes prevention, and of course, I haven't talked much about the SGLT2 inhibitors. I'm just looking, I have to look at my time, how much I'm over. I think I'm just a little over. I'll just finish in a couple of minutes. Last slide. I think the big question we have today is what can explain the cardiorenal benefits of the SGLT2 inhibitors in patients with and without diabetes? How can we explain heart failure, kidney disease, which all this time we thought comes with diabetes, but now it is above and beyond diabetes. And for me, I think the SGLT2 inhibitors also have benefits on retinopathy. And we, of course, published our hypothesis in 2016. We said the benefits are due to fuel metabolism, which is our hypothesis underplays everything. In the beta cell is a high consumer of oxygen. The mitochondria are working overtime in the beta cell to make insulin every single minute. And of course, fuel metabolism is glucose and fat predominantly. Protein comes in, but protein has to be converted into the Krebs cycle through acetyl-CoA. And both of these, and I know Krishna Sheshadri was talking about yesterday about the circuit, how we are getting more nutrition. But in diabetes, we said that ketone bodies are a more efficient fuel, which improve myocardial and renal fuel metabolism. Why are we not using fat and glucose in diabetes? In fact, we use the term starvation amidst plenty. There is plenty of glucose because of insulin resistance. You can't use that glucose. There's plenty of fat, free fatty acids, but fat is a good fuel, but it is energy inefficient and generates a lot of oxidative stress. And when we wrote our paper, within 1 week in Cell, the group from Toronto said, not so soon. Ferranini and Mudaliadi said, this is far too soon. But I think the studies have proved that yes, SGLT2 are coming of age. And I'm going to be updating my hypothesis. Initially, we thought beta-hydroxybutyrate is only a fuel. But now we know profound effects on the NLRP3 inflammation to block inflammation. This is why it reduces, in my opinion, heart failure and kidney. How can people with non-diabetic kidney disease, they have IgA nephropathy, they don't have diabetes, but NLRP3 inflammasome is there and beta-hydroxybutyrate can reduce that. HCAR2 blocks lipolysis, FFAR3 lowers the metabolic rate. This is the big thing, HDACs, histone deacetylators, which are important for epigenetic changes. Sirtuin T1, which is one of the master fuel switches along with AMP kinase, acting to FOXO3, which I know Dr. Sheshadri is very, and all this reduce stress resistance, longevity. So I want to make the point, ketone bodies are not only signaling molecules, suppress oxidative stress and have anti-inflammatory effects. And even those without diabetes can have effects because they don't spill 100 grams, they spill about 40 grams, and that chronic low-grade ketonemia helps with the kidney. I should go quickly through this. People are talking about ketone bodies for COVID disease. And this, I just saw, it was published just yesterday. There is a study for dapagliflozin to prevent, because as people with COVID-19 get a lot of MIs and all that. I just saw this yesterday. I wanted to put it in. Let me finish. I'm sorry I'm going over time. I've used this slide before. Kalidasa in Malavika Agnimitran, he said, do not accept anything as good just because it's old. That's why they've moved on from all these starvation diets. Do not reject anything as useless. SGLT2 inhibitors would have been really rejected initially when everybody said they are going to cause more urine and destroy the kidney. I think this is where we are. The wise weigh the substance. People like Dr. Mohan, Dr. Kulkarni, Dr. Good, all the people they are weighing. And of course, it is the unwise who are led by the opinion of the others. Thank you very much for your opinion. And I'm sorry if I went a little over time, and I will stop my share. Thank you.
Thank you so very much, Dr. Sundamadliya. That was a wonderful journey. Spoken with a lot of passion, and then it was interesting that you started with Turkish bath and opium for treatment of diabetes.
Please don't use that.
I saw that because I also heard a few people saying about we don't mind a Turkish bath and opium for diabetes if it's allowed today. But then you brought us through the ages, and it was kind of memory down the lane. And I still remember when we did the phase 3 trials for all the SGLT3s. And in fact, my hospital did almost all the drugs. And when we would go for this investigators meeting, we would talk among ourselves and say, this is not going to be a great drug. And that was just, as you very rightly said, 2013, 2014. But what a great drug it has proved, and what a great drug it has turned out to be. We still don't know what more is there along the pipeline. The whole world is waiting, but what we have right now looks solid. And I have just one question before we wind up the session. I just want your answers. Whenever there's a trial, whether it's an EMPA-REG or whatever trial, we do see some 30% getting the benefits, remaining 70% not getting the benefits. 18% benefit, 82% not getting the benefit. Well, we are very happy with the benefit that we are getting in that small percentage, 20, 30 or whatever it is, but we are not getting the benefit in the majority of the patients. And we always say, well, there must be a residual risk, and we have to look into this. Your thoughts on that before we close this edition of ADORE 2020?
Oh, absolutely. And actually, I think I would love to see Dr. Prasanna Kumar. He's still switched off his video. If you're there, Dr. Prasanna, because yesterday I listened to the chat between Professor Prasanna Kumar and Krishna, and he talked about, the progression. There is no cut line that, you stop here, you go here. It's a gradual progression. And I think it was Krishna or Prasanna Kumar who said, we have to treat hard, treat early. See, once you keep going down the thing, a person who's, I remember, I won't mention the political leader's name. He said, if he sees a person who's drowning 20 feet away, he throws him a rope 11 feet and said, I'm meeting you more than halfway. The guy's going to die. We have to catch them and rescue them far before the people are drowning. Once a person is drowning and the water is near his nostrils, you're not going to get people.
Dr. Sundar, today, when somebody is drowning, people will not throw a rope, they will take selfies, and then within minutes, they'll get 10,000 dollars. Don't expect anybody to throw a rope or go and rescue.
Fascinating. No, fascinating. And I like you put everything together. Great session. Unfortunately, it was too early for me to attend all your other great sessions.
I also remember SGLT2, 1995. Novo update was in Bangalore. There were 50 delegates. I gave 5 talks. One of them was SGLT2 inhibitor. And I spoke about Florizine, all these studies. At the end, I said, this molecule will never see the light of the day because it is so toxic. And 6 years back, like Arvind, I got a SGLT2 inhibitor clinical trial at Ramaya.
Sir, that was in 2003 before DPP4 inhibitors. And I came back with you with the feasibility, and you told me, Sanjay, let's prove them wrong.
And also that this does not answer the underlying mechanism, whether it is on liver, whether it is on pancreas, whether insulin resistance. How can you use a drug which does not even answer the underlying pathophysiology? We will not do study.
And the first time, the ethical committee in Ramaya threw us out and said, you would come and speak about against pathogenesis of diabetes. We are measuring urine sugar. You're coming and telling us that you're going to do a drug in this, and we got thrown out of the ethics committee.
Exactly.
That was the story. Before DPP-4 inhibitors, actually, canagliflozin was in phase 2 study we got in, but they didn't take off at the time.
No, I have done glucose clamps, beta cell function. I have the data. We published it in 2003, 2004. We were doing mechanistic studies over here and we were the first, I know I'm blowing my own trumpet, to use the remogliflozin in type 1 diabetes. It was a proof of concept study. We did placebo control. We showed how, and we designed the study and I was measuring all the sugars and everything, and it works. But unfortunately at that time, GSK did not want to take it
No.
the Japanese partner.
No. They did that phase 2 study in India, and we were part of it. Dr. Prasanna and we gave 10 patients for a type 2 phase 2A program, and after that, they just tanked the study. And Pfizer also had one more molecule, and they also tanked it.
And actually, they would not let us publish the paper. Anyway, long story.
I think.
Thank you, Dr. Sundar Madliar. Thanks, Prasanna, for being there till the end. And I would like to thank all the people who have worked behind the scenes of ADORE 2020. And I take this opportunity to thank the entire Primer team, the Cure Trust team, and all the volunteers, Ravi, Satish, Syed, Deepa, Rupa, and others who have worked. And well, you need to be there in front of the computers for long hours, and people have done it for 2 days. We have come to the end of another successful ADORE 2020, and I'll hand over the virtual space to Bhavna.
Probably you would like to thank the sponsors and play the
sponsors video once more before we end today. Thank you, Sundar Madliar. Good night, everybody. Just wait for another 1 minute. Sponsors video will come on.
I think I'm unable to start my video because it's being shared by others. They have to give it. Okay, there it goes. So good night, everybody. Thanks for being
there with all of us during the ADORE 2020, and we'll hope to see you next. And before that, definitely during the debate 2021, maybe end February, the entire Primer team will be seeing all of you. Good night. Stay safe. Bye-bye.
Bye.
Thank you.